and the discovery of the BCR-ABL fusion gene. In 2001, the US FDA approved the first precision oncology drug, also known as Gleevec or imatinib, which drastically changed the CML, the mortality of CML, and created it into a chronic disease from a life-threatening disease. So where have we come thus far? So this was a nice assessment that was actually published this year, looking at the different clinical actionability mutations, biomarkers, and drugs that have been approved by the FDA. As you see here in this nice timeline graph, in the late 1990s, Herceptin was approved for HER2-positive breast cancer in 1998. And over the course of the years, you see a staggering number of novel biomarkers and drugs that have been approved by the FDA. Around 198 new oncology drugs have been approved, and about 43% have been basically on precision oncology therapies. And these group of investigators also sequenced about 47,000 tumors, and they found that between 2017 and 2022, the increase in number of standard of care predictive biomarkers of response in tumors increased from 9% to 31%. And tumors carrying non-actionable drivers halved from 44% to 22%. So in other words, we've made great progress in the field of precision oncology. However, we still have the undruggable genes that you see here, TP53, KRAS, CDKN2A. Although KRAS, now you have new drugs that are coming into the clinic that are targeting KRAS. So the currently druggable targets in precision oncology in the last decade, as you all know, have focused on a few major classes of drugs. First of them have been the oncogenic drivers. In green, the receptor tyrosine kinases. These are cell surface receptors, and we know all about HER2 and breast cancer, ALK and EGFR and lung cancer, and we can target those with precision oncology. And then we have the signal transduction pathways in here in yellow. The most well described is the MAP kinase pathway, and we have BRAF inhibitors, MEK inhibitors that can target this overactive pathway. The next class of drugs that we can use actually target genetic vulnerabilities, such as homologous recombination. So homologous recombination is basically tumors that cannot properly repair the DNA, the double-stranded DNA. So they rely on single-stranded DNA repair. And so we have drugs known as PARP inhibitors. PARP is an enzyme involved in single-stranded repair, and we can target PARP, and that could essentially cause synthetic lethal interactions in tumors. The next class of drugs, we have immune system, and this is what we call the checkpoint inhibitors. This has really revolutionized oncology in the last 5 to 10 years. And the concept of this is that tumors can actually evade the immune system and the T cells by using the PD-L1, PD-1 axis. And this is an inhibitory axis, so when the tumor overexpresses PD-L1, it can interact with its ligand with PD-1 on the T cell, and then this causes a negative inhibitory effect on the T cell, so blocking the T cell's effect to kill cancer. And what we have in the clinic are what we call checkpoint inhibitors, which are monoclonal antibodies that can essentially block this axis and unleash the brakes of the immune system, and the T cell can do its job. And finally, we have drugs that target the blood vessels and neoangiogenesis, as you're all aware of, as the VEGF inhibitors. So advances in immunotherapies. Going beyond immune checkpoint inhibitors, we have cellular therapies such as CAR T therapies, T-cell fusion constructs, and I was involved in a phase 1, phase 2 trial, which we published in Nature Medicine, using a TRuC. This is a T-cell receptor fusion construct. It targets mesothelin, which is a cell surface glycoprotein. And what we did is that instead of using CAR T therapy, CAR Ts are called chimeric antigen receptors, and they're actually separate from the T-cell receptor. TRuCs actually incorporate the target, the target here, which is anti-mesothelin, and we incorporate this actually into the native T cell receptor instead of a separate CAR receptor. And this allows a more robust signal to the T cell and more activity. And so we published one of the first trials using this in solid tumors here last year. Similarly, our group in NCI, we also work on immunotoxin therapy. Immunotoxins are composed of antibodies attached to a protein toxin. Usually we use Pseudomonas exotoxin, and the antibody brings the toxin to the cancer cell and kills the cell by a unique mechanism by inhibiting protein synthesis. As you see here, you have the antibody moiety right here, and then you have the Pseudomonas exotoxin here. And that's basically a cytotoxic payload. And we actually published in Science Translational Medicine a combination of immunotoxin therapy with immune checkpoint inhibitors for mesothelioma, and we saw some dramatic responses here as well. So I'll kind of shift gears and talk about what are the major precision oncology trials that have occurred. We have first the IMPACT trial. This was done in MD Anderson in Texas. It was a retrospective non-randomized trial. We have the Moscato trial, the Shiva trial, which was a French trial. It was one of the first prospective randomized trials. And then we have one of the largest trials called the NCI MATCH trial. And I'll go through all these. I'll actually go through just the NCI MATCH trial. But all of these oncology clinical trials used different screening platforms, but they all relied on NGS sequencing. For example, some use hotspot genes, a few hotspot genes. Some use several hundred gene panels, and they essentially matched patients to specific DNA alterations using either monotherapies, combination therapies, or also phase 1 investigational therapies. And you see here the responses kind of vary. You have anywhere from 40% to up to 24%. And so I'll focus on the NCI MATCH trial because it was one of the largest precision oncology trials in history. It was a collaboration between the ECOG-ACRIN group in the US and the NCI. It was launched in 2015 and completed in 2023. It was a genomically driven, what we call a tumor agnostic trial, and also known as a basket trial. And they accrued about 6,000 patients, and they screened for different DNA alterations, and about 1,600 patients were assigned specific therapy. The primary endpoint was objective tumor response, but really the goal was to see if a certain precision oncology drug can work in a genomic subset despite the tumor of origin. So it was a tumor agnostic clinical trial. And briefly, the trial design included 3 phases implemented sequentially. One was a pilot study, and that was about 800 patients. And then they opened it up to accrue up to 6,000 patients, and they also added more treatment arms. And then they had a trial continuation arm, which essentially opened the enrollment to academic centers. In order to be eligible, patients had to be 18 years old. They must have solid tumor, lymphoma, myeloma, have failed at least one prior therapy, and had tumors amenable to tumor biopsy. They initially screened all the tumors using a universal assay, also known as an Oncomine NGS assay. And if patients had an actionable mutation, they were allocated to 1 out of 38 sub-studies. And these were all phase 2 studies that basically paired a specific drug to a genomic alteration. And they found the outcomes of the initial 27 studies here show that about 7 out of 27 arms met the criteria for a positive study. However, the overall response rates was only 10% in the whole study. When they screened about 6,000 patients, 37 had actionable mutations, but only 12% really were registered to treatment. So that was the treatment match rate. So in summary, the NCI MATCH trial turned out to be a very feasible trial. They registered about 6,000 patients in 15 months. The goal was to document response across different cancer histologies. And it was really a lesson for oncologists and researchers that they can develop and implement large precision oncology trials. However, there are some questions that remain regarding, did it really affect cancer mortality? And also, majority of the treatment arms did not have a positive activity, and none of the responses led to durable and major responses, as we saw with Gleevec and imatinib and CML. The overall responses was about 10%. And due to the low matching rates, there was questions about using limited gene panels, lack of drug availability, and it led to additional questions about what other factors may be playing for precision oncology, including tumor heterogeneity, which my colleague from the NCI, Dr. Anish Thomas, will talk about in small cell, acquired resistance, and co-mutations. And so one of the current limitations of precision oncology is that using a single genomic platform, just using DNA sequencing, does not get the whole picture of what's going on in the tumor microenvironment, what's going on at the protein level, what's going on at the RNA expression level. And so really the push is for a panomics type of approach. This includes going beyond the genome, looking at the epigenetics, looking at the machinery that affects gene expression, looking at the protein expression, RNA expression, the metabolomics, and also the surrounding stroma, which is very important because the microenvironment may be promoting the growth of the tumor. And I'll just be talking about the transcriptomics due to the interest of time. And this is probably the easiest way to implement in the clinic. This is basically sequencing the RNA transcripts. And when we do that, we can get a better understanding of the select gene expressions that are going on. We can determine if certain pathways are upregulated or downregulated. We can detect novel or known gene fusions. We can get a better understanding of the protein expression. And also we can learn about the immune status of tumors, whether these are hot tumors and they may be responsive to immune checkpoint inhibitors, or they're cold tumors that they may not be responsive to checkpoint inhibitors. And this was actually implemented in the Winthrop trial. This was the first study to incorporate transcriptional analysis in an international clinical trial of 5 countries. This was prospectively navigated patients to 2 arms. One arm was the DNA-guided arm, which was arm A, and then arm B was the RNA treatment-guided arm. And they had different classes of drugs, including immunotherapy, chemotherapy, hormonal agents. The primary outcome was what we call PFS2. PFS2 is the progression-free survival on the Winthrop trial. So, and comparing that to the progression-free survival prior to the Winthrop trial. So the goal was to see if the Winthrop trial actually prolonged their survival with this genomics platform. They consented about 300 patients, and 35% received treatment. So it had a higher treatment match rate than the NCI match trial. And as you see here, the outcomes in looking at by arm, so arm A was the DNA-directed therapy, arm B was an RNA-directed therapy. We see that the arm B actually had a better clinical benefit from precision oncology. They had more patients with stable disease greater than 6 months, or patients with a response, also known as a partial response or a complete response. And also when they looked at the ratio of PFS2 to PFS1 greater than 1.5, the RNA-directed therapy was much better. And so in interest of time, I'll just skip that. So what are the limitations of precision oncology? Well, we talked about the low match rates, but that can now be supplemented by using RNA sequencing. We have an issue of poor quality of biopsies, and that's important, especially if you want to implement panomics research. And then we have the difficult challenge of targeting clonal evolution and the presence of acquired drivers. As you see here in solid tumors, early on in the stage, you have a single driver mutation. But as the disease advances, you have multiple emerging driver mutations. And as you can imagine, it's harder to target all of these in the advanced setting. And this is similarly the same paradigm in CML. If you see here, the molecular response to imatinib significantly drops with advancing disease. Imatinib is only responsive 10% in the blast crisis. So really the solution is to sequence patients early. I think that's the main message I have is sequence patients early and try to incorporate precision oncology early on in the stage of the disease. If they do have driver mutations, think about combination therapies. And also remember about acquired resistance. Resistance is inevitable with any precision oncology. Tumors will learn how to respond and how to bypass their drugs. So you have to have a method to monitor response, and either using longitudinal tissue biopsies or even liquid biopsies. And this is one example of a patient I treated at the NCI. This is a patient who had EGFR mutated non-small cell lung cancer. He was on one of our trials using osimertinib, which is a third generation TKI. And then our goal was that if a patient developed oligoprogression, in other words, progression at a limited number of sites, up to 5 sites, then we can offer radiation or even surgery and get rid of those resistant clones and allow the continuation of the therapy. So this patient here at baseline, you see here, had an exon 19 deletion, which is an EGFR sensitive mutation. They had multiple pulmonary mets circled here in yellow. The primary mass was this peri-aortic mass. After 2 months being on precision oncology, you see that the pulmonary mets have disappeared and the primary aortic mass has also shrank. But with time, after a few more months, you start noticing the first progression here at the primary site. So we offered a lobectomy for this patient, and when we sequenced the mutation, we determined this patient had a C797S resistant mutation, which is one of the classical mutations that is resistant to osimertinib. So we could essentially take this resistant tumor out, which harbored the resistant clones, and we can allow continuation of osimertinib. And as you see here, the pulmonary mets remained with no active disease, and this patient actually had a very good benefit from continuation of osimertinib in conjunction with doing the lobectomy. And similarly, when we looked at circulating tumor DNA, we can look at the decrease in the circulating tumor DNA in the exon 19 deletion and a resistance. At the time of progression, you see that increase in the mutation copies of this EGFR mutation. And so finally, this is, try to wrap up in 1 minute. The future of precision oncology, we talked about biopsying, doing molecular profiling, looking at genomics, transcriptomics. We looked at treatment options, monitoring resistance and recurrence. And finally, the last slide I'll talk about is functional testing. And I'll end on this slide. And this is using in vitro and in vivo models to guide precision oncology. Today, we have this translational approach, bench to bedside and also bedside to bench. And what we can do is we can create patient-derived xenografts where we take out the tumor in humans, implant them in immunodeficient mice, and we can grow these tumors. And the benefit is that we can retain molecular, genetic, and histopathological features, and we can test for different drug combinations. And at the same time, we can create organoids, where we harvest tumor tissue. We can dissociate the tissue and put them into functional units and enrich stem cells and create these spheroids. And the benefit of doing this is that we can perform high throughput screenings within a short period of time. And this is more clinically relevant and easier to do than doing PDXs because of the advantage of the growth of these cells in culture. So I think I'll end it there. I'd like to thank you all, and I'd like to thank our patients and the Thoracic GI Malignancies branch. Thank you.
Thank you very much. So I have a pleasure to introduce our second distinctive speaker, Professor Muhammad Abdulrahman. Dr. Muhammad Abdulrahman is an associate professor in the Department of Cybersecurity and Forensic Computing, College of Computer and Cyber Science, University of Prince Migrin. Dr. Abdulrahman has received the Best Research Award for the past 3 consecutive years. His research interest is wide, including blockchain, off-chain, solution for medical applications, AI-assisted oncology solutions, as well as security at clouds, just to name a few. So please, he will give us a talk about revolutionizing oncology with technology.
Sorry. Good morning. First, thank you very much for giving this opportunity. I'll be talking about the disruption in technology that is already disrupted, by the way. It's very difficult for me to, convert technologies into some medical domain, but I will try my best so that you can understand what type of disruption is happening. First of all, I will be mostly concentrating about the quality of life of the cancer patients. That really matters, all the effort that is taken place just for the patients so that they have comfort. And then I will be talking about the introduction about some of the key technologies because it's very diverse. And I will be also sharing with you some of our experience in designing some of these technologies locally here in Medina. First challenge is, one of the challenges that is you have very few data points. Once the patient comes to you, only then you get some data. Once he goes for 3 months back in home, all the pains, all the sleepless nights, you don't have any data. So you don't know exactly your treatment plan, how to change the treatment plan. Maybe by the time you see him, his lung is already half of the lung is gone. So the good thing is that the technological innovation, the breakthrough can actually fill the gap. So first I will be talking about a little bit context about PREM and PROM data. That's what I will be talking more about. Assuming that we have the quality of life line, and then we have all the organs are working, and suddenly cancer was detected. So the body function line is basically this one. This red one, so body function. We have all the people that are giving service to the cancer patients. And finally, we have the intervention, whatever you want to apply, and the palliative care. All are different combinations until the patient dies. This is an example how quality of life is dependent on the technology. For example, we started, this is the month. This is the surviving factors. So at first, for example, first 2 months of technology or the treatment is quality of life is 20%, and then we have quality of life 80%, for example, because of the variations. And finally, the quality of life, for example, changes over time. Now, as has been reported that the higher the quality of life, it happens when you have better treatment plan for the patients. Here you can see that the effect of technology in terms of the quality of life. This is the cost, and this is the different types of technologies that are being applied. Oops. Sorry, different technologies, and the cost increases. And here we have, for example, we have 2 patients. This is green is patient 1, whose quality of life, and the other one is, so you see the technological innovations actually brings better quality of life depending on the treatment plan. This is another example that different types of combinations of the therapies actually and how they affect the quality of life. For example, you can see here that all of them increases over time. Same thing, all the physical functioning, role functioning, everything goes down. Now, this is a sample example that how different types of chemo, radio, for example, immunotherapy, targeted therapy, and then you just name it, you combine, and then you can see the variations of the quality of life over time if you start finding out what's going on here. And then, in general, we have studied the quality of life instruments or the measurement techniques, for example. Like in the US, you have ECOG and KPS. We have in Europe, we have QLQC30, and so many different ways technology can give you the exact data that makes oncologists comfortable about the status of the patient. First, I will talk about some of the brief technology about that is really disrupting the oncological domain. Medical IoT domain, where getting medical grade data from the patients of different types, different organs, different type of oncological states that they go through. Also, we can have very quality of life data we can collect from the hospital settings, from ICU as an example. We can also collect, this is one of our implementation that we implemented with different types of medical IoT devices, EEG, EMG, ECG, of different types, kinetic data, kinematic data, pain, different type of data. And you can also use it from the in-home data collection. This is one of the examples how you can keep monitoring of the quality of life data. This is a small implementation that I did myself about, oops, sorry. Oh, no, sorry, it's different. This is a small implementation that we did. How do we do that? Sorry, the video is, it was basically, it can help you, yeah, can you run the video if you don't mind? Yeah. If you want to remotely monitor someone about activity, pain, fall detection, so immediately the algorithms can, or these IoT devices can help you in understanding what's going on with the patient. Thank you. So from the medical IoT devices that are listed down, you can go to the medical data fusion, and finally the quality of life. This mapping can be done for every patient. This is a quick walkthrough about different types of quality of data that you can collect from patients with a very medical grade data that you can trust, basically. Mobility data, then we have the sleeping, because one of the hardest part, if somebody who have gone through that, the sleepless nights of the patients is so painful. So there is no pre-and-prom data available from the patients that what kind of comorbidity is basically affecting the patient. And what's more, you can even fine-tune, fine-grain every activity that is being, every quality of life activity that is, you can break it down using IoT devices, using technology together, that exactly how he's being treated. This is a small setup. This is our own setup that we did. We actually made a home for the cancer patients, and we were observing different quality of life data of different types, including the EEG devices and other devices, and physiotherapy, other type of therapy data. How the muscles are, how the treatment is basically, how the drugs are being received by the body. These are all different technologies, our own homegrown technology. It's available. If you want, we can share with you. Remotely monitor, you can. Again, this is an use of augmented reality for some of the oncological, and we use different type of games for different type of therapies, so that, because it's very painful for them, they don't want to do it. So unless there is a motivation to do it. The next type of technology is the digital twin. Many of you were using mice to apply, but now you have the amazing digital twin that you can basically. So what happens is that you take your physical, physiological data, and then you create a digital copy from genetic, laboratory data, imaging studios, and biomedical signals, behavioral data, social data, and you can make a digital twin of your patients, and you can use it for the diagnosis, for the prognosis, therapy, optimization. So it starts with initial data collection, then you do the integration and analysis, do the simulation and prediction in the digital world, and then you apply your treatment plan on the actual patient. Again, you can have different copies of digital twin of a patient for drug, for DNA, for different types of tests, and then you can apply your theory on the digital twin. This is an example of a different set of digital twins, and then we have a set of treatments that you want to apply, you want to try, and finally you choose which one is the best that is for the patient, and you give the therapy based on the patient's exact physiological need. Now, one of the hardest part, I hope inshallah I will be able to transfer the knowledge to you. I really wanted you to focus in this particular, that this is real, in the last 8 years, this level of disruption has never happened. That happened just 1 year. I just wanted to show you how technology is shaping the world, and how it's really, and we have tested it local here in Medina, all these technologies I will show you. But I really wanted you, as a medical doctor, MD, oncologist, to at least understand what level of technology can help you in supporting this very vulnerable segment. So first thing is the understanding, a little bit high level, is the discriminative AI, which is combination of machine learning and deep learning models. And then our new baby, I would say, which is the generative AI. That's one of our dreams in the past, but now it's true, which is a combination of natural language processing, the way the doctors interact with the AI, and then we have the computer vision and this deep learning combined together called generative AI. This is, say for example, you can create different discriminative AI model. First, I will talk about discriminative AI. You can create, for example, a model that can summarize your EHR summarization. Oops. For example, EHR summarization, cancer stage suggestion, oncology patient conversation for medical notes, systemic diseases or other comorbidity type of data, and then tumor classification. So you can train the AI algorithm. Almost every branch of the medical system has their own kind of very precise, very trustworthy data about the machine and deep learning. One quick example, how much it has evolved. For example, the medical data, many of them are 3D or 4D, 4-dimension, right? For example, cancer, once the cells grow, you need a 3D perspective that how over time, how it is growing. So there is a 3D CNN, 3D deep learning model. What does it do? For example, because we wanted to see how the cells are being basically growing, and then it will allow this 3D algorithm to observe in 3D space of the progression of the cancer. So for example, we have tested with, thanks to many of the Johns Hopkins is one of the, for example, they are, providing samples, thousands and thousands of samples that we are using as a researcher, and many other European countries like King's College. So many of them are basically supporting us with the 3D and 4D volumes of different types of cancers. I'll show just one example that how 4D volumes help in tumor growth, metastasis, and treatment response over time. This is my own implementation where this is 3D CNN was applied. Can you run the video if you don't mind? Can you run the video just? Oh, thank you. You can see here that the 3D CNN, or this discriminative AI will detect the cancerous cell in 3D space, basically. Here you go. So it really helps the oncologist to just figure out. Oh. Okay, now this slide I will spend just 1 minute time just to give you the biggest shock of your life. See, this is how the generative AI and this neural network actually has grown over time. We call it generative AI. Just remember the term, why it is so much of the hype. So imagine that you have 14 years of school that you learn the basics. Then you go to medical school that you learn for 5 years, 7 years, 8 years. You learn so many tricks, books, journals, you do, right? And finally, you keep working for 10 years, 15 years, and this 20 years of journey, it took you 20 years, right, to learn. Now, we can have the generative AI model that can, say, for example, learn this 14 years of your schooling time in just 2 days or 3 days. We can just throw you all the knowledge and it will be ready to, and then you can assume that this AI model has learned all the books, all the content, how to interpret, getting the key concept from there. And then your foundational layer also again can be trained. Give 20,000 medical archive books of all the treatment plans, all the things that you have been talking. It's out of my brain, but I can't understand. But my technology can actually grab it in just 20 days of all these things. And finally, you are working, same thing with this language model can help you doing the same thing. You are talking a very professional way, and these medical notes can be understood very well by this new generation of technology. So now you have a powerful AI and oncologists working together to serve the humanity. Think about how powerful. So the whole journey on the right side took you only 20 days, 1 month, 1.5 months that you took. So that it's not a replacement, but it's give the real task to the machine learning languages. This is a very true kind of theory where this AI can be useful. Think about medical IoT devices, continuous or time interval that you keep collecting. And then you can deploy this AI model within a robot that has this generative AI and this discriminative AI. And now your patients can talk to them in real life language. And they will understand because they have been trained with your knowledge, basically. Let's go back quickly into see the quality of this discriminative AI. And this is one of the Nature journal. And they're kind of catching up with both models in terms of the deep learning models and the generative AI models. It's quite fascinating. Another very important piece of technology is explainability, because oncologists, they will never accept a technology if it is not convincing to them, right? That's why a branch of the technology, which is called explainable AI, that is helping. For one of the famous technology that is from the Meta, called Medical SAM. You can explore it later. This is really amazing. Just throw them thousands of CT volumes, and it will auto-annotate your tumors. It's really amazing technology. Privacy and security. Most of the hospitals are attacked just because of this weakness of understanding. Medical doctors, sometimes they don't go into security domain. So I just wanted to just warn you that attackers have AI capability, bad attackers. They use AI to attack this AI algorithm. So just watch out. Technology have to be safe and secure. This is a sample example for you to understand. For example, there was an AI algorithm, and then it says, yeah, with 98% confidence, it's cancerous. But then there was an attack, and the attack actually made this algorithm to fool it to tell that this is actually benign. But then we need a defense mechanism that will algorithm will heal itself, understand that there is an attack going on. This is some of the core security things. Blockchain for oncology, I will not go into details. This can be very beneficial for radiotherapy and then patient secrecy, data secrecy, finding the treatment plans. It's an exciting technology. This is one of the technologies which is called, if, for example, King Faisal Special Hospital, they don't want to share the private hospital data with another ministry. So you can create your own generative AI model locally with your data without actually sharing with outsider. And then two hospitals, they can still communicate. Johns Hopkins can communicate with King Faisal Special Hospital without sharing Saudi data with the US data. So they don't go into violation of the NDMO, violation of the Ministry of Health or any other kind of. So they're fascinating technology that you can work together remotely. Finally, you can combine in hospital and in-home settings all the available technologies there, and then you can also add your ethical approval, IRBs, anything that you want. So you can apply these with your, so they can convince the oncologists. Finally, you can convince the authority or regulatory body with the privacy and security. These are different technologies. I will not go into details. Finally, the technical convergence. This is happening, which is, for example, you take the cancer patient PREM-PROM data, EHR data, EHR, EMR data, and then you can use it for the detection and the diagnosis. So human and Gen AI can work together to support the patients. In the clinical judgment and interpretation, you can trust the generative AI. It can be hallucination-free. It can be trained exactly on the corpus, on the journals that you want it to learn, and you want it to use it once you want support from it. Observation, treatment, administration, continuous monitoring, in all phases, you can work with AI, with the new generation of technologies, with accuracy. So for example, leave all the painful things to the medical, to this AI, and for example, EHR data pull up, reading the different medical conversations, medical notes, follow-up procedures, treatment plan, handwritten, throw everything to this, and then you just take care of the decision-making itself. So every visit happens, then all these lot of data are being generated, so throw it with the high accuracy to these technologies.
1 minute.
Sure. This is the last part where our journey. For example, we are able to take different multimodality of the data from different domain and then create one very large multimodal model that can understand EHR summarization, comorbidity, and other type of activities. This is what I will spend just 1 minute time here. For example, we are able to work with 12 different data sources. I think all of you are working with different type of sources in different cases. Medical diagnosis, medical notes, treatment plan, EHR, medical knowledge, prescription, follow-up procedures. So we are using these sources to train the AI algorithm. 12 modalities you can see here. I think you will find almost all of you the data that you're dealing with, that we are able to take this data from clinical settings, from hospital settings, and we can create our training architecture, training model, and we create a large oncological multimodal model that will understand, you can use it once it is trained for in-home healthcare, for in-hospital, for hospital process automation, medical diagnosis. Last slide. So now once your model is ready, so you can, it is hallucination free, it is secure, it is safe, and it will go through clinical trials, that what kind of data. And the good thing is that in March 9th, this will be inaugurated hopefully by the Minister of Telecommunication in Riyadh. So basically, now you are ready to communicate, talk to your this AI can automatically work with the human doctors in different parts, and you can ask for evidence. You can have your own natural language, that where is the tumor, why do you think? So it can go and pull a lot of time series data, a lot of other type of lab data, with all the evidence can be pulled because of the training process, how much technological advancement has happened. So this is a very fascinating, I would say, disruption that is happening. I would say that this is the takeaway message. First of all, the current technology allows continuous pre-and data monitoring, both in-home and in hospitals. So you can see last 3 months how your drug affected, what is the quality of life. If quality of life changes in 1 month, some of the organ fail, bring him, because you have continuous data, and change your treatment plan. The pace is astronomical. The pace of technological changes is too much. Leave this to us. You have peace of mind as a medical doctor. Leave the technology on the technology provider. But we can work together to make it secure, to make it safe. And finally, this technology needs to be custom tailored, custom made for every hospital. There's nothing called one technology fits all of you. So I think we at Medina, we should be standing on our own by building the technologies, and thanks to the organizer, King Faisal Specialist Hospital. I think they have all the right tools, resources, technologies, mechanisms, everything is there. It's just a matter of nice collaboration with so many world leaders that are here. Thank you very much for this opportunity. Thank you very much.
Thank you very much, Professor Abdurrahman, for this wonderful and inspiring talk. We will leave the question to the end for the sake of time.
Assalamu alaikum. So our third talk today will be presented by Professor Ghulam Mufti. It's actually my pleasure to introduce him. He's a professor of hemato-oncology and the head of hemato-oncology medicine department at King's College London. Professor Mufti actually has a special interest in myelodysplastic syndromes and acute myeloid leukemia and stem cell transplantation. His work has helped to transform the detection and treatment, leading to improvements in diagnosis, treatment, and life expectancy of people with leukemia. He was actually awarded a prestigious award, the Order of British Empire, in 2017 for his services and significant research achievements that included focusing on molecular aberrations in MDS and AML, identifying novel therapies, and also publishing over 450 papers and chapters in scientific journal. Dr. Ghulam Mufti will be talking today about a vision to the future. Professor Mufti, the podium is yours.
Assalamu alaikum, everyone, and good morning. It's a wonderful thing to be in this pious city. I'm extremely grateful to Amal for organizing this meeting, and also extremely grateful for the program that she has put together. The topic she has given me is a vision for the future, and this is impossible to predict. Having listened to two extremely wonderful talks on the pace of medicine and how medicine is changing so rapidly and has changed rapidly during my lifetime. I remember when I was a medical student in Kashmir, which is where I come from originally, in order to get a BMJ in the library, you would invariably go to the librarian and say, could I have the BMJ? And he or she, usually he, would say, yes, you will get it in 4 months' time, because it will take 2 months for the BMJ to arrive from Tavistock Square in London to come to Medical College in Srinagar, and then it will be passed on to all the faculty in the medical college, and by the time you got that BMJ, it was 4 times the original size. It was black in color because everybody had seen it and turned the pages of it. And also, some of the pages would be missing. And then I came to Oxford. And in the early days in Oxford, you would go to a very stern librarian, and she would look at you and you would say, could I see New England Journal of Medicine? And she would say yes. And she would have a book on her left-hand side, and you would write your name on it. And your name would come up, because there will be 40 or 50 names ahead of you, and you will get the journal, and then your turn comes. And that would be usually about a month after you had written your name. And that was the case. And now you listen to the 2 presentations that have been given. One excellent presentation at the beginning on how genetics and precision medicine is becoming a reality and has become a reality. And secondly, the generative AI, that how that is also influencing all aspects of medicine. Therefore, it is very easy to see the title of my talk, that you can only have future clinical care when you have interdisciplinary collaborations. And this is particularly true in this country, where the population is limited, and it is essential that collaborations take place. What I thought I will do in the next 15, 20 minutes is to give you some examples of why I think these collaborations are essential if you are to succeed in making a name for yourselves in an international arena where the pace of research is, and the competition in research is increasing very significantly. Could I have the next slide? Does it work? So the first slide is basically to say, yeah, the first one. Okay, yeah. So clearly knowledge is power, knowledge shared is multiplied, and science knows no boundaries, and that's kind of obvious for all to see. But the second lecture also is showing that technology is sometimes disruptive, but technology has a very important and propelling effect in all aspects of medicine that we prescribe now. It is hoped that the combination of advances in technology and understanding of the diseases will improve the access, affordability, quality of care, and choice in healthcare. Now, if you look at the other thing that technology has done and understanding in medicine has done, it is that it has, at one level, simplified medicine in a way, because what has become clear is that there's old boundaries of this is hematology, this is oncology, or this is immunology or genetics. Those boundaries are slowly disappearing. The reason for that is, as time has gone on, we have learned that there are certain hallmarks of cancer or malignancies and certain enablers for these malignancies. So this particular slide I've taken, this started, Hanahan did this in 2000, and then after a period of time, they're kind of reviewing it. What you can see is that there are certain hallmarks of cancer, and they're true of hematological malignancies as they are true also of solid tumors. What you can see, So what you can see here, that from sustained proliferative signaling to avoiding growth and avoiding immune destruction. And that's become important only in the last 2 decades in particular, and only in the last decade in terms of treatment interventions, and I'll focus quite a bit on it. And enabling replicative immortality, tumor-promoting inflammation, again has become important in the last decade or so, activating invasion and metastases, inducing or accessing vasculature and genomic instability with resistance to death and deregulation of cellular metabolisms. To it recently have been added those emerging hallmarks of cancer, which are unlocking the phenotypic plasticity of cancer and the role of senescent cells, and enablers are non-mutational epigenetic reprogramming with polymorphic microbes and the role of microbes in generation of responses to treatment as well as generation of the diseases. So if you look at these characteristics of cancer cells, whether they are hematological or non-hematological, you can see by interfering in various points within these steps, you can make a significant difference in the survival or otherwise of the cancer cells. Now, perhaps the best example is hematological malignancy, not because I'm a hematologist, but because hematology has been leading the way. The reason for that is that it's been relatively easy to collect the diseased material. And this was perhaps one of the first examples when acute myeloid leukemia was, the genotype of acute myeloid leukemia and various subtypes of acute myeloid leukemia were fully characterized. So you could see that there are mutations in various pathways going from tumor suppressor genes to activating signaling and myeloid transcription factors and so on. So a relatively small number of mutations in genome and epigenome led to the phenotype of acute myeloid leukemia. Not only that, as time has gone on, what has become clear is that examples, Azim showed examples of the microenvironment and the role microenvironment in the immune system is playing in the genesis of malignancies, and how interrupting those leads to cessation of progression or even responses. But what has also happened with technological developments have been that genomics has now expanded extraordinarily. So in single-cell technologies, single-cell sequencing can now integrate all aspects of the genome as well as the proteome and transcriptome in a single cell. So you can get this vast amount of information from a single patient, from a single blood sample or a bone marrow sample or a biopsy, be it a liquid biopsy or a solid biopsy. The question, though, is that if you get this, as well as with the help of CyTOF and technologies like that, you can get the, if you like, immunological profile of an individual, you can get the genetic profile of an individual, you can get the genetic profile at a single cell level. The question then is, how do you put it all together? And how easy is it to put it all together? Well, in institutions like NCI or King's College or other institutions, it may be relatively easy. That's because you have experts that are able to make sense of all this data that is coming through. I mean, just to look at the simple thing, to give you a report, a final report on whether a person has got a mutation or not, whether that is panel sequencing or exome or whole genome sequencing, you have to go through a whole load of steps in order to arrive at that point, final point of knowing what the relevant mutation is and whether or not it's a driver or a passenger mutation, and when you have got that mutation, whether or not that mutation should be the mutation that should be the target of drug delivery. So it's not easy. You have to have a grasp of all these algorithms which are necessary in order to interpret the data. The other thing that's happened is that the pace of research, partly because of the technology, but also partly because of the ease with which the technology can be applied, has increased quite rapidly. Best example in my own field is that CAR T cells, there are now 6 products that are available for both 2 for myeloma, 4 for diffuse large B-cell lymphoma of different types. You would have thought this is a complex technology. So you're taking a cell, you're putting a gene into it, you're returning it to the patient gets CRS or ICANN or whatever. But amazing thing is that in a relatively short period of time, despite the cost, despite the complexity, 27,000 doses, according to recent New England Journal of Medicine, have been given worldwide of these CAR T cells. So although the pace of technology was brisk, but its application has been enormous because response rates have been very good. At least 40% of patients who would otherwise have died are free of their disease as a result of this kind of treatment that has become available, which was not available previously. And not only that, the pace of technology has meant that we can now begin to attack those areas that were dark areas in the days gone by. And that is the microenvironment. For example, if you look at the new CAR constructs, many of them are armored CARs now with either cytokines or chemokines and monoclonal antibodies and various peptides, and I'll show you some examples of that. Not only that, but also techniques that are available in genetics that have been applied now in CAR T technology, like CRISPR-Cas base editing and prime editing, has meant that there is a new kind of drug development that is taking place. And in a country like this, it is essential that if you are to be competing in these kinds of areas, that you have to have the expertise, that is genetic expertise, immunological expertise, obviously hematological expertise in this instance, in order to bring it all together and to constitute the treatment, to institute the treatment. Now, I think this might have run out of battery, or I haven't, but the pointer has. So could I have the next slide, please? Because I don't think the pointer is working. So I think the other thing is, it's a kind of a lesson also that, okay, the technology has advanced. You give the treatment, and this is probably one of the few occasions when Nature has published a case report. But there's an important lesson in it, and this is why I'm showing this. What you can see here is this was somebody who had CLL, B-cell CLL, who was treated with CAR-19. But he didn't have a response immediately because you couldn't detect the CAR T cells immediately. But if you look at these three pictures at the bottom, you can see over a period of time, when you come to 2 months post-infusion, the red dot there indicates that the patient's CAR T cells you could find, whereas you couldn't find those CAR T cells previously. What you can also see at the top is that if you do the TCR rearrangement, this particular patient at the beginning had a TCR B-beta-5 rearrangement. So that means there was a clone of cells that had B-beta-5 rearranged. And you can see 2 months post, that red area on the circle increases. So the number of cells which are B-beta-5.1 positive have increased to the extent that by the end, that almost all the cells that were sequenced in this instance were B-beta-5. So in other words, in this patient, there was a clone of cells that expanded and expanded almost to 100%, and this patient was in, by the way, he became in complete remission. What is interesting, though, is that it became clear that the lentiviral vector CAR-19, that it got inserted into that gene, TET2 gene. And those of you who do myeloid malignancies or do clonal hematopoiesis of indeterminate significance will know that TET2 gene is one of the common genes that's mutated as we get older and gives rise to clonal hematopoiesis. So this insertional deactivation took place as a result of lentiviral vector going into the TET2 gene, and that gave the clone a growth advantage, and therefore it stayed on. Now, it's become clear now from the work that's been done at UPenn that something like 40% of patients have a TET2 lentiviral vector going into the TET2 gene, leading to insertional deactivation. The reason why it is important is this kind of observation shows that can we now use TET2 mutations specifically transfect those cells that have the TET2 mutation so that you can assure the longevity of your CAR T. Against that is the fact that there are at least, according to, again, recent New England Journal of Medicine, 22 cases of T-cell malignancies that have been reported, probably directly as a result of lentiviral integration into the T-cell receptor sites. So extending it forward, again, applying the technology and the thinking around it, it is going to be possible, as UPenn and some others are also developing a CAR that can be available and effective in all hematological malignancies. ABC, according to UPenn, stands for all blood CARs, and you will hear more in the CAR T session. What has also become clear, for a variety of reasons, time doesn't get me allowed to go into detail, that when you have an IL-18 secreting CAR, that it is effective in refractory resistant diffuse large B-cell lymphoma, even those patients who have relapsed after a CAR T treatment, and B, it is also called a mini CAR because the number of cells that you need to give to the patient is much less than is the case with what we do at the present moment. So I think the knowledge, therefore, has increased dramatically, and that's one example of pace of research. Another example of pace of research was like the dark DNA. This was the dark area. What is the microenvironment? How does microenvironment interact with a cancer cell? And what is the role of individual cells within the microenvironment? Not only the immune cells, but also cells like fibroblasts and phagocyte macrophages and so on. And all of that is coming into the scrutiny as a result of technological advances. And some of this is paying dividend. One example of this is a recent paper on IL-10 CAR, and if the pointer were working, you would see that in this IL-10 CAR in a solid tumor, this is a breast cancer HER2 mutated cell line. in the mice, and you can see the last panel here, the last 5 mice, as well as the plots on the side that IL-10 secreting CAR ones have both a longevity as well as the size of the tumor is extremely low, indicating, therefore, if you can manipulate the microenvironment, that there are advantages to be had in terms of the effects of that. And this I won't talk about in detail. My brother-in-law is Rafat Hassan, and his paper was quoted by Azim just now. But there are other areas where there are solid tumors trials ongoing. The other reason for saying that these demarcations between disciplines are disappearing, this is an example. This appeared as a case report from this German oncologist of using anti-CD19 CAR in systemic lupus erythematosus. You can see amazing responses in this particular patient. Double-stranded DNA disappeared, C3, C4 in complement components increased, and even the renal function, which was abnormal in this patient, that kind of improved as well. This was followed by a Nature paper where there were 5 patients that were treated in a similar kind of way with similarly excellent responses. What is interesting about it is that unlike hematological malignancies, after 3 months, the B-cell function appears to return, but the disease doesn't appear to return. This has led to at least 14 clinical trials that are ongoing, which are using both CD19 as well as BCMA to treat autoimmune diseases. And similarly, in cardiomyopathies as well, there are clinical trials of CAR-Ts of various sorts that are ongoing. So all these, what we had, this is a hematologist, this is immunology, this is cardiology, those are slowly kind of not completely disappearing, but the boundaries are certainly becoming blurred. And hematology and vector development and understanding the immunology, understanding the implications of what you do are extremely important. But this can't be done by one small teams. This has got to have appropriate technology. Is expensive. It's very difficult to have maintenance contracts for these. I've seen equipments here in institutions which have hardly been used. That can't be right, particularly when the instruments cost about $1 million. They need maintenance. They need updating. Clearly, you need appropriate skilled manpower in order to get these diverse technologies together, diverse areas of medicine that are coming together. And also, what was elegantly demonstrated by the second talk is that you need to have this expertise in bioinformatics and artificial intelligence and all the statistics and everything else that goes with modern AI-type bioinformatics platforms. And also mechanisms where people don't silo themselves, that clinician is a clinician, I do only clinic, and lab is a lab, and there has got to be an interface between the clinical and the laboratory. And unless and until all these steps are in place, there cannot be research that can be internationally competitive at the present moment. And even going forward, it will become probably even more so. And also, it's necessary that once you have identified through your technology what the problem may be, then as was shown, that as we go on, the biological significance of what you find is becoming relatively easier now to do. The big question, though, is, and this is a question for everybody, is that there is no doubt that cancer trials have increased tremendously. It's only partly because of huge expansion of clinical trials in China. But the question that you have to ask yourselves is, how many trials do we have where we are phase 1 centers in these clinical trials? How many trials do we have for phase 3, phase 4 clinical trials where we are participating in a new drug for a phase 3, phase 4 trial. I think that can only happen when you create a critical mass. And you can only create a critical mass by collaborations between centers, by collaborations between disciplines. And the other thing is the cost is increasing so much, and it applies to almost every country. In my own country, National Health Service is on the screen almost every day, partly because cancer care is expensive. For example, the United States probably spends something like $3.5 to $4 trillion on health services. The question is, and $270 billion of it are on anti-cancer drugs. The question is, can we continue to have this kind of huge expansion and a huge expenditure as well? And how do we make sure we make the best of every dollar that we spend, that it goes into focused research, collaborative research, and research that has got an end point with a clinical point as well. Then in this country, which is what I was asked to do, is a vision for this country, is that you have to take population characteristics into consideration and what are the health needs of the people. For example, if you look at the, I don't know, this may be out of date, but this is the most up-to-date result I could find from internet, that you have total number of deaths that occur due to cancer are around 13,000 plus, and total number of cases of cancer about 27,000, and they're distributed as shown in the pie diagram. Interestingly, though, going through this, when you actually divide these 27,000 plus cases into different parts of the country, you can see central, eastern, Medina, southern, and western regions, that the country almost divides itself into 5 supra-regional centers where you could have the kind of research, kind of translational research and clinical trials, infrastructure, etc., that I was talking about, with all the facilities in these centers. But given the population size and the population age as well, because median age of the population here is in mid-30s, whereas median age of the population in Western countries in the United States is around 65 or 70. Therefore, the distribution of diseases is a bit different as well. And the numbers of cases that you see are different as well. So if you look at United Kingdom, blood cancers, leukemias, diffuse large B-cell lymphomas, etc., the number for, say, acute myeloid leukemia is about 3,000, and altogether we see about 41,000 cases. And you look at United States, in terms of lymphoma, myeloma, leukemia, hematological malignancies, about 184,000. But when you look at Kingdom of Saudi Arabia, because of the population size, the number is less. Distribution is different. One example of distribution being different is that if you look at the thyroid cancers, both in males and females, are pretty common. As compared to the incidence of thyroid cancers in the Western world. And then breast cancer, particular types of breast cancer, which is outside my field, and particular types of hematological malignancies, which I know about and which we are doing some work on. They're also different. So population size, population mix needs to be taken into consideration. Because look at acute myeloid leukemia. Acute myeloid leukemia, these are all the cases of acute myeloid leukemia that were seen in 1 year, that were registered in 2016. It's out of date. But it conveys the message, which is the total number of cases that you see is relatively low. So if you are going to do any meaningful clinical trials, then that number has got to be kept in mind. And it can only be done by collaborations between centers. And then research, translational research, can only be done by collaboration between centers. So my main request is for all the centers to be inclusive, to integrate yourselves, to be collaborative and to try and bring together the secondary and tertiary healthcare provisions, perhaps along the 5 regions that I mentioned, and to have selected research programs according to what the population needs. So you start from the materials that are available and have clinical databases and tissue banks, have the personnel and the expertise that I talked about, and that goes from information technologies to genomics to immunology expertise and biological services, various animal models or not. Those are important, and all the equipment and the know-how of the equipment, along with the space and infrastructure to keep it going, as well as clinical trials infrastructure. And then if you want to layer onto it other things that are on the far side, which is metabolomics, proteomics, drug discovery, or medicinal chemistry, you can do so, but you can't do it in every center. It's got to be centralized to centers with a particular interest in one of these areas, but linked together with other centers in the country.
2 minutes.
Yes, this is the last slide. One example of what I thought is a good example for all of us. A young man who is on the far side looks to be in that kind of Doctor Who type area is Professor Collins. He used to work in Oxford. He then went to Cambridge. And he had this idea that we will start a UK biobank. And this UK biobank does all the information that you have on this side of the slide. So it collects all this information. This was started now some years ago. The reason why I'm showing this slide is that this has now collected 500,000 data on 500,000 plus individuals in the country. And this exercise has led to something like 250 publications up till now. And there are about 30 publications that have appeared in Nature, Science, Cell, etc., from this UK biobank, which has been used by everybody in the world. So I think if we are to make inroads, we know nothing about this population. I'm doing whole genome sequencing on 200 samples of acute myeloid leukemia, thanks to King Faisal Specialist Hospital. And the genetics of that is different to what the genetics is in the Western world. So I think it is essential, if you are to do, to create centers which are internationally competitive, then these kinds of lessons are important to learn and to implement and practice them in relation to what is happening at the present moment and is what is going to happen in terms of expansion of the technology and the clinical care to the patient populations that you see. So I think one final slide is kind of a reminder that how important knowledge is. Last slide is, you know it far better than I will, and that is that, let's all pray for increase in knowledge. Thank you very much indeed.
Thank you, Professor Mufti, for this explicit talk. For the question and answer, I would like to invite our speakers to come to the stage so we can proceed with the question and answer. So we can start with the questions.
Assalamu alaikum. Good morning. I think you show us that there is tons and tons of data in the biobank, and myelodysplastic syndrome is one of the most very well studied, especially as a cause at molecular level, and maybe comparable to a breast cancer. Nowadays, we are talking about precision medicine, individualized treatment, and we have the artificial intelligence, which we hope that it can collect all this data, putting it together, and to choose the magic bullet or the magic treatment which will take care of the diseases or of whatever disease. Since you are the father of myelodysplastic syndrome, I would like just to hear your comment. Where are we now with what available data and with the application of artificial intelligence?
Yeah, thank you very much. I think MDS is probably where some of the other malignancies are in an older subject. I think one of the problems that I think there is in MDS, as it is in malignancies over the age of 70, particularly hematological malignancies, that the cells have had time to the chronic low-grade inflammation that is taking place as a result of aging, for example, and therefore you get these mutations which are kind of chip-type mutations, and then you get the driver mutations on top of those. So for those reasons, it's been difficult to identify whether there are specific genes that can be targeted. And I think the message is that there is probably no single drug that will do it. I think it is probably going to be a combination of things, both affecting the environment as well as affecting the clone that has progressed as a result. And the other thing which we're kind of now beginning to think about is, as was said, I think in the context of another cancer, you showed a fish diagram of a cancer where you had a few mutations and then there was a driver mutation on top that took off. That what is happening in MDS is that people are now being bold enough to treat CCUS with various things. So take the treatment back, because by the time it has reached the stage of RAVE2 or acute myeloid leukemia, it may be too late because they have accumulated so many mutations on the way and the resistance patterns that go with them. And I think that's when a part of the reply, but it's not the whole reply, because I think the other thing that's happening is that we are beginning also, on one hand, we're beginning to go precision medicine and find a target, as Paul Ehrlich called it magic bullet. On the other hand, it is also important to realize that in MDS, like other cancers, that you are beginning to identify the pathways that you can block. BCL2 being an example, venetoclax 5-azacitidine is probably the best combination that we have for both AML and MDS over the age of 70. And that venetoclax is not only for MDS or AML, it's used in other indications as well. So that pathway, immune mechanisms, that's a pathway as well. So that pathways, those will become clearer over a period of time. But at the present moment, I think I would say MDS is in an exploratory stage of science in relation to the new drugs. I don't know, it's a long waffle, but I don't know whether I answered your question. Huh? Well, it's the same thing, isn't it? It's been, I mean, others will comment on it, it's been bit by bit that things have got better. We kind of were, I think solid tumor people were kind of, they had a difficult job of it because hematologists came there first with, as was shown, with chronic myeloid leukemia. But not everything is chronic BCR-ABL positive disease and imatinib having the effect. I think we may hear later on about FLT3 inhibitors. There was a time when FLT3 inhibitors in acute myeloid leukemia, you didn't have any drugs for this. And now with gilteritinib and so on and so forth, there are targeted drugs against those mutations. So it is coming. It's slowly changing the paradigm. I think I don't.
Any other questions?
Nothing to do with FLT3.
Nothing to do with FLT3. In fact, at our institution, we have, at your institution, we have a disease, acute promyelocytic leukemia. And we can give lectures where we say, look, the cure rate is 100% with arsenic and ATRA, but in fact, that's not true. We lose a significant fraction of patients before they ever get diagnosed. So here, we're using some of the things that were talked about this morning. We got he looked like a high school student to me, but in fact, I think he did have some college training, who developed a machine learning algorithm to examine the slides. When a patient comes into our institution, a complete blood count is drawn and put into a robot, and the images are digitalized.
Yeah.
And the program is being taught to identify acute promyelocytic leukemia just from the CBC, because we have millions of images to teach it. The program is not looking at the granules and the cells. It's looking at things we wouldn't have thought of, clusters of lymphocytes and platelet abnormalities. It doesn't care about the cells. It's just, and it performs better than me. And I've been looking at slides for many years. Yeah. And we're at a position now to implement this AI program into the robot so that when a patient comes in with APL, this is when we lose them, when the emergency room physician doesn't recognize the emergency, but the robot will. And we're very close to that already right now, and this is actually happening in a sort of a pilot program right now.
Can I answer just on top of it? Let me tell you, the technology is ready. Now, the technology for example, ChatGPT has crossed the MD, passed the MD exam. So the technology is there to understand any type of challenge that you are talking about, whether genomics, any field. Now, the technology, you have to understand, doesn't come this is something called, I couldn't really show it here, technology called a foundation model. The foundation model, like ChatGPT, has been trained with these foundation things. But then, if you, as a King Faisal Special Hospital, you want to train your own certain specific advanced knowledge that you want to specialize, then this AI comes with this flavor that you can take this general knowledge, general MD, train it with your, for example, CAR-T or any specific domain that you have a lot of data, then it will be specialized in certain. So if you have 20 different departments, you can have 20 specialized AI algorithms so that everyone learns in that and they can answer in that way, number one. You have to understand this, that technology doesn't fit you. So what will happen? Something called TRL, technological readiness level. So any technology is there, as you had a question, magic bullet. Yes, it is there. But you have to adapt it, and that adaptation process until the clinical trials phase have to be tested by you, unless this is authenticated. So this is the hardest part only. I have one example I will give you. One of the technologies that I will talk about, that it was used from a US company. that they were giving, I will not mention the details. She's also from Johns Hopkins. So she was advocating that technology using complete AI in 47 seconds, it will give you very precise result, and it is applied on more than 10,000 patients in Saudi Arabia. And it went above more than 85% accuracy. Even the medical doctors, she herself, very well trained from Johns Hopkins, but she even couldn't differentiate between the delicate results, but the algorithm could. So now, but still last 3 years, it took the technology to bring into the to the patients, because there is a process of SFDA, you get approval from here and there. So it's a whole bunch of things. So, but I saw that doctor, she was very, I would say, patient in terms of slowly going through. And now she's about to launch that one, because she, as an MD, she's the one who actually was from technology to medical domain. The whole thing she was supervising. So my only concern is that unless the MDs, they take the technologies and kind of supervise the technology to mature it. Technology is there, but it has to mature. It has to serve your need. But that part doesn't come automatically. It has to, so the hospitals have to take a leap forward and then embrace these disruptive technologies, but don't just let it go, but I mean, give specific, that it will really help in efficiency, in getting a lot of things done that would have taken 5 months, but now it can be done in just few minutes maybe. So I think there's no magic bullet, but there is technology there, but that requires intervention from the medical doctors. That would make comment about AI.
Thank you very much.
I think it is important to say that what I was trying to say in that slide of when you got a whole genome sequencing data, and you apply algorithms to it, it's quite fascinating. There are so many algorithms, which are all based on AI, that you sometimes get a different result with a different algorithm. And certainly, one of the things that I've seen with this project on AML from here is that how different it is, because the populations are different. And therefore, to give you an example, there's a polymorphism on MIPL at position 106. That's been reported as causing high platelet count, kind of ET-type picture, without really increase in platelets, etc. But when you look at the population now, that is a polymorphism rather than a mutation with a functional change in it. So you find it's in a lot of populations. So those minor allele frequencies and all those that need to be done in order to teach the technology what is relevant to the population, I think that also needs to be done and hasn't been done up till now to the greater detail, particularly in cancer and related fields, I think. But I think it's happening now.
Thank you very much.
Sorry, I have this quick
We'll just have to conclude because of the time. Dr. Ziad Shibani, the chair, has something for the audience. Dr. Sibiai.
Of the first session, so the coffee break will be for 10 minutes, and we'll be coming back to the second session. Second things is for Al Madina tour, which will it is free for registration. It will be at 4:30. So feel free to drop by front desk for registration. The bus will move around 4:30. Even if you are invited to the gala dinner, there will be time to be, you will be on time for the gala dinner. The third announcement is regarding, the Jum'ah prayer. Jum'ah prayer will be around 12, and the buses will be provided in the hotel session. It will be in the mosque close to the Al Meridian. Thank you so much. We'll see you after 10 minutes.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Ladies and gentlemen, welcome to the second session, the GU session of this Precision Oncology Saudi Summit. First of all, I would like to thank the organizing committee for inviting us to participate in this prestigious meeting. It's my great privilege to co-chair and co-moderate this session with my dear friend, Dr. Imad Dasqandi, who's a senior medical oncologist in King Abdullah Medical City. And by the way, I'm Dr. Fahad bin Shams, I'm a medical oncologist from Dammam Al-Malik Fahad Specialist Hospital. Dr. Imad, if you kindly present the first speaker.
Thank you, Fahad. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. Special thanks to the organizing committee led by Dr. Amal. It is my honor to introduce the first speaker, Dr. Fahad Al-Muqbil. He's a consultant medical oncologist from King Faisal Specialist Hospital in Riyadh, and he will be talking about new era of prostate cancer precision medicine.
Thank you, Dr. Thank you, Dr. Imad. Thank you, Dr. bin Shamsa. Bismillah ar-Rahman ar-Rahim. Alhamdulillah, salatu wassalamu ala ashrafil khalq, Muhammad alayhi afdal as-salatu wa tamu taslim. Dr. Amal, Dr. Ziad, Dr. Amil, all the member of organizing as well as the scientific committee, thank you so much for inviting me to this great city that we all love, Medina Munawwara. So my task is to present prostate cancer in the era of the precision medicine. So those are my disclosures. So I will walk you through two main objectives. The first one, I would like to discuss the new diagnostic modality that we use it in our daily practice for any patient with a big prostate cancer. The second is the new therapeutic agent for advanced prostatic cancer. So mainly in the new diagnostic modality, we'll talk about tumor profiling, as well as for PET-BISMA, which one of the new modality diagnostic image. And regarding the second and the main topic is about the therapeutic agent. I will walk you through the lutetium-177 as well as for the PARP inhibitor and immunotherapy. So if we go to the Saudi Cancer Registry looking for the prostate cancer, it's not one of the top 10 if you look to the both gender, male and female. However, if you look to the male, it will be one of the fourth actually cancer common in the kingdom. And this is based on the last registry that we have 2020. So regarding the tumor profiling, we have two items that I would like to discuss with you is the test and the type of the test. So we have two main new tests that we use it for advanced prostate cancer is the HRR and MSI as well as a tumor mutation burden. The type of the test, which is the debates among us in the tumor board and between the clinician is the tissue versus blood. So what's the HRR? HRR is a homologous recombination repair pathway. It's usually in the third of patients. And there is a targeted PARP inhibitor or poly-ADP ribopolymerase inhibitor. It's, if you look to the somatic, it's accounting 23%. If you look to the germline, 11%. And total it will be around 33. There is around 18 gene alteration in the HRR pathway that you can use it and you can target it once the patient harboring one of those 18. In the NCCN guideline in the last 2 or 3 years, they adapt this test that it's a must or one of the standard of care to do HRR for the patient with a prostate cancer to offer them PARP inhibitor. If you look in detail for the NCCN, which was in 2020, there is looking for the patient characteristic and the risk factor if the patient Ashkenazi Jewish or the patient presented with advanced prostate cancer, as well as the other that you have to do HRR test for those patients. The HRR, or mainly PARP, is starting in 1960 in lab, and the first colony was, was in 1980. Then the first approval was in 2014 for patients with ovary cancer. 2015, we received the first approval for prostate cancer based on olaparib, based on the trial tobarab A. So it was evolving in the last few years. However, we start to see it in the practice in the last 3 or 4 years. Now, if you look to the old PARP inhibitor landmark study, you can see it's different. They didn't use all of them, the 18 gene. Tobarab A, they use a few. Tobarab B. Profound, they used the all 18. However, they divided in cohort A and cohort B, as well as the other PARP inhibitor, rucaparib and telaparib, landmark study. They use some of them and they ignore the other. As we will see in the next few slides, the response is different between one alteration to the another alteration. So you cannot keep one alteration in one basket. Each one of those alterations, they have different response for the PARP inhibitor for your patient. The second debatable items usually, can we do tissue? Which is usually one of the main issue in our workup for prostate cancer sometimes, or I can use less invasive tests through the blood. There is, again, different in the sensitivity and the specificity, and we do not have enough data to supporting using blood over tissue, as there is no clear concordance between the tissue to the blood. Each one of those have advantage and disadvantage. However, still the favorable test is do HRR from the tissue. Now, the next item I would like to discuss is the BIT-BISMA. We know the BIT for many years. However, recently we have BIT-BISMA designated for the prostate cancer, which is using some kind of agent that binds to the protein more than almost 1,000-fold than the normal, and it will lighten in the BIT scan. You can use it mainly in advanced castrate-resistant prostate cancer. And recently, if you look to the FDA approved, they have many agents. However, in US, they have only 2 products that used for BIT-BISMA, gallium-68 and F-18, which was approved 2 years ago. However, there is a lot of other diagnostic agents that can be used in BIT-BISMA to do this radiological assessment. So when I have to use it for my patient, again, there is no consensus or clear. If you look to European or Canadian or even NCCN, there is a thought here and there about when I have to use BISMA. And again, we have a big debate in our daily practice, especially in urology tumor board, about what's the optimal patient that I can use this test to help me in the giving the proper and precision therapy. If you look to the pictures on your left, you can see this is the BIT-BISMA, and you can see below the kidney it lighting up in the lymph node. However, if you do the regular BIT or BIT-choline, you can see there is no uptake in below the kidney. So it's more sensitive in detection of oligometastatic or other hidden area of metastatic prostate cancer. So now we'll go to the second main objective, and my talk is the precision therapy. We have the radium, or lutetium-177, and we have the PARP inhibitor. And I will end my presentation with the immunotherapy in patients with MSI-high prostate cancer. So in the first new products that we use it precisely for some of the patients, however, we are not using for the other, is the lutetium-177, and that was based on the VISION trial, which was published in 2021. And they have around 1,800 patients that they progressed after 3 lines or more, and they dividing them in the experimental arm, either lutetium for 4 to 6 cycles and standard of care or standard of care. And they're looking for the BFS as a primary endpoint, as well as the co-primary endpoint, the overall survival. And it was a positive trial, as there is prolonged in BFS and OS compared to the standard of care if you use lutetium-177 for patients who progressed after 3-line. However, if you look to the trial itself, for those patients with PIT-Bisma positive, they gain more benefit than those with the PIT-Bisma negative. So this is, again, area of precision medicine that I can offer lutetium-177, which are available in King Faisal Riyadh, as well as King Fahd Dammam, and I heard soon will be available in King Fahd Medical City, Riyadh. The side effect that we face it usually for those patients with lutetium-177 is the most common is the dryness, mainly in the mouth, as well as some kind of hematological toxicity that is not common, especially in the grade 3. You can see here the BFS Kaplan-Meier is clearly showing superiority of sorry for the resolution, maybe it's not clear, for the BFS as well as for overall survival, and the third, the last Kaplan-Meier, the skeletal-related event. And you can see the survival increase in the blue bar around 4 months compared to the standard of care in the red one if you offer lutetium. And this is the side effect, as I said, it's not that bad or not that grade 3 or 4 toxicity in general. So the lutetium-177, if they approve a year ago or 1.5 years ago, so another trial confirmed this, that lutetium is work based on therapy. It's similar to some extent, however, this is a phase 2 with a small number, around 300, and the control arm cabazitaxel, which is the standard of care, and the experimental arm lutetium, again 4 to 6 cycle, cabazitaxel up to 10 cycle, and the primary endpoint. This is a slightly different, the division, which is the BSA response, and it was a positive trial showing a response and significant drop in the BSA with a better side effect and toxicity profile for those patients. But if you look to the update, which is last month for lutetium-177 based on therapy trial, they didn't show improvement in overall survival, unfortunately. So we have just only response in the BFS as well as BSA and no overall survival for lutetium. Now, the second targeted therapy or the precision therapy that we use it is the PARP inhibitor, not for all comer with advanced prostate cancer. We have many line, we have many options, olaparib, rucaparib, niraparib, and tilazoparib, different chemical structure, different half-life, and different trial that conducted to seek approval, and some, if not all, they get approval in second or third line and beyond, and some of them they get in the first line, as we will discuss in the next few slides. The mechanism of action, we can see the normal cell harboring the PARP side, as well as the alteration in the other side. And if there is any, different or in the cascade or in the repair of the cell will leading to cancer death or cancer proliferation. So what you need to have BRCA mutation and PARP inhibitor to correct and to stop the cell from proliferation. At the end, however, there will be resistance in different mechanism. So PARP inhibitor was studied as a monotherapy in BRCA positive and was studied as a combo with either hormonal therapy or immunotherapy or even chemotherapy and different level of phase 2 and phase 3. So one of the landmark study that get the first PARP inhibitor approval in advanced prostate cancer is the PROfound, which is a randomized phase 3 for those patients who failed the first line and they receive either olaparib or physician of choice. They divide the patient in 2 cohorts. Cohort A, which is those patients who are harboring BRCA1 and BRCA2 and ATM, which is the most common, and they get the more benefit except for ATM. And the cohort B, which is different alteration, the rest of the 18 gene, which is 15 gene. The primary endpoint was BFS, and this study was a positive and regarding the BFS, as we can see from the Kaplan-Meier, with improvement around 40 to 50%. The side effects, and the benefit was in all patient characteristic or all the subgroup analysis, except some of the alteration, including the PP2R2A. And you can see clearly that some of them cross the line and the others still showing a response in different alteration. Those are the side effects that we are all familiar: hematological toxicity in the PARP inhibitor, mainly anemia. And the second landmark study that I would like to share it, however, this time the same drug, which is olaparib, but in the first line, which is the PROPEL trial. It's a phase 3, double-blinded. They give the patient the standard hormonal therapy with placebo or hormonal therapy with olaparib, and the primary endpoint similar to the profound trial, which is the BFS, and it was a positive in regard of the BFS. And this is the Kaplan-Meier showing the response, the control arm, based on investigator analysis, and this is based on the independent analysis. And you can see slightly there is a difference when the analysis was done externally or outside the investigator of the trial. Now, the last item that I would like to share it with you is the immunotherapy. We rarely use it, as the incidence of MSI high less than 3% in prostate cancer, and in some trial it's around 12. However, I believe it's around 3 more than the 12, but according to data, can reach up to 12% with MSI high or tumor mutation burden. And I think it's must to be done for the patient who's not harboring HRR, as this is one of the targeted or precision medicine that we have to offer it to the patient, especially in second line and beyond. In 2017, we have agonistic approval for pembrolizumab for all comer with harboring MSI high or having MSI high or deficient MMR. And again, there is many ongoing trial that already conducted showing the objective response of immunotherapy is between 40 plus minus if you offer it to the patient. So I think one of the therapy that we can use it for only MSI high. I will end with this slide that Canadian Urology Association, you can see clearly that they added some of precision therapy in the first line, like olaparib and the other PARP inhibitor, as well as in the second line and beyond. And we can say now, in the last few years, that there is a precision medicine in prostate cancer after long years with just only one size fit all. But now we have a different, as I mentioned in the previous slide. Thank you.
Thank you, Dr. Fahad, for this outstanding review of precision oncology and prostate cancer. As usual, thank you very much. I think we'll proceed to the next speaker, so the discussion will be at the end of the session. It gives me a great privilege to introduce Professor Yusri Rostom. Professor Yusri is a professor of clinical oncology in Alexandria University. Presentation title is Immune Oncology in Poor Risk Metastatic RCC, How to Select Best Treatment Option. Professor Yusri.
Assalamu alaikum. First of all, I would like to express my gratitude and pleasure to be invited to such an esteemed conference. I'd like to thank the organizing committee headed by Dr. Amal, and I'd like to express my gratitude to my dear colleague and friend, Dr. Mervet. Now we come to the issue of our presentation today. What is the best treatment for patients with metastatic RCC. After the introduction of immuno-oncology or immunotherapy in this domain, as you all know, 30% of RCC patients have metastatic disease at their initial presentation. The International Metastatic RCC Database Consortium adopted a prognostic criteria for metastatic RCC based on the time from initial diagnosis to treatment, Karnofsky Performance Scale, low hemoglobin, high calcium, high platelet, high neutrophil. These prognostic risk factors were subdivided to three main categories: favorable risk group, intermediate risk, and poor risk group. It's sad to know that the poor risk group constitute 75 to 80% of metastatic RCC patients. As you all know, this was translated to the overall survival, as the poor risk group showed only 7% 2 years overall 2 year survival, while the favorable risk group showed up to 75% 2 year survival. This is the evolution of the first line treatment in advanced RCC. As you see here, in 2006 up to 2009, there was the introduction of TKIs as sunitinib, pazopanib, beva, interferon alpha, and the introduction of the mTOR inhibitor like Temzo. Then came cabazitaxel in the 2017, with 2018 with the introduction of CheckMate 214, trying Epi plus Nivo for 4 cycles than Nivo for intermediate and poor risk patients. In 2019, the FDA approved the combination of pembrolizumab according to Keynote 426 and avelumab according to the Javelin Renal, and this was followed with evolution many other lines like nivolumab in the following year and pembrolizumab according to the CLEAR trial and everolimus. And in 2021 there was introduction of triad of Epi, Nivo, Cabo in the Cosmic 313, and Prodig introduced the Epi, Nivo, and lastly in 2022 the CheckMate 2014 approved Nivo as a single agent. Now we come to the latest guidelines. As you see here, the NCCN guidelines included 5 regimen with a category 1 recommendation, which is the axitinib pembro, cabo nivo, epi nivo, lenvatinib plus pembro, and cabozantinib for poor and intermediate risk patient with metastatic disease. Now we come to the Keynote 426, which included axitinib pembro. The inclusion criteria, you will find that most of these inclusion criteria are repeated on all the coming trials. The Keynote 426 included patients with new diagnosed or recently or recurrent stage 4 clear cell RCC, no previous treatment, Karnofsky Performance State more or equal to 70, measurable disease per RECIST, provision of tumor sample for biomarker assessment, and adequate organ function. It included 860 patients randomized in a fashion of 1-to-1 to either the trial arm, which is pembro, axitinib, compared to the standard arm of sunitinib, and the dual primary endpoint was overall survival and progression-free survival in intent to treat population, while the key secondary endpoint was overall response rate, duration of response, patient-reported outcomes, and safety of the treatment regimen. As you see here, For the favorable risk patient, this combination didn't show significant overall survival difference, while it showed a progression-free survival of 45% compared to the 35% at 2 years for the standard arm, and the overall response rate was significantly better in the trial arm of 69.6% versus 50.4% for sunitinib. While in the intermediate and poor risk patient, it shows significantly better results regarding overall survival, progression-free survival, and overall response rate. At the median time from enrollment to data cutoff of 42.8 months, the treatment-related adverse events with incidence more than 20% were comparable in both treatment arms, as you see here. And the adverse events of interest, which are we usually concerned about in patients with immuno-oncology or patients with TKIs. So on April 19, 2019, FDA approved the combination of pembrolizumab for the first-line treatment of patients with advanced RCC. Now we come to the second competitor, which is CheckMate 9ER, which included Nivo plus cabozantinib. This is updated follow-up results of Nivo plus cabozantinib versus sunitinib for previously untreated advanced RCC. As you see here, the previous result showed that Nivo cabozantinib demonstrated superior progression-free survival, overall survival, and overall response rate, and better quality of life versus sunitinib in patients with previously untreated advanced RCC in the primary analysis or at 18 months, with a median follow-up for overall survival of the phase 3 CheckMate 9ER trial. With extended follow-up, Nivo-Cabo maintained efficacy and a better quality of life versus sunitinib at 44 months of a median follow-up. So here we report the updated efficacy in the intent to treat population with 55.6 months of follow-up for overall survival, one stratified by IMDC risk and organ sites of metastasis and quality of life safety. This is the regimen used, the Nivo-Cabo, compared to sunitinib, which was standard of care at that time, treatment until disease progression or acceptable toxicity. We were looking for a primary endpoint, progression-free survival, according to the blinded investigator central review, and the second endpoint of overall survival, overall response rate, and exploratory endpoint of quality of life. As you see here, the combination showed a better, significantly better progression-free survival and overall survival and overall response rate per blinded independent central review analysis in IMM-free survival in favor of the combination, and the hazard ratio of 0.73 for overall survival in intermediate and poor risk patient, and the overall response rate was significantly better for the combination of 52.6% when compared to the standard of care with sunitinib of 23%. And the treatment-related adverse event, which showed any grade of treatment, led to the discontinuation of Nivo or Cabo in 28% of the patient, Nivo only 10%, Cabo only 10%, both simultaneously 7%, both sequential 1%. And patient who received sunitinib showed 11% stop of treatment. To conclude, for this trial, with 55.6 months median follow-up, Nivo plus Cabo continues to maintain meaningful long-term benefits over sunitinib in progression-free survival, overall survival, and overall response rate. Progression-free survival and overall response rate favored Nivo plus Cabo versus sunitinib, regardless of the IMDC risk factors. Efficacy favored Nivo-Cabo versus sunitinib in specific subgroups by baseline organ sites of metastasis. The safety profile is consistent with previous follow-ups with no concerns identified. Quality of life was consistent with the previous follow-ups and favored Nivo plus Cabo versus sunitinib in the intent to treat population and in the IMDC intermediate and poor risk patients. These results continue to support Nivo plus Cabo as a standard of care for previously untreated advanced RCC. Now we come to the CheckMate 214, which tried the Nivo and the Epi in combination as a first-line therapy for patients with advanced clear cell RCC. Sorry. This study included treatment-naive advanced RCC, clear cell component, measurable disease, Karnofsky performance scale more than 70%, and the patient were stratified according to IMC prognostic factor to favorable, intermediate, and poor risk. And they were stratified according to the region, to the US, Canada, Europe, and the rest of the world. The Arm A received Nivo plus Epi for 4 cycles, then maintained Nivo every 2 weeks. Patient can receive Nivo for flat dose of 240 milligram compared to the standard arm of sunitinib 50 milligram once daily, 4 weeks on, 2 weeks off as usual. And the treatment was given until progression or unacceptable toxicity. The primary endpoints were overall response rate, progression-free survival, and overall survival in intermediate and poor risk patients. As you see here, the hazard ratio for overall survival has been 0.69, which means decrease the risk of death by 31% for the combination Nivo Epi. Even this result were consistent over 8 years of median follow-up, as you see here, at 2 years, at 6 years, and at 8 years. The results were consistent of a median follow-up, intermediate, and poor risk patient in favor of Nivo Epi. This was replicated in the progression-free survival, as the hazard ratio for progression-free survival over 8 years of median follow-up in intermediate and poor risk patient was 0.73 in favor of the combination Nivo Epi. This was shown regarding duration of response, overall response rate, best overall response in the intermediate and poor risk groups, as you see here. So the hazard ratio for overall survival with Nivo and Epi versus sunitinib has remained stable over 8 years, as we already mentioned, about 99 months of median follow-up in the intent to treat and the intermediate risk group, and has improved over time in favorable risk group, because it is at the start there was no difference in the favorable risk group between the treated arms, but after 8 years the curves started to diverge. Progression-free survival probability were higher with Nivo Epi versus sunitinib in the intent to treat and the intermediate and poor risk patients, with 90-month progression-free survival probabilities ranging 23-25% in the Nivo Epi arm. Responses to Nivo Epi were deep and durable in the overall study population. Patients had notably improved duration of response and more complete responses with Nivo Epi over sunitinib, regardless of the IMTC risk. Long-term safety with Nivo Epi continues to be manageable. These results represent the longest follow-up in a phase 3 trial of a checkpoint inhibitor combination therapy in first-line advanced RCC, and continue to support Nivo Epi as a standard of care. Now we come to one of the very interesting trials which has been compared, which is a clear trial comparing lenvatinib with combined with Pembro and lenvatinib everolimus against the standard of care, which is sunitinib. As you see here, when we used the first arm, lenvatinib Pembro showed much better overall progression-free survival of hazard ratio 0.39 when compared to sunitinib, and the other combination lenvatinib everolimus showed as well a better progression-free survival of hazard ratio 0.651 compared with the standard of care of sunitinib. And this was reflected to an overall survival benefit for the lenvatinib-pembro combination when compared to sunitinib with a hazard ratio of 0.66, but this was not reflected in the second arm of lenvatinib everolimus when compared to sunitinib, as the median overall survival for lenvatinib-pembro not reached 33.6 plus, and lenvatinib everolimus not reached and sunitinib not reached yet. So when we compare the favorable histology with the intermediate and poor risk, this combination didn't show overall survival benefit in favorable risk group, while in intermediate and poor risk group, the lenvatinib-pembro showed significantly better overall survival benefit as it decreased the risk of death by 26%. And the overall response rate of the combination lenvatinib-pembro was much better, of 41% when compared to sunitinib, 36%, as well as lenvatinib-evro when compared to sunitinib of 53.5 compared to only 36%. Both results were significantly better response rate. Here we'd like to show the treatment duration of exposure. Median duration of treatment exposure for the lenvatinib-pembro was 17 months, while in the lenvatinib everolimus were 11 months and in sunitinib 7.8 months. Grade 5 treatment-related adverse events were observed in 1.1% of patients in the lenvatinib-pembro arm, 0.8% in the lenvatinib everolimus arm, and 0.3% in the sunitinib arm. The treatment adverse event in more than 20% of patients in both arms, it showed a comparable incidence of adverse events with a slight difference. The ALT elevation observed in 9.7% of the patients with lenvatinib-pembro arm and in 8.8% of patients in the sunitinib arm. Grade 3 in 3.1 of patients in lenvatinib-pembro arm versus 1.8% in sunitinib arm. EST elevation observed in 9.4% of patients with lenvatinib-pembro arm and in 8.8% of patients in sunitinib arm. Grade 3 in 2.6 patients in lenvatinib-pembro versus 0.6 in sunitinib. Well, now we come to the final trial, or the last trial I'll present, which is Avilo plus Axitinib for advanced renal cell carcinoma. It's the Javelin Renal 101 trial. It tested Avilo plus Axitinib for advanced RCC, the same eligibility criteria as all previous trial, but here with the tumor tissue available for PD-L1 staining. The patient was stratified according to ECOG performance status 0 versus 1, and geographic region USA versus Canada, Western Europe versus the rest of the world. Avilo plus Axitinib were given for 6 weeks as a 6-week cycle compared to the standard dose of sunitinib. As you see here, regarding the progression-free survival, the combination showed significantly better progression-free survival of 11.8 months when compared to 7.2 months for the sunitinib, and in the patient with PD-L1 population. While in patient with the overall population, not regarding the PD-L1, it showed better, the combination showed better progression-free survival of 13.8 months compared to 8.4 months. Now we come to overall survival in the PD-L1 population. The hazard ratio was 0.83. For the overall population, the overall survival shows a hazard ratio 0.8 in favor of the combination Avilo-Nivo. when we consider the anti-tumor activity among patients with PD-L1 positive tumors and in the overall population, the combination of avelumab showed 55.2 months of objective objective response rate compared to 25.5 for sunitinib in the PD-L1 positive tumors, while in the overall population it showed 51.4 month as a confirmed objective response rate compared to the 25.7 month for the sunitinib. Now this is a kind of a visual comparison between the main two large trials, Checkmate 214 and Keynote 426, which comparing Nivo Epi with sunitinib and axitinib Pembro with sunitinib. The aim of this trial is just show this slide is just show that Checkmate 214 failed in favorable risk patients. This is a kind of visual comparison. I know this is not the standard of scientific comparison, but it showed comparable results for both regimens when compared to Sutent as regards the overall survival for intermediate and poor risk patients. This is the tables of comparison of response rate in the previous two trials, Checkmate 214 and 426. This is a kind of a collection just to show some thoughts or conclusion. In the clear trial, pembrolizumab, lenvatinib, intermediate and poor risk patient. Poor risk patient constituted only 9% of the patient. In the median progression-free survival, Javelin trial showed 8 months of overall survival for poor risk patient, progression-free survival for risk patient. In the Checkmate 214, median overall survival at 5 years was 43%, it was the highest. And in the Keynote 426, the overall response rate were 75%, and grade 3 and 4 toxicity were the higher 82% in the clear trial using pembrolizumab. From this, we can make a kind of consensus or of kind of choice for a stable patient with comorbidities against VEGFR TKIs, no high tumor burden. They can use the combination of Nivo Epi according to the Checkmate 214 was better longevity and quality of life. The rationale is better 5-year overall survival, manageable adverse event toxicity, less patient were withdrawn even after 5 years. The other option for this kind of patient is Checkmate 9ER, which included Nivo-Cabo. And for patients with stable condition, high disease burden, fast-growing tumor, resected or not resected, the Keynote 426, which is the Pembro axitinib, showed higher longevity with higher overall response rate and 5-year overall survival 38%. And another option for this kind of patient is the pembrolizumab according to the second arm of clear trial. And its results are better at 4 years with a median overall survival of 47 months, overall response rate 73%, median duration of response of 17 months. But only poor risk patient was 9%, while in the immediate group was 59. This is to conclude IO-TKI combination yields the best combination of upfront overall response rate, progression-free survival, and long-term overall survival benefit to date, while IO shows a durable, sustained response. For favorable risk patients, some can be observed or started even at a single agent VEGF-TKI. Good toxicity measurement ensures responding patients can stay on active therapy. I'm very sorry to be a little bit long, but I like to invite you all to our coming event in Alexandria. It's the Alex Onco. It will be in the next spring from the 1st to 2nd May 2024. Thank you very much. I'm very sorry for being long.
Thank you, Professor Yusri. I would like to invite you and also invite Dr. Fahad to the stage so we can have maybe 5 to 10 minutes discussions. For our audience attendees, if you have a question, please raise hand so we can deal. So maybe, Dr. Ahmad, if you allow me to start for a question with, for Dr. Fahad. Thank you for the presentation. It was really outstanding. And I want to know, in your practice, when do you do the HRR mutation and the mutation analysis for prostate cancer patient? Do you use tissue or blood?
Thank you, Dr. Fahad. Thank you, Dr. Fahad. So what I'm doing, as well as my colleagues, Dr. Bazrbashi, Dr. Raouf, GU team, Medical Oncology in King Faisal Riyadh, all patient, all comer, we are requesting for them the metastatic prostate cancer, mainly the patient with the castrate resistant from the tissue, honestly. But if we face an issue with the tissue, we have two options, either to have another tissue or to do it through the blood. One of the cases that I faced recently, that the tissue was not enough, I request for blood, just only BRCA1, BRCA2, which was negative. Then I request for HRR, which is the extended 18, and I found one of the mutation that, I start the patient in PARP inhibitor. So you can start with the tissue, as this is the most studies. Then you can go after that if you have a difficulty in access or challenge to the blood.
Dr. Ahmad, how is the situation in your center in practice?
We've been passing through a lot of changes in the past. We were able to request for tissue and then liquid, but we had some troubles. At the end, I think with the collaboration from other parties, we are able to do that from day one for liquid biopsy nowadays. So another question to you, Dr. I think so. Yeah,
sorry, Dr. Ahmad. Well, thank you, Dr. Fahad, and thank you, Prof. Rostom, for this nice explanations. Just to Prof. Rostom, so now we have a lot of options. So we have Lenva Bimbro, we have Nivo, plus Cabo, and then we have another study supporting intermediate or going risk score by the depending on the features the patient presenting with. So in your practice, do you go based on selection of histology? Because there's certain pathology like the papillary types, they have very aggressive behaviors, and they maybe were not well represented in the study, because majority of the patient in the studies, they are clear cell type. So in your practice, in these rare types, like papillary subtype of pathology, do you have any specific preference for which your first line treatment?
Assalamu alaikum. Thank you for this very intelligent question, because we face these rare types. We follow the guidelines. If we have all the medication available, we follow the guidelines. I know it's more aggressive. We should be, but there is guidelines for treatment of the non-clear cell histology. We follow the guidelines. We can start with cabozantinib, we can start with pembro, and I think the results will not be as we'd like to be, but there is guidelines for this kind of patient, and we can follow it in case of availability of the treatment.
Can I add that before we use, as Dr. mentioned, cabozantinib, but now there is a data for pembrolizumab. So, and this is what we start to adapt it in King Faisal Riyadh for patient with papillary, as well as some of type of the clear cell. And soon you will, inshallah, hear from one of my colleagues that he's collecting the data to see the real world data for using pembrolizumab or immunotherapy in general as a first line for non-clear. It's multi-center with the help of other oncology center in the kingdom that they are collecting this data. So far, what we are seeing in a few cases here and there in our daily practice, they are responding to some extent, matching the historical data.
Yeah, تفضل دكتور
Dr. Shoghi.
Thank you, Dr. Fahad. The question is for Dr. Fahad. Beautiful lecture, as always. Even people who treat breast cancer are attending your lecture. So I have a question that I don't have an answer, so I would like to see your insights and or the group. So in the PROPEL trial, patients were, the primary endpoint was radiographic PFS. In both groups who are BRCA positive and BRCA negative, or the HRR negative, the primary endpoint was met. It's only the overall survival that was not met, which is a secondary endpoint. So my question is, why do we put a primary endpoint, we meet the primary endpoint, and then we don't take it? And the second question is, why do you think there was an improvement in the radiographic PFS with the hazard ratio of 0.7 in those who are HRR negative or BRCA negative? Thank you.
Thank you, Dr. Bazabashi. So, difficult question from my boss, and I do not have an answer to cut it short, honestly. But honestly, Dr. Bazabashi, honestly, I don't know. So, theoretical, we have a lot of other solid cancer that they are responding in the tumor marker or they are responding in PFS. But if you look to the real, the end, that what we aim, the overall survival, you cannot. Like, for example, pathological CR. We have many trials in different solid cancer. You achieve better CR, but did not reflect in overall survival. This is regarding your second question, that the patient is responding radiologically or clinically, however, the overall survival didn't reflect that. Is it because patient characteristic? Do we need to know to have a different PARP inhibitor other than abiraterone because it's a different structure, or we need to have more study in non-BRCA and to see the overall survival? Honestly, I don't know. But for the first question also, no clear answer, and no, I don't know about Dr. Ahmad, Dr. Fahad.
Well, I agree with you, Dr. Fahad. This is a great question, Dr. Shoghi. And this speaks that we need to learn more, and there's a lot to be discovered about the markers that we deal with. We say PD-L1 immune therapy, but like PD-L1 negative also respond sometimes. PRCA negative also respond. That means these are not the perfect targets. Of course, as you always state, there's something more to learn about these things. And I totally agree with you regarding the primary endpoint and secondary endpoint. If it's the primary endpoint, I think it should be given the most respect regarding practice.
Great question, Shawqi. As you know, PROPEL trial is one of the highest trials where they had a lot of criticism. This is point number one. I think point number two, if you look at all MCRPC trials, they all met primary endpoint, the overall survival. And when we see that trial showing only PFS and then secondary endpoint, so this put and raised a lot of questions which we don't have an answer. I think the third point, at least in my view, the evolution in PARP inhibitor in MCRPC is something nice, but I think we need more time also to find the best answer for each such a question. Someone raised his hand over there. Okay, another question to you, Dr. Rustom, is when you look at selecting the best treatment option with those combinations in metastatic RCC, we have safety and we have efficacy data among them. So which is number one in your practice should guide you and guide us as well?
I always try to be safe as I can. Because, as you know, the efficacy along the horizon of the different combination of IO, TKI, IO, they didn't differ much except for this cabozantinib containing trials. So and with the personal variation, I start with the most efficacious and most safe. Then, if there is
Can you give us an example? So most efficacious.
I usually start with pembroxetinib for the clear cell type, or either axitinib or pembro, a single agent for non-clear cell type, and it is usually well tolerated with a very good results till now.
Okay, thank you.
Okay, I think we're on time, so if you want.
All right, I think now we are at the end and closing the session. Thank you, speakers. Thank you, Mr. Chairman, and we move to the third session. Thank you.
Thank you all.
Good morning, Assalamu alaikum. Now we'll move to maybe more interesting session of precision medicine in early breast cancer. I'll invite my co-chairs, Dr. Shadi Khayyat and Dr. Majid Al-Jahil. To save time, we'll proceed directly with our first speaker, Dr. Nikki Levitt from UK. She is a consultant medical oncologist with a very large experience in treating early and late breast cancer with all modalities of breast cancer management. She is running multiple trials in the NHS. So welcome, Dr. Nikki.
Good morning, and first of all, I'd like to thank the organisers very much for inviting me to speak today. The topic that I've been given is for women with hormone receptor positive HER2 negative early breast cancer who have high clinical risk disease but low genomic risk disease. Do they benefit from adjuvant chemotherapy? These are my disclosures. So this morning I wanted to go over the data from the TAILOR-X and Responder trials, and also to mention that there are other genomic assays available. I plan to split the question into that affecting postmenopausal women and then premenopausal or younger women. And finally, I wanted just to share with you a few slides from an audit that we did in Oxford. So we know that chemotherapy is unpleasant treatment with significant both short and long-term side effects. And we also know that it doesn't benefit very many people. And the graph I've put up is from the Early Breast Cancer Trials Collaborative Group from 2012, showing that fewer than 10% of patients benefit from the addition of adjuvant anthracycline-based chemotherapy. And this has led on to the development of genomic assays, which hope to divide women into those who are highly likely to gain benefit from chemotherapy, and very importantly, those who do not gain benefit from adjuvant chemotherapy and can be spared the toxicity. And one of the assays to be developed was the Oncotype score, which comes out with a recurrent score and is a 21 gene assay. And about 5 or 6 years ago, the TAILOR-X study was published. In this, women with T1 or T2 node negative, hormone receptor positive HER2 negative breast cancer were offered an Oncotype score. Women with very low scores, 0 to 10, were recommended to have endocrine therapy only, and women with high scores above 26 were recommended to have chemotherapy followed by endocrine therapy. And women with intermediate scores, 11 to 25, were randomized 1-to-1 between endocrine therapy or chemotherapy followed by endocrine therapy. And important to remember, the hormone therapy was not specified in this study. The primary endpoint was invasive disease-free survival, and I hope you will all agree that the curves absolutely on top of each other, no benefit in this group from the addition of chemotherapy. And overall, the secondary endpoints of distant recurrence-free survival and overall survival, again, the lines absolutely overlie each other. In the total population, no benefit from the addition of chemotherapy. However, when there was a subgroup analysis, and in the Taylor-X, women were divided into those under 50 and those over 50, those women who were over 50 showed no benefit from the addition of chemotherapy if they had an Oncotype score below 26. However, for younger women, there was benefit seen with scores above 16 and certainly scores above 20, indicating that they did potentially benefit from chemotherapy, and that we should have some concerns about omitting chemotherapy in this group of women. After the Taylor-X study, there was the Responder study, which was a very similar study, but in women with node-positive disease. So in this, women with N1 disease, so 1 to 3 nodes involved, again had an upfront Oncotype score, and women with high scores of 26 or more were recommended to have chemotherapy, and those with scores of 0 to 25 were randomized 1-to-1 between endocrine therapy and chemotherapy, followed by endocrine therapy. And again, in the Responder study, the endocrine therapy was not pre-specified. I wanted just to remind you of some of the patient characteristics in this study. So, of note, 1/3 of patients were premenopausal and 2/3 postmenopausal. Approximately 2/3 of patients had only one node involved, and of the remaining third of patients, fewer than 10% had 3 nodes involved. And looking at the grade of cancers, again, roughly 2/3 had grade 2 disease, with about 10% having grade 3 disease. So within the higher clinical risk population, the Responder trial was the lower end of high clinical risk based on nodes and grade. Looking at the results, again, for invasive disease-free survival, for those women who were postmenopausal, there was absolutely no difference seen and no benefit therapy. However, that was not true of the premenopausal women, where the curves separated with a 5-year improvement in invasive disease-free survival of 5.2% for the addition of chemotherapy. The most important clinical endpoint, recurrence endpoint, is probably the distant disease-free survival, because it is distant disease that goes on to end women's lives. And again, looking at distant disease-free survival, for the postmenopausal women, you can see that there was, again, no difference, no benefit from the addition of chemotherapy. Whereas, again, for the premenopausal women, there was approximately a 3% difference seen. And looking at the overall survival, again, for postmenopausal women, no difference for the addition of chemotherapy. But for premenopausal women, the curves separated with a 5-year absolute improvement in overall survival of 1.3% for the addition of chemotherapy. I want now just to focus on the postmenopausal group of women and think about them. So this is the forest plot for the pre-specified subgroups. And what I'm hoping that you can see is the dots for the mean for all these subgroups are very much around the 1.0 line, with no improvement in survival for the addition of chemotherapy, regardless of whether they had higher grade disease compared to low, they had larger tumors compared to smaller tumors, whether they had higher clinical predict risk using the predict scoring system compared to lower risk, whether they had 2 or 3 nodes involved compared to only 1 node involved, and perhaps in particular, whether they had higher low recurrence scores, i.e. 14 to 25, compared to the very low scores of 0 to 13. Therefore, I think that we can say that for postmenopausal women with 1 to 3 nodes involved and low recurrence scores, there was no benefit from the addition of chemotherapy. But I just wanted to think a little bit about women with higher risk disease who have more than 4 nodes involved, because women with N2 disease were excluded from both the responder study and also from the MIND-ACT study, which asking a similar question but using the MammaPrint 70 gene assay. This slide is just looking at a little bit of data from the Prosigna assays available. And this data is taken from the Mitch Dowsett 2012 paper. In this schema, women who had, just in case the key is small on your screens, women in grey had node negative disease. The yellow lines correspond to women with 1 to 3 nodes involved, and the blue lines to women with 4 nodes involved. And what I think you can see is that regardless of the nodal status, there were women with a variety of risk of recurrence scores across all 3 nodal groups. I think that on average, if you had node negative disease, you were likely to have a slightly lower recurrence score than if you had 4 or more nodes involved, but there is a wide variation with women with high nodal burden, but still having low recurrence scores. And the recurrence score is still very meaningful in women with significant nodal disease, with even with 4 nodes involved, women with a low recurrence score having a much better long-term outlook than if the recurrence score is high. Furthermore, thinking of women in this category, we know that if you are postmenopausal and you have a hormone receptor positive HER2 negative breast cancer, and you have a low genomic risk, we know that if you have node negative disease, you do not benefit from the addition of chemotherapy. We know that if you have 1 to 3 nodes involved, you do not benefit from chemotherapy. It would seem to me unlikely that with a low recurrence score, a low genomic score, that if you have 4 nodes involved, that you are going to benefit from chemotherapy, because my feeling is that it is much more to do with the biology of the disease than the nodal burden. But of course, we don't have data on that as yet. I now want to think about the premenopausal women who this is the 6.1 year updated follow-up from the responder trial. And you'll remember that women who are premenopausal do get benefit from chemotherapy, and we can see that those who had chemotherapy have lower disease distant recurrence compared to those women who did not have chemotherapy. This is the pre-specified subgroup analysis, the forest plot, and as you can see that in different to the women who were postmenopausal, now the majority of the dots are lying to the left, favouring the addition of chemotherapy. The 2 subgroups who are closest to the one axis are the women over 50 and the women who had lobular breast cancers, which I think is no surprise. I think we would guess that they were the women who were least likely to gain benefit from chemotherapy. Thinking again about whether it is the nodal burden that's important, this is data from a post hoc analysis. So the trial was not powered to look at this, and so please don't take this as being significant data, because it isn't. However, numerically, when looking at premenopausal women, looking at whether they had micrometastatic or macrometastatic nodal disease, we see very similar curves, with even women with micrometastatic disease appearing to get benefit from chemotherapy. So it looks to be more the biology, I think, than where you've got to in terms of nodal spread that's important. And thinking about whether it is a direct cytotoxic effect of chemotherapy or whether it's this is actually an endocrine effect that is benefiting patients. And in both the Responder and the TAILOR-X studies, as I've said, the endocrine therapy was not specified, and only a small minority of patients had ovarian suppression. So in the endocrine treatment arm, only about 15% of women had ovarian suppression, and in the chemotherapy arm, even fewer had ovarian suppression, only about 5 to 10%. And it is hypothesized generally that for many of these women who were premenopausal at diagnosis, that and with low recurrence scores, that actually the benefit from chemotherapy is because they are pushed into a menopause, with a chemo-induced menopause, by the chemotherapy, and that it is much more of a hormone effect than a direct cytotoxic effect. And again, this is another post hoc analysis, so not statistically significant. However, numerically, for premenopausal women, you can see that whether they were in the endocrine therapy alone arm or the chemotherapy alone, those women whose periods stopped, that's the blue lines, appeared to do better than those women who continued to menstruate regularly, the red lines. And this should not surprise us, because we know that ovarian function is important for women post breast cancer. We've got 25 years of knowing this. This is the data from the 1996 Lancet overview of ovarian ablation in women under 50, and looking at both recurrence-free and overall survival, whether you were node negative or node positive. Those women who had ovarian ablation had improved survival. And we actually have further data on the importance of endocrine therapy in premenopausal women from the EBC TCG 2022 meta-analysis, which looked at over 7,000 women from a number of hormone studies with 8 years of follow-up. In these studies, all the women had ovarian suppression, and those women who had the addition of an AI in blue had less recurrence, both any recurrence and lower distant recurrence, in comparison to those women treated with tamoxifen in red. So the hormone therapy that you give women really does matter. And the concern is that that in the Responder and MINDACT trials, that the hormone therapy was less than ideal, and that by giving chemotherapy, you're improving the hormone therapy rather than acting with a direct cytotoxic effect. I just wanted to mention the MINDACT study, which looked at the MammaPrint 70 gene assay, and is similar, therefore, to the TAILOR-X and Responder trials using the different genomic assay. So in the MINDACT study, women were eligible if they had T1 to T3 disease and were node negative or had 1 to 3 nodes involved. And the study picked out those women who had discordant clinical and genomic risks. And Martine Pickart presented this data about 3 years ago with a median follow-up of about 7.5 years. And the 8-year invasive disease-free survival showed that overall, women with high-risk clinical disease but low genomic risk disease had no benefit from the addition of chemotherapy, and this reached their non-inferiority boundary. Looking at subgroups, again, there was no difference between whether women had node negative or node positive disease. However, again, when women were looked at below and above 50 years, which I think has got to be a marker for pre and post menopause, there was a difference seen with a 5% benefit from the addition of chemotherapy in invasive disease-free survival. So really, the results very, very much in keeping with that which we've looked at in a bit more detail with the Oncotype. So it would seem that possibly for younger or premenopausal women, the benefit from chemotherapy may be due to an increased rate of chemotherapy-induced menopause rather than a direct cytotoxic effect. And this is now being looked at in the UK. We are entering women into the Optima study, in which in both the endocrine and chemotherapy arms, women are then mandated to have ovarian suppression for at least 3 years. And in the United States, there is the Offset trial, which is recruiting women with T1 to T3 disease, N0 or N1 disease. And again, women with Oncotype scores under 26 are being randomized between endocrine therapy alone or chemotherapy and endocrine therapy, but all arms are mandated to have 5 years of ovarian suppression. So hopefully these studies will go on and answer the question that remains about the benefit of chemotherapy in premenopausal women. Just to finish up with, I was hoping to share a few slides of real-world experience from an audit that we did on our data in Oxford. We've been very lucky in Oxford to have access to the Oncotype score for, in fact, over 10 years now. And so this is looking at, sorry about that. This is looking at data from February 2013 onwards. And this study, this audit was done by some of my colleagues in Oxford listed here. The majority of our patients were node negative. However, we did also have access, very unusually in the UK, to the Oncotype in node positive disease. And we've actually had quite a number of women treated with it. And in Oxford, if women had low recurrent scores, they would have not gone on to have chemotherapy. And so this is just looking a little bit more at our patients who had node positive disease, really just to show that regardless of grade, we still had patients with low Oncotype scores who would have gone on to not be recommended chemotherapy. This is looking at tumour size, which shows very much that you get a lot of low recurrent scores, even with the largest of tumour size. And this is looking at the NHS PREDICT scores, where I think what I want to show you is even with very low PREDICT scores, you pick up some women with high recurrent scores who potentially do gain benefit from chemotherapy, and we would have treated them with chemo. But also those with higher recurrent scores, there are certainly a number of women with low PREDICT scores who probably do not need chemo. And this is our follow-up data with just under 3 years of follow-up. Those with less than a year of follow-up are excluded, leaving us with 85 patients. I'm not in any way saying that there is any statistical significance attached to this, but it is gently reassuring that we've seen only 3 local recurrences and no distant or regional disease. So to conclude, for postmenopausal women with hormone receptor positive, HER2 negative early breast cancer with high clinical risk, with 1 to 3 nodes involved, but low genomic risk, I think the data is very clear that they do not get benefit from chemotherapy. However, we don't have data on women with higher nodal involvement, with 4 or more nodes involved, as they were excluded both from the Responder and MINDAC studies. And so the questions remain, can we extrapolate the data to those women with higher nodal burden? And my feeling is that chemotherapy may well not reduce the risk further, and that these women should be treated with maximal hormonal therapy with the addition of adjuvant CDK4/6 inhibitors. However, we don't currently have the data to show that it's safe to omit chemotherapy. And for premenopausal women, as I've said, I think age under 50 in these trials is really a marker of menopausal status rather than there being a biological difference that occurs on your 50th birthday. I think we know that currently that chemotherapy benefits younger or premenopausal women. However, it is hypothesized that much of that benefit is due to the induction of the menopause rather than a direct cytotoxic effect. And hopefully this question will be answered by the OPTIMA and OFFSET studies, which will include ovarian suppression in both arms. And my suspicion is that women who are above 40 but older but premenopausal and perimenopausal women with low genomic scores, I think they're unlikely to gain benefit from chemotherapy, but do need maximal endocrine therapy involving ovarian suppression, an aromatase inhibitor, and, where appropriate, consideration of a CDK4/6 inhibitor. However, we don't have the data to say that it is safe to omit chemotherapy yet. So my absolute conclusion as to whether we can omit chemotherapy for women who have high clinical risk but genomic low risk is that if you are postmenopausal, the answer is probably largely yes, with there being no data yet for the heavily node positive women, but for premenopausal women, not yet. And that concludes my talk for today.
Well, thank you. Thank you, Dr. Levitt, for this nice review, and I believe that touched a big part of our practice in the clinic. For sake of time, we're going to move to our next presentation. So our next presentation, it's about the role of immunotherapy in early breast cancer, and our distinguished speaker is Prof. Michael Genent from Austria. So Prof. Michael Genent is a well-known to the, all the community of the medical oncology. He's a professor of surgery, and he's the president of the Austrian Breast and Colorectal Cancer Study Group. Prof. Genent, he is a professor in the Medical University in Vienna in Austria, and he also worked with a lot of collaborative group. He authored multiple recognized articles, and he sat in a lot of guideline writing committees. So Prof. Genent has been in multiple visits to Saudi Arabia, and it's our pleasure to welcome you in Medina, I guess, for this time, first time in your trip. So welcome here, and we'll be eager to hear about your presentation. So the floor is yours.
Thank you very much, Mr. Chairman. Thanks. Good morning. Thank you for bringing me back to the kingdom and to this great conference of precision oncology. Here are my disclosures. This is where I work, in a tiny country in the heart of Europe. And you obviously know Vienna because of the history and the culture and everything, but Vienna is also a hotspot in breast cancer. As you know, since 2005, the St. Gallen Breast Cancer Conference has moved to Vienna. Someone called it the largest tumor board in the world. And I hope that in March 25, many colleagues from Saudi will actually join us in Vienna for that meeting. So to the subject, I will focus on checkpoint inhibition. I have been doing research about 25 years ago with immunotherapy, largely unsuccessful. We were doing vaccinations based on dendritic cells and everything, and why this was unsuccessful, I was then at the National Cancer Institute of the United States, is because we didn't understand and we didn't know the concept of the interaction between the immune cells and the tumor cells. And this has now been deciphered, and obviously oncology is swamped away, has been swamped away in the last decade with data with CTLA-4 and PD-1, PD-L1 antagonists. And, you know, this is outside my field, but that's what immuno-oncology did, for example, to melanoma, as you're well aware, from a deadly disease to a well-treatable disease. As breast cancer oncologists, however, we are kind of jealous because it's not working that much like in bladder cancer, like in melanoma, like in lung cancer. And the reason for this is that breast cancer at large is not very immunogenic, and not because the immune cells don't go there and don't attack breast cancer, because we know that we have all these tumor-infiltrating lymphocytes to a variable extent in some diseases, but it appears to be more complex. And eventually, unfortunately, yes, it is more complex because anti-tumor immunity is a dynamic process. It doesn't only have to do with the organism's reaction, but it also has to do with activation, recognition. One of the deadly things of tumor cells is that they can hide from the immune system, as you're well aware, and that means they need to be recognized, which needs to recruit and lymphocytic infiltrate, but that also has to be capable of actually doing something and killing these cells. And that's something that is blocked, obviously, via the checkpoint process. And in the field of breast cancer, we see that the activity of that therapeutic principle largely goes along the molecular subtypes or the main intrinsic subtypes, and everybody knows that obviously immunotherapy works less well in luminal cancers, and if there is a subtype in breast cancer where we see promising results, then it's obviously the triple-negative breast cancer. Unfortunately, and that may be a part for our discussion, things are even more complicated. Because, as I said, even with infiltration, you will see that there is interaction with other treatments. Chemotherapy that is obviously used in some breast cancer patients has an interaction with the presentation of antigens. And patients who receive chemotherapy or who do not receive chemotherapy react quite differently in terms of the activation of the immune system. So I said, okay, let's focus on triple-negative breast cancer. But even there, the situation is not trivial because there is a variety of subtypes within triple-negative breast cancer. And some of them, PARP inhibitors might actually be the better way to go. Some are subject to efficacy by checkpoint inhibitors. And we have to see in the future what ADCs can do in that respect. So let's just briefly review the data. Early triple-negative breast cancer, neoadjuvant immunotherapy, you know the two pivotal trials, which is KEYNOTE-522 and IMpassion 031. And the beauty on KEYNOTE-522 is that it's not only looking at PCR, but also at longer-term outcomes, meaning event-free survival, which was not the case for the Atezo trial. And I think it's important that we can also relate what is the importance of the surrogate parameter, PCR, or any other neoadjuvant surrogate parameter for later outcome differences. And you have seen this data before. This is now almost 5 years old that we saw that first difference in complete pathological remission in KEYNOTE-522. The difference when you add Pembro is about 14%, and it's quite similar as a matter of fact for the Atezo. That was less successful in metastatic disease. What was a big disappointment, because we all speak of personalized oncology, precision oncology eventually, as this conference is entitled. And in our field, when we look for a biomarker, it's not that easy, because at least in some of the initial results, PD-L1 status of the tumors were not really predictive of the effect of anti-PD-L1 treatment. So as you can see, whether the CPS score is low, that's original data from Keynote 522, or it's a little bit high or it's very high, that really doesn't make a huge difference, also as indicated by the forest plot here in this slide. And the reason for that is, at least in part, probably analytical and pre-analytical, because it's not trivial to accurately assess PD-L1 on tumor cells. And there's a number of technical details about the scoring calculation, the cutoff values, which antibodies you are using. Remember, the same was true for HER2, like 20 years ago. And so this is part of the disappointment, I think, that we didn't really figure out the way on the global perspective to have the most perfect platform, most perfect analytical methodology to do that. There's some interesting exploratory data in looking at tumor-infiltrating lymphocytes. And in fact, when we add Pembro in patients with low TILs, then you see that new immune response is, let's say, improved. It's not dramatic, but it's an indication of what to work on in the future. Interestingly, and maybe the more labor-intensive for our colleagues in pathology, but maybe a little bit more accurate parameter for response to neoadjuvant treatment is residual cancer burden. And what you can see from this exploratory analysis for 522 is that in all these categories, you will see rather similar effects there. The true question, however, is there benefit of the checkpoint inhibition beyond PCR? And we have data from 522. Peter Schmidt presented them basically now about 18 months ago. And what you can see is that, yes, if there is no PCR, there appears to be this additional event-free survival benefit. But again, that also happens in patients with a high RCB score. Now, let's look at the latest updates. That's now just a couple of months ago. San Antonio 23, you see that stage 2, you see the same effect. Some, but in absolute terms, minor benefit for PCR patients. And the same is true for stage 3. And when you look at nodal status, again, you will see that patients with residual disease will benefit whether they are node negative or node positive. So to conclude, I think that we see higher RCB scores associated with worse event-free survival. In general, we see higher PCR rate with the addition of pembrolizumab, and we see the reduction of event-free survival events in most RCB categories. When we discuss that interaction between an early response readout, which is PCR, and the event-free survival, you will see, obviously, these are the famous Cortázar curves, but they are not true for all types of breast cancer. So when we look to luminal breast cancer, we know that in general, our PCR rates are much lower. And as a matter of fact, PCR in receptor-positive breast cancer does not very well predict the long-term outcome. And that's actually one of the reasons why we do neoadjuvant chemotherapy. Patients and we are happy about the PCR, but we want to improve the long-term outcome, obviously. And in luminal breast cancer, we see things like, with CDK4/6 inhibitor, that's almost 8% at 5 years. That's a reasonable benefit. And we know that we can do the chemotherapy also preoperatively, and we should do that for all these reasons, also for surgical reasons. But the question is this also true for immunotherapy in hormone receptor-positive breast cancers? And at last ESMO, we have seen Keynote 756. You're well aware of the trial, so that's receptor-positive breast cancers of a certain size, and they were randomized to have the usual chemotherapy plus minus pembrolizumab, and that was also brought into the adjuvant phase. Those results, however, are not mature yet. In terms of PCR, again, we saw some difference. However, notably, this is a smaller difference than we observed in triple-negative breast cancer, and many of us consider it questionable whether that will eventually translate into long-term outcome benefits. Now here, when we look at PD-L1 expression, maybe we improved a little bit. We see that this difference has a tendency to be larger if the PD-L1 expression is higher in this patient, and that's particularly true when you look at estrogen receptor positivity. So among the luminal cancers, those low estrogen expressors, they have, and with a high PDL score, they have a reasonable difference that when you look at the left side of this slide, we might see that translating into event-free survival differences. However, if the PDL is not there, actually that's minute. And it will be a very interesting discussion, and we need some additional data for that to see whether that's worthwhile, the side effects. After all, checkpoint inhibitors are not trivial in terms of tolerability. They will, as compared to placebo, obviously increase the side effect issues. And that's a slide that I'm grateful for to Liz Mittendorf. Actually, about 10 to 15% of these side effects can be permanent. And that's a problem. I mean, we are talking about luminal breast cancer with an excellent prognosis, with a variety of treatment modalities and curable patients. And some of these patients included in the trial look at, let's say, long-term recurrence rate of about 10%. So if we then have toxicity in the ballpark of 10%, I think this is going to be a difficult call and needs to be discussed very well with patients. Just for completeness, also the NIVO data from the CheckMate 7-eval, again, very similar setup, addition of NIVO to traditional taxane-based chemotherapy. And here we see, again, about the same, very similar difference compared to the Pembro. But this is now larger with PD-L1, interestingly. And there are subtle differences also in the assessment between these two trials. But when you compare that also in a more detailed way, you see that if we accurately measure the presence of the target of the checkpoint inhibitor, then we might be able in the future to optimize or in a more optimal way select patients who are appropriate for this treatment. And in summary, I have to say some of the data are impressive. We started using checkpoint inhibitors in selected patients in the place where I work and in many places around the world, but we will have to be better in defining what is the ideal subtype, even in triple-negative breast cancer. We need also better surrogate parameters. I point your attention to a very interesting paper by Antonio Lombard-Cruzak's group and Javier Cortes on how to define a good surrogate endpoint, because eventually we will also want to have on an individual patient basis an early predictor of response. So in summary, unfortunately, breast cancer in general is not very immunogenic. Pembro, yes, increases the PCR rate in TNBC, and it appears to improve outcomes. In luminal breast cancer, the PCR rate improvements are modest, and we need to see the outcome of 756 in terms of long-term survival. And for now, when we counsel a patient, I think we need to balance those effects versus the side effect profile that might not be trivial. And as I said, in the future, I think we will have to better define, and there is a trial, the NeoTract, running, trying to fine-tune the activation of the immune system, also based on the presence of TILs and other parameters. In summary, we need to keep learning. So I used to say this is my office. It's not. It's actually some artwork. And as said, I hope that many colleagues from the Kingdom will join me in March 25 in Vienna. Thank you very much for listening.
Thank you, Prof. Ganan, for this elegant and excellent presentation. We'll keep the question till the end of the session. Now we'll move to the third talk. It's my honor and pleasure to introduce Prof. Joseph Gilgrove. Prof. Gilgrove is a professor of medical oncology at University of Sorbonne. He is the director of the department regrouping medical oncology, radiotherapy, and hematology and supportive care at Sorbonne University. And he is the vice president of the French National Ordinal Commission of Oncology. His clinical and translational research activity focused on breast cancer predictive and prognostic marker. Prof. Gilgrove will give us talk about the next generation sequencing in metastatic breast cancer. Prof, the mic is yours.
Thank you very much. Thanks for the organizing, to the organizing committee and the scientific committee, and particularly Dr. Mervet Mahrous for the invitation. It's always a pleasure to be here in the Kingdom. And I will try in the next 20 minutes to go through the question of the next generation sequencing in metastatic breast cancer. Here are my disclosures. And I will begin with, just to be sure that we are all on the same, I will say, perspectives and looking of what we're discussing. What are we talking about? And just to remind you that two things. If you have an activation of an oncogene, it requires alteration of just one of its two alleles, as you can see here. And usually, it might be a point mutation, it might be a gene amplification, and it might be a chromosome translocation. Okay, these are the three ways we have actually regarding the activation of an oncogene. And the mechanism of alteration are usually heterozygous alteration, and in consequence is a gain of function. On the opposite, if we look at the cancer suppressor genes, the mechanism of alteration is a biallelic, again, inactivation here. And as you can see, it might be an inactivation mutation that you acquired on the tumor cell and you potentially have initially on the normal cell, a large deletion, or some epigenetic deactivation that we might have also. And this is an important point also. The consequence is a loss of function, and here you have several examples. And just moving to what I just mentioned before, the epigenetic regulation of the genes, we have actually several mechanisms, but the two more important is one, the methylation that you might have in several points of the gene that will clearly deactivate, I will say, the gene expression. And the other one that you regulate also on the DNA level, it's the histone as a target and the histone modification. These are the 2 points. This could be explored by the NGS. And this is I wanted to focus on. So now moving to the NGS, what is the history of the DNA sequencing? It's not a very old history when you look at, because the beginning of the history, it's a little bit more than 50 years before with Frederick Sanger and his method. And you have the first, I will say, classical approach with the next generation sequencing, which is about 20 years before. So the only thing that we have moved is the methodology, how to explore the genome and how to go faster and deeper to the exploration of the genome. But at the end, if you use the Sanger method, you might have exactly the same type of information. The only thing is that it will take more times. And NGS is just a question of methodology and the way you might use some new technology to improve faster and better, potentially, the information you want to get as a relevant information to treat the patients. So what does it mean in everyday practice? If we look at the tumor biopsy and the circulating DNA, you might have small NGS panel. You just define that you want to explore 5, 10, 20 genes and 20 alterations that you want to just focus on. You might have the large classical panel that you might use, and you can have whole genome sequencing or whole exosome sequencing. And this is a program that we have actually in France in several platforms in the country, just specifying that we are using this in very particular cases when we have rare tumors, when we have very aggressive diseases in young population, and when the classical NGS panel, smallest one or largest one, do not give enough information, and we think that we might have some interesting information to try to find a new target for these particular cancers. If you look at the circulating DNA approach, you might have also a small NGS panel, which is one thing. The large panel, usually it's not possible. And you have the digital drop PCR, which is interesting because it's just one gene that you want to explore with a few mutations. This is actually one of the ways we can use this approach to explore the estrogen receptor 1, the ESR1 mutation, as one of the targets, of the new, I will say, third approach like elacestrant. So the second thing that you want to look potentially when I mentioned that you will have an acquisition of a new oncogene, it's the chromosomal translocation or the fusion transcript by using the RNA, and then you focus usually on the tumor biopsy, FISH analysis, you know very well from the HER2 history, the small RNA sequencing panel as a theranostic tool, and of course, you can use the classical approach with the large screening RNA-seq as a theranostic and diagnostic assistance. So the next generation sequencing or second generation sequencing technology, they use miniaturized and parallelized platform for sequencing 1 million to 33 billion short reads per run. All NGS share the technical paradigm of massive parallel sequencing via spatially separated clonally amplified DNA templates or potentially single DNA molecules in flow cells. And this methodology allows sequencing to be completed on a larger and faster scale, including epigenetic approaches. It might concern tumor tissue and circulating DNA, and it might be using in an academic way. You might have your own platform on your own institution or commercial platforms that you already know from several companies that offer the possibility to have this type of diagnosis. So now, what are the relevant alterations in metastatic breast cancer? This was a question you asked me. And I will go first to the definition of the ESMO scale for clinical actionability of molecular target, just to remind you that we have these levels, SCAT 1, 2, 3, 4, 5, and the other one. The SCAT 1 is that you have a clear correlation between a target, a theranostic tool, and the clinical impact. It's ready for use in clinic. There is no discussion. The investigational one are under the way. We have several, I will say, information from retrospective analysis, for example, but we need potentially to improve the level of evidence by prospective approaches. And now you have the other type of approaches, hypothetical target, combination development, and at least what we don't know. This was the ESMO approach, but we have exactly the similar one when you look at the ASCO, and some institutions even use their own one, the Memorial Sloan Kettering Cancer Center, regarding the OncoKB approach for the classification of this type of information. So we have several initiatives that have been made to classify the molecular alteration. So what do we have in breast cancer? I will focus on DNA double-strand break repair pathway, receptor tyrosine kinase pathway, ESR1 route, and the cell cycle. So regarding the repair of DNA double-strand break, you know that this is a genetic alteration that we have, and there are several molecules that might be potentially interesting, but I will focus on BRCA1 and BRCA2. At the end, we have a kind of integrative approach using some biomarkers of sensitivity to the PARP inhibitors, and you know this very well from the ovarian cancer history, using the HRD phenotype. You have on the left side a HRD negative tumor, and on the right one an HRD positive tumor, just as a resultant of exploring the capability we have to repair the DNA. And usually, on the HRD approach, you are not just looking on the germline mutation, but also on some somatic mutation that might give this type of HRD phenotype. The biomarker of sensitivity to PARP inhibitors are level SCAT1A. You see that we can use it in ovary, in prostate. I will focus on breast and on pancreas. But interestingly, on breast and pancreas, it's just the germline mutation BRCA1 and BRCA2. We don't use the other one, the somatic mutation, actually, as a standard of care to initiate a PARP inhibitor treatment, and the HRD are not clearly validated in the breast cancer approach. We have several, actually, data from small, I will say, subset of patients that have been treated with somatic mutation when they find potentially some interest of using PARP inhibitor. However, the level of evidence is not enough to consider that we have to use PARP inhibitors in this situation just according to the presence of a somatic mutation of BRCA1 or BRCA2. And we have potentially new players. We have new data with PALB2, for example. So this is for the DNA double-strand focusing question. Now the ERTK channel and the receptor with tyrosine kinase activity, you know very well the pathway splitting in two, the cell proliferation and the apoptosis. And I will begin with the different, I will say, target that we have and what we can look at in general in cancer. You see here, targeting EGFR, the ALK and NTRK fusion protein. You have the RAS-RAF pathway and ERK. This is more for the lung cancer. When we look at the PIK3CA AKT-mTOR pathway, we have several drugs that might be interesting in breast cancer. Alpelisib, that was one, ipatazartib or capivasertib targeting AKT, and for mTOR targeting everolimus that you already know. The question is NGS relevant or interesting? We will see in a few minutes. However, what you can see here is the frequency of the alteration of these different proteins in breast cancer. And when you look on the left side regarding the cell proliferation, you can see that the rate of mutation and alteration is very low on breast cancer, looking at the cell proliferation pathway. When you look at the apoptosis, PIK3CA is the most frequent, about 1/3 of hormone receptor positive disease. When we have very few percentage of mutation of PTEN but higher percentage of deletion, about 2% of AKT mutation, and we don't have clear signal regarding mTOR. That means that when you look at this, the probability that you will find with NGS using largest approaches relevant information to optimize the way you treat the patient is not so clear if you do complete, I will say, NGS more than the 20 or 30 target that you might use in breast cancer. The interesting point is that we know actually that we have an important rate of HER2 amplification in some subtypes. For example, in lobular metastatic breast cancer, when we might have an increasing rate of HER2 mutations, and we don't have any signal regarding the EGFR mutation in breast cancer. The other point that is interesting is that this type of mutation are exclusive. If you have one mutation on the PIK3A, you will not have on PTEN mutation or deletion, and the other one also on AKT. There is one abnormalities usually on this pathway, and they are exclusive. And this is very important when you look at potentially the drugs that are targeting this pathway, and I'm thinking about the new approaches like capivasertib, I will say, approval. The other thing also is that according to the, let's say on the left side, the luminal, typical luminal A subtype of breast cancer, and on the right side, the basal-like or triple negative, you can see that the rate of mutations, looking at this pathway, is pretty different, clearly. Meaning that you will probably use this approach in general for metastatic breast cancer if you use NGS, but the result that you might have will also potentially orient you if you have some tumor heterogeneity to know what is a clone that actually is the more aggressive one that you have to use for the treatment. And last but not least, as I mentioned before, the RAS-MAPK pathway in breast cancer, you see that the rate of mutation is very, very low in general, considering that even if you go using NGS trying to explore this, one, it's pretty rare, and two, the level of evidence that it might work, we will see it, it's also very low. HER2, it's important to just clarify that this rate of mutation, 2-3%, is very important to find because you have targeted treatment that might work here in metastatic breast cancer. We have clear signals with antibodies, with ADC, and also with tyrosine kinase inhibitors. Same thing regarding the PIK3CA mutation. Yes, it's interesting to integrate. Same thing actually potentially with AKT, with the new and capivasertib drug, and new alteration that we might find regarding the PTEN and all this pathway. Third type of abnormalities that might be interesting using NGS approach is trying to look at the emergence of the ESR1 mutation. You know that the tumor metastatic situation in endocrine resistance, you might find about 20 to 30% of these tumors that are with ESR1 mutation, which is totally different in the early stage. Actually, several data have shown that it's between 0 and 1 or 2%. So it's a very low rate of ESR1 mutation that you might find because it's a very probably small clonal abnormality that you have at the beginning, and using the pressure of the treatment that you give, you will have the emergence of this clone of mutation. And this is what you might see regarding the mutated SR1 clone. If you look at the heterogeneity space on the primary tumor and using the classical approach with, I will say, the paraffin-embedded approach on the tissue, you might have a signal that is negative. If you look at the circulating DNA, and if the clone is prominent and explaining the progression of the disease, clearly it's more relevant to use circulating DNA here than you're using some tumor or metastatic biopsies that might be less informative in general. So CDK4/6, we know that it's clearly very important to use these drugs in metastatic and probably now in early breast cancer. We know the pathway and how it is regulated. We know also that we have some clear overexpression of amplification of some of these cyclin that might be interesting to potentially use the drugs. It's more out of the field of breast cancer, but this is one of the possibilities that we have potential even on some triple negative disease, and there are some trials ongoing looking at that. The ERBB1 gene mutation and deletion that are clearly one of the predictors of resistance to CDK4/6 inhibitors that we usually don't screen and don't look at, but this is one of the points explaining the primary resistance to the CDK4/6 inhibitors. And when you go back to all this information, and you try just to resume and look at what happens, you can see that according to the NCCN, according to the ESMO, according to the ASCAT classification, at the end, we have just a few number of alterations that are considered to be clinically meaningful for everyday practice. So advances in biology have made it possible to identify sensitivity and resistance factors to treatment already used or new treatments. This was the first step approach, trying to optimize the way we treat the patient with the drugs we have or developing new drugs. They are still limited in the fields of breast cancer, and the overall alteration in other cancer seems to be less interesting in clinical practice because it's with low frequency and non-theranostic comparing to other one. So at the end, what is the relevance in practice for metastatic breast cancer? These are the guidelines that we have provided with the ESMO. They have to be updated clearly, but you see that looking at the marker, the level 1 of marker are not NGS, they are immunohistochemistry, estrogen receptor, progesterone receptor, HER2, and after that, you might use several one like germline BRCA mutation, PALB2 for example, or other one that have to be integrated in the future, like the activation of PIK3CA AKT PTEN pathway. The second thing is that we have done a few years before under the initiative of Fabrice André and Yvan Biech from Gustave Roussy Institut Curie, a trial addressing the question of after in metastatic setting, you treat the patient, then you have NGS and CGH array approach, and if you have induced response or stable disease, then according to the presence or not targetable molecule activation, you will have a randomization targeting PIK3CA pathway, potentially other type of targets, or if you don't have any other targets, using immunotherapy. It was in fact durvalumab compared to maintenance therapy, chemotherapy. And what we have seen here is on the overall population, you have about 250 patients, the SCAT1 to 2 population of this population, 115, between about 40%. And you see that triple negative HER2, very small number, but because we have very small number of patients here. Overall population and the type of SCAT classification, 1, 2, 3, or 4, we have in SCAT1, 2 population, majority were SCAT1 and a small number of SCAT2. And you have here the type of alteration that we have seen. Of course, some amplification of cyclin CCNDAN, but we have the classical one, PIK3CA, and anything. It is just meaningful when you will consider on the upper right side those that have SCAT1 and 2 alterations. Then you have an increasing of the PFS, and this is particularly true in the BRCA mutation. So a long trial, a complicated trial, to at the end of the day just concluding that if you have... It was published pretty recently by our Spanish colleagues in Lancet Oncology, just looking in an overall population of patients that have been treated, what is the impact of the NGS? And you have the different genomic alteration that you might find. It's not only on breast cancer, and the conclusion was that it's useful mainly for non-small cell. For the breast cancer, use the classical approach is the most important. You could use NGS, but clearly not routinely. It will not change anything. And this has a curves showing that according to the different type of cancer, you will not have a particular impact.
You have to conclude.
So this is my last slide. The use of NGS in metastatic breast cancer is important. However, as a first approach, it should not get the anomaly of proven interest, and I mentioned it here, and it could target a larger spectrum in a strategy of clinical trial screening and access to innovations, but not routinely. Thank you very much.
Thank you. I think we have very important announcement from our organizers. All the breast satellite symposium will be moved to after prayers, Juma prayers, so everyone can attend the Juma prayer, and we can have only 1 or 2 questions to conclude this session for the same reason. Thank you for your understanding, and we'll start sharply at 2 p.m., inshallah.
Yes, everyone, we'll try to come a little bit earlier, like at 1:30, since we delayed all the satellite symposium. So we'll have the 3 satellite symposium, and then we'll go for the 3rd GI malignancy. Thank you. See you soon.
Okay, thank you very much. We'll meet at 1:30, inshallah.
Enzyme concentration
بسم الله الرحمن الرحيم. أي.
Good afternoon, everyone. So we'll start after noon session, and it's a pleasure it will be 3 satellite symposium in a row. Dr. Fahad Al-Maqbil on SERB satellite symposium moved earlier because there's a flight commitment. So he will be presenting with us the SERB sponsored satellite symposium, and he will be talking about carcinoid tumor diarrhea. Dr. Mukbil was presented earlier, so with no further delay, he will start his presentation. Thank you.
Thank you, Dr. Amal. Assalamu alaikum. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على أشرف الخلق محمد عليه أفضل الصلاة وأتم التسليم. So this is a satellite lectures that's sponsored by SERB, and would like to discuss in the next 20 minutes something related to the quality of life. What we present yesterday and today, most of our talk usually as a medical oncology is something about survival, or either overall survival or progression-free survival, or but however, this mainly is about quality of life. So those are my disclosures. So I will walk you through 3 main objectives, some of them a little bit basic and some of them more than that. So what's the carcinoid tumor? And we'll talk about the spectrum of carcinoid syndrome, and main topic and the main target of this satellite lectures is the diarrhea secondary to carcinoid syndrome. So usually carcinoid syndrome is only 10% of all the carcinoid tumor. So we have carcinoid tumor, which is almost, I can say, 1 to 3 per 100,000. It's not that common cancer. We have it in the kingdom, and usually from mid-gut. So you have out of those 10% that they have carcinoid syndrome. Usually this, if there is a metastatic to the lung and liver, and the syndrome is as following. You have the patient with flushing, like pale, and redness, diarrhea, and we'll discuss more about characteristics of the diarrhea, tachycardia, hypotension, and bronchospasm, as well as right-sided heart failure. Based on the location of the carcinoid tumor, you will find the age that most common. Like let's say the youngest is usually appendix. They have carcinoid tumor between 40 to 50 and representing 12% among all the carcinoid tumor. The majority is either from the rectum or small intestine, and the presentation is a slightly different based on the cancer site. So we have different spectrum of the carcinoid tumor depend on the site mainly. After that, it will have a different presentation based on the site, as well as the percentage of metastatic initially different between one site to another site. So let's talk about more basic, about pathophysiology. When you will have carcinoid syndrome, why, to be more clear. So there will be more circulation or secretion of serotonin to different organ. We'll start from the heart, so there will be high blood pressure, hypotension, and tachycardia. In the lung, it will affect the breathing, and they will have a more bronchospasm. And in our main topic in this talk is the gut. So more serotonin secretion, more mucus secretion, more paracelsus movement, and more diarrhea. So what about diarrhea secondary to carcinoid syndrome? just specific, only these symptoms, diarrhea, usually it's 80%, majority of the carcinoid syndrome, they will present with diarrhea. Usually this diarrhea will be explosive, watery, multiple times, more than 3 or 4 times. And this symptoms is really affecting the patient's quality of life. There will be more hospitalization. It's almost twofold of hospitalization if the patient having carcinoid syndrome with diarrhea. The health cost and the financial toxicity to the health organization is 1 to 2-fold than the patient without diarrhea. What the pathophysiology, already I mentioned that the transient gut faster, it's almost 6 times the usual that we have it in the small bowel because of serotonin, as well as the peristalsis movement of the colon. Again, there is other causes other than if I have a patient with carcinoid tumor presenting with a carcinoid syndrome, I have to keep in mind other possibility or other differential diagnosis. The patient usually they have surgery, mainly they have bowel resection. So I have to keep in mind, could be the diarrhea is not because of the carcinoid syndrome, could be because of the short bowel syndrome or bile salt malabsorption. If the resection is related to the pancreas, also there will be enzyme deficiency. And we have to differentiate those, or we have to keep it in mind, so we have to work for the proper workup as well as the proper treatment. Also could be irritable bowel syndrome because the patient having chronic disease. Now, there is other also syndrome other than carcinoid tumor. We have to keep it in our mind, like Zollinger-Ellison syndrome. They are presenting with plus minus the same spectrum of syndrome with part of it diarrhea. So also, again, we are treating carcinoid tumor or carcinoid syndrome with a specific medication. Those specific medication also can cause diarrhea, like everolimus, like octreotide, like Sutent, as well as bezobenib, based on what you can see in the table with the multiple retrospective and prospective trial that showing a range between 20 to 30% from the treatment that you use for carcinoid tumor can cause diarrhea. Usually the diarrhea, more than 50, it's a mild, 1 to 3. However, we have a big portion of a patient to some extent, if you can see 32, 9, and 4, they have something significantly or grade 3 or 2 and more of diarrhea, between 4 to more than 10 times. And this moderate to severe, for sure it will affect the quality of life of the patient, causing sleep disorder or insomnia, fatigue and anxiety, depression, as well as I said, economic burden to the health organization in general, if not treated in proper way. So usually we manage those patients, and algorithm is easy. I have to look for general treatments, and I will discuss it in detail, and I have to look for specific targeting etiology-driven treatment. So in general, we have to look for dietary modifications, surgical cytoreductive, as well as targeted therapy to the liver mainly, and PRRT, one of the options that available in the last 4 or 5 years, as well as the old gun or the old kids in the block, which is the somatostatin analog or octreotide and lenalidomide. So dietary modification, what I mean by that, we advise the patient to avoid amino acid glucose, as it can help around 50% of those. Also advising the patient to have small meals, avoiding cheese and other food that have high amine can cause diarrhea. The other is the surgical resection. By 80 to 90%, you can have a palliative surgery that can help the patient and decreasing the serotonin secretion, at the end decreasing the diarrhea. So what about targeted therapy to the liver? If the resection is not an option in the table, we have TACE, TARE, radiofrequent ablation, and in general, those there is no superiority of choosing radiofrequent ablation over chemoembolization or transradioembolization. Now, one of the options that I mentioned is the PRRT. BRRT was based since 2017 based on one of the landmark study, NATARD trial, NATARD 1, which is phase 3 international trial, randomized the patient to the experimental arm, which is lutetium dotate with best supportive care, mainly octreotide, and the control arm, the standard that we usually offer to the patient, which is the octreotide. The primary endpoint was BFS, the secondary was the usual. And it was positive and regarding BFS and OS, and you can see in all subgroup analysis favoring the experimental arm if we add BRRT to the patient with carcinoid tumor. And the adverse event in general is not that toxic, and the toxicity profile is not high to the patient. Now, the main gun, the main medication that we use it in most, and if not all of the hospital, is the somatostatin analog. We have in general two. We have the octreotide, the short-acting. We use it for to control days. And we have the long-acting octreotide, as well as the alternative or the new is lanreotide. There is a difference between those, and we will discuss it in the next few slides. And that was that show that there is improvement in both the 5-HAA reduction and the serotonin in the urine, as well as the controlling the diarrhea, and that was based on multiple studies, different either retrospective or randomized trial. Now, this is one of the new medication that got FDA approved in 2017, and this is the sponsor by this satellite lectures, the SERP, is the triophene hydrochlase inhibitor. And I will discuss it in detail. We have other option for refractory diarrhea other than this enzyme inhibitor, bile acid sequestrant, as well as ondansetron. So what is the Telostrat? Is based on two well-known trial, phase 3 trial conducted in the last few years, the Telestar and Telecast. They have, to some extent, same methodology to give the patient this enzyme inhibitor in different dose, 250 or 500, as well as the octreotide, and to see the difference for those patients who had refractory, more than 4 times per day diarrhea. And they want to look for the efficacy of decreasing the diarrhea, improving the quality of life of the patient, and both Telestar and Telecast was a positive. If you look to one of those that I would like to share it with you in little bit detail, Telecast is the international randomized trial, as I said, phase 3, choose those patients with less than 4 bowel movement without octreotide, and those with more than 4 bowel movement, they have somatostatin analog, and they randomize them or double blind for 12 weeks. Then after that, up to 36 weeks was open label extension. And they randomize it, as I said, to 3 arms, the 250 telostats, 500, which is, by the way, oral medication, or just only placebo. And they look for the safety and efficacy, as well as if there is any adverse event. So there was no significant adverse event in general, and the 500 was equal to 250. However, the 500 maybe it's a slightly more side effect in mild. However, in moderate and severe, the 250 was more having side effects. And which kind of side effect we are talking about? Anemia. However, it's not that high in form of grade 3 or 4, as well as some kind of GI toxicity. So this is a summary for the medication that we use it as a clinician. We have the old medication, somatostatin analog, either octreotide or lanreotide. As I said, the short-acting octreotide, we can use it more frequent per day, and sub-Q, mainly octreotide. Long-acting is intramuscular, and it's really compromising a little bit the quality of life patient, as it's Q4 intramuscular, and we have the lanreotide, which is more easy administration sub-Q, and we have the new medication, the new enzyme inhibitor, that can be given oral and shows improvement in the diarrhea. So if we look to the NCCN guideline adapted after 1 year from the FDA approval, in 2018, they look to the first line, which is resection, resection, resection. Otherwise, we have to use somatostatin analog, either octreotide or lanreotide, in the first line. If the patient still progressed, I have other option. I can use somatostatin analog. I have BRRT, as I said, everolimus, and targeted therapy or local control to the liver. For refractory disease, we have this a new medication to some extent, although it's approved in 2017 by US FDA. And we have the local control of the liver. Thank you.
Thank you, Dr. Fahad. I think we will move to the second satellite symposium. It will be by Novartis. Yeah. Dr. Amin. Yeah.
Assalamu alaikum. So I would like to thank the organizer to invite me to participate in this meeting. Special thanks to Dr. Amal and Dr. Ziad. So this is the satellite symposium by Novartis. I would like to thank them for inviting me to moderate this session. It will be about the mastering CD4/6 inhibitor, key considerations for successful treatment in metastatic breast cancer, AR-positive, HER2-negative breast cancer. So this will be presented by Professor Gunnant. Michael Gunnant is a professor of surgery at the Medical University of Vienna, Austria, and he's the president of the Austrian Breast and Colorectal Cancer Study Group that conducted many pivotal early breast cancer trials. He's regularly giving lectures at international meetings, including ASCO and San Antonio, and hosts the St. Gallen International Consensus Conference in Vienna since 2015. Please, Prof. Gunnant, the floor is yours.
So thank you very much for the introduction. Hope you're not too tired after the lunch break and the prayers. Thanks again for bringing me to Medina and to this great symposium. This afternoon I'm going to review a little bit with you the CDK4/6 inhibitors that have revolutionized our treatment of metastatic breast cancer. So here are my disclosures, and it's about a decade now that we are using these trials in these large pivotal trials that all of you are well aware of. And you see that Paloma 2 was the first trial. And then in terms of the reporting of the overall survival data, because eventually this is what matters to our patients with metastatic breast cancer. And I will very clearly admit that in the beginning I thought, it's a class of drug and they're all the same. And from the initial result presentation, it appears to be the fact. But particularly in the last 18 months, I think we have seen some important differences that have, in many places around the world, changed the practice quite significantly. So let's dig into this with some more detail. And obviously, when we have a class of drugs that has subtle differences, then it's also important to look at the small print in the clinical trials and in the publication in terms of the patient population, in terms of the trial setup. And these trials vary. The Mona Lisa set of trials MONARCH 3 didn't really have early relapses, despite the fact that abemaciclib was described because of its multi-kinase activity, that it might have, actually even some single-agent activity was described. But it's important to keep these differences in mind, because after that initial wave of primary endpoint reports, when they looked all the same, we have now seen quite interesting differences in the overall survival results. And I'm not sure you can, oh yes, you can see that. Basically, the Paloma 2 and Paloma 3 are struggling in defining an overall survival benefit. And I think we need to consider together a little bit what could be the reason that ribo in all three trials shows significant overall survival benefit. Abema in the MONARCH trials struggling to show statistical significance, but there is a clear difference in these trials. And for Palbo, disappointingly, this appears not to be the case. And why is that when we still see rather similar results in terms of difference in the progression-free survival? So let's now first look at the endocrine sensitive population. That's obviously in the first line setup, MONARCH 3, Paloma 3, and Mona Lisa 2. And you see that 12 months of difference, 2 months of difference, 12 months of difference, exactly what I described. The situation is a little bit more blurry for Mona Lisa 3 and Mona Lisa 7 because there have been sensitive patients in there. And the special thing about Mona Lisa 7 is that it's dedicated to premenopausal women, which in many parts of the world comprise a large proportion of breast cancer patients. So this slide just again summarizes. We now have mature data on all these trials, and we can assess and discuss the differences. When you move to the second line, or what we would consider endocrine resistant, again with Mona Lisa 3 and 7, there were some patients included in there, but for the others, it's MONARCH 2 and Paloma 3. And again, you see a trend, just 5 months for Palbo in that, not significant, 6 months for Abema, and almost a year in the Mona Lisa trials. And that is a difference that matters to patients, and it has led to a change of practice in my institution. A patient who needs to be put on a CDK4/6 inhibitor nowadays will have ribociclib, particularly because we don't have ribo not yet available in the early breast cancer setting, so those patients will receive Abema. What can be the reason why seemingly similar class of drugs produce such different overall survival results? And I think we do a little bit of translational research here. You know, we keep saying CDK4/6, like that would be all the same. It's not. CDK4 is different from CDK6, and as you know, it eventually addresses cyclin D1 and cyclin D2 in the cell cycle. And when you look to the laboratory, you will see that the growth mechanism of breast cancer cell lines, of the majority of them, is very much depending on cyclin D1, which is the CDK4, whereas the CDK6 cell lines are more hematopoietic in origin. And once you realize that difference, then you don't wonder why, for example, usually we see more significant neutropenia with palbociclib in either setting, and we see less of that and potentially improved anti-tumor activity with ribociclib and abemaciclib. And you can actually see that in a very nice presentation by Richard Finn on progression-free survival in Paloma 2 by CDK4 expression, and you have the feeling that these high expressors are associated with what we would call endocrine resistance, or at least not the perfect addressability of that pathway. And that's the same in an animal model again. So when you use knockout mice, then you can clearly see that ribo and abema are more active against CDK4 than CDK6, whereas for palbo, this is pretty much an equality. Also, when you look at the molecular targets on the cell level, you will see that there are differences. The different kid on the block in this dimension is abema, because abema has a lot of interaction with other kinases, which, by the way, is the reason that it has some limited single-agent availability, because CDK9, CDK7, CDK2, it's not very pure, so to speak. In the future, we will have more targeted CDK inhibitors against 2, against 9. Abema kind of a little bit of a machine gun. It hits many of them, which is one of the reasons for the diarrhea that you will not see with ribo and with palbo. In that respect, ribo and palbo are very similar. They are very specific for CDK4 and 6. However, palbo, both kinases at the same level, ribo, a little bit more activity on the CDK4 side, and there's a lot of research meanwhile, and actually it has been created in addition to the basic research that now we need to explain why are we seeing these differences. Even more so in the adjuvant setting. You know that I was one of the global co-chairs of the adjuvant palbociclib trial, the PALLAS trial, which unfortunately, to our great disappointment, was outrightly negative, whereas monarchE and NATALEE show benefits for ribo and abema, respectively. So, again, another essay, ribo and abema targeting CDK4 more than CDK6, whereas palbo rather similar in that. And one of the advantages of ribo here is that the on-target inhibition in terms of drug binding is maximally among the 3 drugs. By the way, there's a 4th drug, talposeglip. It's not available in our part of the world. It's a Chinese agent published in Lancet Oncology, very similar results to what we have seen, with our 3 drugs. Now let's try to translate this a little bit to the clinical observations. The population for the overall survival readout, I would say, is reasonably similar. And what strikes you on this slide is, yes, may have been lucky or not, but all the 3 Mona Lisa trials from the very beginning reported statistically significant overall survival benefits. Personally, to be honest, I was not so sure about the early reports. The Mona Lisa 7 for the premenopausal patients specifically was very convincing. And many of you may have seen Dick Finn's presentation at ASCO 22, or Paloma 2 simply didn't show a difference there, which was rather disappointing. And for monarchE, we had to wait until the last San Antonio to eventually find that difference. However, not a statistically significant difference. And that's interesting because in the primary endpoint, you see they are very similar. This is what caused many of us to believe they are interchangeable and we just use the side effects but not the efficacy. I'm just going briefly again here. This is the pivotal trial, Paloma 3, excellent progression-free survival, but overall survival simply, and not so much of a difference and no statistically significant difference. Monarch 2, you know the trial, progression-free survival, again, hazard ratio 0.55. We were thrilled in the field of luminal breast cancer. I mean, after the aromatase inhibitors, the difficult-to-use everolimus, we didn't think there's too much of innovation coming along. But these hazard ratios are like in the HER2-positive subtypes. So that was very convincing. And when you look at overall survival, again, a bit struggling. Something there, hazard ratio 0.76, in the last analysis then 0.79, borderline significance, I would call that. As compared to Mona Lisa 2, from the very beginning, a statistically significant difference. And also when you look into subgroups, which we obviously all do already only very cautiously, but you see that eventually the main effect, everything is scattering around the main effect. And this is, and I like such detailed data because it helps us in our clinical decision making, in our counseling and consulting patients. This is even a conservative difference because when you look what happened after the first progression event, obviously those patients from the non-ribo group had a higher likelihood to receive a secondary CDK4/6 inhibitor. So whatever we observe in terms of difference of the overall survival is a conservative assessment of that because the placebo group has been treated with more active treatment afterwards. This is an endpoint that is increasingly important to patients. I'm not sure, you might have read the Lancet piece by Fabrice André and others 2 weeks ago about what should the future endpoints in clinical trials look like. And the outright request was, let's not use anything but overall survival and patient-reported outcomes, and time to chemotherapy in the field of hormone receptor-positive breast cancer obviously is something that is very important for patients, very important for families, and an important patient-related effect. So postponing chemotherapy, I think, in addition to the overall survival benefit, is a very strong argument to use a specific measure. Let's talk a little bit about safety. Yes, there's no free lunch, as the Americans say. Our patients sometimes pay a price, and it's our job to kind of balance this against the benefit, but also to help our patients to do that. What you can see here in this trial is that those reductions are eventually frequent with CDK4/6 inhibitors, but they are also possible. And when you look at, and specifically now for ribo, neutropenia, we know that. We knew it from Palbo. We have in the early breast cancer trials almost 30% of treatment discontinuation. In Pallas, it was 46%, 30% in Monarch E, and 28% in the Natalie trial, because we need to give the bone marrow some time to recover. Yes, we have transaminitis. That is usually mild, that usually goes away. The specificity about the transaminitis is it does not start in the beginning, or not necessarily. So it can occur later. You need to keep your patients under control. And then there is the QT interval story, and I'm not sure the field of oncology would have learned about QT intervals without those pivotal, actually was one poor patient put on one of the first ribociclib trials, because QT intervals prolongations is a very frequent event with antidepressants, with many other drugs people are using, but as we are obviously very safety oriented, it needs to be watched. We need to do an ECG. As we saw in the adjuvant setting, the issue more or less goes away when you reduce the dose to 400, and usually it's well manageable, but it is a consideration when putting a patient on treatment. When you look what this does to the outcome when you reduce the dose, I think in general we can say, and that's something we also saw, for example, with everolimus, and we sometimes see, interestingly, not with aromatase inhibitors. So aromatase inhibitors in the early setting are always sometimes difficult to take, and when you switch, the benefit over tamoxifen goes away. There's a very interesting analysis of the Big 198 trial to that end. But here in the metastatic setting, when you start at the right dose and you have to do a dose reduction at least once, maybe just for 2 weeks or for 4 weeks, then you will still see the overall survival benefit, which I believe is very reassuring. I was already praising Mona Lisa 7 because that's the pre- and perimenopausal patient trial, and I always encourage companies to do trials also for young patients, because on a global perspective, young breast cancer patients are actually the majority. It's just in aging Europe and the United States that people sometimes believe breast cancer is a disease of the elderly. This is not true in Asia and in Africa and not even in the Middle East. You know about the design, obviously, also of Mona Lisa 7. And this is a summary here showing again, all the pivotal trials and whether there was a statistically significant benefit or not. And I think that's, when you look at it in the totality of the evidence, is a pretty convincing argument to use ribociclib in that situation. As I said, I consider the Monarch over survival stuff a little bit unlucky, but that's how it is in clinical trials. Sometimes you are lucky, sometimes you are less lucky because the level of significance was a little bit different. And that's true for first line, and it's true for second line when you compare the three drugs. Now, what does this lead to in summary? This is the ESMO magnitude of clinical benefit scale, and you see that based on the requirements there are now, and this has completely changed in the last 2 years, subtle differences in the level of recommendation, a lot of it favoring starting new patients on a ribociclib combination based on the consistency of the overall survival benefit that the other twos are kind of struggling, particularly Palbo, more or less no overall survival benefit, and Abema, as I said, some, but not really statistically significant. We have seen exploratory analysis, real-world analysis, but as a clinical trial aficionado, I have to tell you, whatever is there in terms of a prospective randomized setting, to me, is always more important than any other report. So, again, in terms of efficacy, a lot of arguments for ribo. Let's just briefly review the safety data in a little bit more detail. We know...
Prof. Ganant, only 2 minutes.
Yes, I will make that. So neutropenia, a little bit less with Abema, a little bit more with Palbo. Overall, it's manageable. You all have experience with these drugs and how to do it. We now know that this type of neutropenia, because it's just a stop sign to the hematopoiesis, is less difficult to treat, basically by pausing or dose reducing. So nobody died from it, nobody died from transaminitis, and nobody, fortunately, in any of the Mona Lisa trials died from QT prolongation, which led to the inclusion of the ribociclib combination into the NCCN guidelines, as well into the most recent living ESMO guidelines. 1 minute 50. Thank you very much for your attention.
Thank you, Prof. Please join us here for some discussion. Yes? Is that what?
We'll have your session.
Okay.
So our next speaker is Dr. Amin Tijani. Dr. Amin is a consultant medical oncologist at the National Guard Hospital, Medina Munawwara. Dr. Amin is going to talk to us about the updates in the management of HER2-low breast cancer. After this satellite symposium, which is sponsored by ASRA, we'll have a Q&A session for the whole breast precision in breast oncology for a couple of minutes. So Dr. Amin, the floor is yours.
Thank you, Dr. Athar, for this introduction. But this is not my slides. Maybe the slides are different. Not working, sorry. The slides are not working.
Do we have anyone from technical support? There's no slides?
مالك برزنتيشن انت؟ لا ليه؟ ما نزلته عندي شيء. ما نزل.
So why don't we open the question and answer session? Professor Grant is with us, and we are very lucky and very grateful to Dr. Nikki Levitt. She's also with us. So please go ahead till we fix these technical problems. Any questions from the audience regarding precision oncology in breast? Okay, may I ask Professor Grant? You know, in the neoadjuvant trials, that we have some, you know, clarity about the definition of the ER, PR, you know, positivity, because we know that those who are less than 10% really behave like a triple negative, and we treat them as such. But they were included in the Pembro. So do you think that results could be explained based on that?
Excellent question, and I would think that I have the same suspicion. We had that one slide I showed where you also see the ER content together with the PD-L1, and obviously that's the subset of patients in the so-called receptor positive that functionally might not really be receptor positive. So I fully agree with you.
Any questions for the...
I have one
yeah,
question.
go ahead, Amin. If you have
Yes.
a question.
Yes, so the usual question that how we can choose by all these different CD4/6 inhibitors if we have all the medications. We know there is difference in toxicity and the data you presented about the overall survival for the ribociclib. So in the clinic, how you can choose between them?
Yeah, that's obviously the crunch question daily. I can just tell you what we did at our center. Traditionally, we have been using Palbo because we were running the adjuvant trial. We had a lot of experience with the drug. We learned how to use it. We learned to withstand the neutropenia, not being scared, and the patients and the families not being scared. And then, you know, basically it was at ESCO 22 when Dick Finn presented that, to me, alarming data that such a benefit does not translate into overall survival. And then there came the negative results from the early breast cancer setting, Penelope B, Pallas. And we kept using Abema for, and that's what we still do, in situations where we would assume that there is a resistant, early relapse, short duration of first-line treatment, something like that. And we now use it in the adjuvant setting, as I explained, because we still don't have access to ribo. But with that convincing overall survival benefit in all three trials, we have completely shifted to starting new patients in general on AI or fulvestrant plus ribo, with exceptions. If someone has severe cardiac comorbidity, we might consider else if a patient, but that's a small proportion. So that's maybe 10% of patients who are frail, who have huge comorbidities, where we want to have an easy drug, where maybe if the lady is like 82 years old, the overall survival might not be as important as in a 70-year-old. So that's how we do that, and nowadays at least 4 out of 5 of our patients will start on ribo.
I have another question about using it post-progression. You know, there is some trials. I think there is maintain trial and space trial. So have you any thoughts about post-progression of CD4/6 inhibitors?
I think that, you know, the maintain trial results are known to you. As a matter of principle, as a researcher, I would think CDK4/6 inhibitors in responsive, slow-moving, non-mutated disease are good candidates for treatment beyond progression. Why is that? In the laboratory, when you treat mice with slowly growing receptor-positive tumors and they develop resistance, you just stop the treatment for 4 weeks. And if the model is slowly enough that the mice will survive, you can just restart it. So this is the stop sign can be put on and off, and on and off. It's a matter of principle, different from chemotherapy. However, having said this, if you have mutated disease, PI3 kinase mutated, ESR1, now with all the new data you will present on the ADC, I think we still have to find the optimal path for an individual patient.
I think your slides are ready, Dr. Amin, so maybe we can proceed with your presentation.
Thank you again. So my topic will be about the recent updates in management of HER2-low metastatic breast cancer. First, I would like to thank AstraZeneca for inviting me to present in this satellite symposium. So this is a disclaimer by the company. And this is adverse events and product quality complaints. So my agenda, I will speak about the spectrum of HER2 expression and its clinical implications in breast cancer. Then I will speak about HER2-low definition, and then data on HER2-low breast cancer treatment, concentrating on DESTINY-Breast04, and then I will conclude my talk. So about 15% of breast cancer are considered HER2 positive. And we know that HER2 positive is a validated therapeutic target, and HER2 gene amplification and or HER2 protein overexpression is linked to a more aggressive phenotype. Traditionally, we look to HER2 as HER2 positive or HER2 negative, and tumors lacking HER2 overexpression or amplification are collectively defined as HER2 negative tumors. If we look here to the HER2 negative by the immunohistochemistry stain, those include IHC0, IHC1+, or IHC2+ plus negative FISH. And we know traditionally there is no any approved anti-HER2 treatment for HER2 negative disease. So there are two different treatment algorithms based on the HER2 receptor status. So either HER2 positive, and those definitely will benefit from the anti-HER2 agent, and those with HER2 negative, which lack HER2 overexpression and HER2 pathway activation, and this is historically not clinically actionable with anti-HER2 agent. So how we can treat HER2 negative metastatic breast cancer? And this is mainly the hormonal receptor dictates the treatment algorithm for HER2 negative breast cancer. For hormonal positive disease, and this is constitute up to 70% of metastatic breast cancer, And these are generally more indolent, have a median survival around 5 years, and mainly metastasize to bone and lymph nodes. This is mainly responsive to endocrine treatment. Compared to the other side, for the hormonal negative, which will be triple negative disease, about 15% of metastatic breast cancer, and this is more aggressive, median survival around 2 years, and mainly metastasized to organs, to visceral organs and brain, and there is no response to endocrine therapy, and by the end, the treatment is palliative. You can see here, this is the ESMO guidelines for management of HER2 positive, for hormonal positive, HER2 negative metastatic breast cancer. And as you know, the treatment mainly is a hormonal treatment with a CD4/6 inhibitor in the first line. And then if the disease progressed, so we'll consider other targeted therapy with hormonal therapy. And after progression, after several lines, so we'll consider chemotherapy for those cases. And this is most hormonal positive HER2 negative patient receive first line CD4/6 inhibitor, either palbociclib, ribociclib, or abemaciclib, with approximate progression-free survival of around 2 years. Several endocrine treatment-based strategy can be used in second line and beyond, and most patients end with receiving at least 2 lines of hormonal therapy, and after that they will start chemotherapy. And after they progress on hormonal therapy, those will be endocrine, exhausted by endocrine treatment, so the treatment will be single-agent chemotherapy in a sequence, and we know the progression-free survival is worsened by each subsequent line of chemotherapy, and the objective response rate will be low. Regarding triple-negative disease, the outcome are even worse compared to metastatic, compared to hormonal positive. The overall survival around 2 years, and the treatment is mainly chemotherapy or adding immunotherapy for those with PD-L1 positive. And after progression, we can give single-line chemotherapy or sacituzumab govitecan. So is HER2 low breast cancer a new subtype? So HER2 is a subset of HER2-expressing breast cancer not addicted to HER2 or HER2 that derive benefit from targeting this receptor with antibody-drug conjugates. About 40–50% of all breast cancer are HER2 low cancer, and that means IHC2 plus non-amplified or IHC1 plus. But the upper boundary is clear for HER2 low, that we need to do a FISH analysis, and if it came positive, so this will be HER2 positive. If negative, this will be HER2 low. But when we look to the lower boundary, it is actually, it lacks a gold standard reference, and the percentage in the low intensity staining is different, especially here for IHC0 negative. Either we have no staining is observed, or membrane staining that is incomplete and is faint or barely perceptible and in less than 10% of tumor cells. So this, if there is a pathologist here, he might tell us more about this. So what is the practical definition of HER2 low breast cancer? And HER2 non-amplified tumors that show HER2 low expression on any prior specimen in course of the disease. Because as you see here, in the primary tumor, HER2 low patients might change to HER2 negative 0, or HER2 negative can change to HER2 low or HER2 positive. And here around 80% of HER2 low, according to the practical definition, so the rate of HER2 low tumors increases progressively with each additional biopsy. And also HER2 low is unstable. There is multiple studies have confirmed the instability of HER2 low expression. The reason is unclear, but may be multifactorial, like pre-analytical factors, HER2 expression heterogeneity, or biologic evolution of the disease. So there is a novel quantitative HER2 testing assays may improve the capabilities to predict the activity of anti-HER2 antibody drug conjugates, unlocking the full spectrum for HER2 expression. Is it a distinct prognostic entity? There is a multiple studies conducted to evaluate the prognostic role of HER2 low expression. Most studies found there is no overall survival difference in HER2 low versus HER2 zero, regardless of hormonal expression. And you can see here, all the study, there is no overall survival difference, except we have to show significant overall survival difference between HER2 zero and HER2 low. So what about the evolvement of treatment? This is a study which is a phase C trial conducted to understand adjuvant trastuzumab is it beneficial in HER2 low disease. And in this study, there is no benefit of adjuvant trastuzumab for HER2 low patients, those who received chemo with trastuzumab and those who received chemo without trastuzumab. There is no difference between the two groups. Also, TDAMN showed little activity of in HER2 negative metastatic breast cancer. So we will come to the trastuzumab deruxtecan in a HER2 low metastatic breast cancer. And this is TDXD is a HER2 target antibody drug conjugate with 7 attributes that are involved in different aspects of tumor targeting. It has a topoisomerase 1 inhibitor payload, and this has a high potency payload with a short systemic half-life, and it is high membrane permeable, which may enable a bystander effect, and also there is a drug-to-antibody ratio reaching 8:1. DESTINY-Breast04 is a phase 3 trial which conducted in HER2 low breast cancer, metastatic breast cancer, those who treated with 1 to 2 lines of chemotherapy and they are hormone refractory. Patient randomized 2:1 to receive TDXD versus treatment of physician choice, and the primary endpoint was progression-free survival in hormonal positive disease, and secondary endpoints, progression-free survival in all patients and overall survival in hormone positive disease, and stratification by IHC 1+ versus IHC 2+ FISH negative, or 1 versus 2 prior line of chemotherapy, or hormonal positivity, or also CD4/6 inhibitor received or not received in the hormonal positive population. When we look to the baseline characteristic, it is well balanced in both hormonal positive and all patient population. And we can see here hormonal positive disease reaching about 90% of this study population. And actually, this is a percentage of HER2 low disease, 90% are hormonal positivity. If we look to the line of chemotherapy, the median is 1, but ranges from 0 to 3. And also endocrine therapy, it is 2 lines. This is the median, and targeted therapy, including CD4/6 inhibitors, in up to 70% of patients. So this is the primary endpoint, the progression-free survival in hormonal positive and in all patients, and it is significantly better in favoring TDXD, with the double in the median progression-free survival from 5.4 to 10.1, and also in all patients, including hormonal positive and hormonal negative, it is significantly better, with a hazard ratio of 0.50 and a significant p-value. The subgroup analysis in the progression-free survival for hormonal positive disease, all are in favor of TDXD, and also in the IHC positive 1 positive, and IHC2 positive with FISH negative, both are benefiting from TDXD. When we look to the overall survival in hormonal positive and in all patients, it is significantly also improved. The median overall survival about 2 years in TDX arm compared to 17.5 months in treatment of physician choice. And also in all patients, the overall survival was significantly better, with the hazard ratio in both groups is 0.64. There is an exploratory endpoints for progression-free survival and overall survival in hormonal negative disease, and also there is significant difference in progression-free survival favoring TDXD and also overall survival. This is a confirmed objective response rate and best overall response in hormone receptor positive reaching 52.6 versus 16.3, and in hormonal receptor negative 50 versus 16.7. This is the best change in target lesions, and it is very clearly in favor of TDXD. Regarding the drug-related adverse events in more than 20%, this is mainly gastrointestinal disorders, nausea, vomiting, and diarrhea, and constipation, and also the blood and lymphatic system disorders. This is the main drug-related toxicity. When we look to adverse events of special interest, we have interstitial lung disease, pneumonitis. It occurs in 12% of patients, but most of these are low grade, but we have grade 3, 1.3%, and grade 5, we have 0.8%. Ejection fraction, left ventricular ejection fraction dysfunction, also there is no difference between what we know for TDXD. This is the updated, in last ESMO, the updated progression-free survival in the hormonal positive and in all patients. And the progression-free survival here is improving more with the hazard ratio of 0.37 in those with hormonal positive, and in all patients, 0.36. So TDXD maintains its activity. This is the overall survival. This is the updated one in last ESMO, which showed for the hormonal positive is significantly better, and also in all patients. This is the efficacy in the hormonal negative cohort, exploratory analysis, and as you see, the curves are well separated. So TDXD approved for HER2 low metastatic breast cancer on August 5th, 2022, and it is the first HER2 targeted therapy to demonstrate improved efficacy in HER2 low metastatic breast cancer. Destiny Breast 04 established TDXD as the new standard of care for HER2 low metastatic breast cancer, potential improvement of about 50% of all metastatic breast cancer patients in this setting. So how we can master the use of TDXD for HER2 low breast cancer? So the current algorithm for HER2 low breast cancer, for those with hormonal positive after they receive CD46 inhibitors plus endocrine therapy, so they can receive other targeted agents, and then after that, they can receive chemotherapy. So HER2 low will come after, become hormonal refractory, and then one line of chemotherapy. In triple negative, which is hormonal negative disease, and HER2 low, the patient will receive chemotherapy first with immunotherapy if PD-L1, or with PARP inhibitors in case of BRCA mutation, and after progression, after that, will receive chemotherapy, and then he will be eligible for TDXD. So is there a threshold for HER2 expression level for the activation of TDXD?
2 minutes remaining, Dr. Amin.
Actually, this is a very busy slide, but this is a DAISY trial of trastuzumab deruxtecan for advanced breast cancer patient. This is regardless of the status of HER2. It's HER2 positive overexpression, or HER2 low, or HER2 non-detected. And even if we can see in HER2 non-detected, there is a response reaching about 30%, duration of response 6.8 months, and progression-free survival of 4.2 months. We have another study which we are waiting for it. This is DESTINY-Breast06. This is a phase 3, include IH0. So this is include patients with what we call ultra-low. And we are waiting for the result of this. And this is there is difference from DESTINY-Breast4 in that it includes IHC0, the ultra-low, and it is larger, and it is only restricted to hormonal positive. And this is for chemo-naive patients. But keep an eye on ADC and IO first-line combo. We have Begonia trial. There is arm 6, which combine T-DXd plus durvalumab, and we have also TADO DXd plus durvalumab in arm 7. So about emerging therapy for HER2-less breast cancer, there is a novel conjugate for HER2 low. 2 additional antibody drug conjugates have shown activity in HER2 low, 1+ or 2+, FISH negative. We have trastuzumab docarmazine, and we have dizitumab vedotin. This is showed objective response rate of 32% and 40% in each one. So by this, I will conclude approximately half of all breast cancer can be considered HER2 low. DESTINY-Breast4 established T-DXd and as a new standard of care for pre-treated patients with HER2 low metastatic breast cancer, irrespective of hormonal expression, with its best use being after the first line of chemotherapy. HER2 low expression on any specimen, primary or metastatic, should be considered adequate to offer T-DXd to a patient with metastatic breast cancer. T-DXd has shown impressive activity among patients with stable brain metastasis. Actually, I did not discuss this here, and early signs of activity even for patients with progressing brain metastasis. With the expansion indicator of T-DXd, a parallel expansion in the awareness of toxicity is required, with particular mention to interstitial lung disease that require proactive monitoring. Thank you.
Thank you, Dr. Amin. For the sake of time, we'll move to the next session. I'd like to thank Professor Grant, Dr. Levitt, Professor Gligarov, and Dr. Amin Tijani for their excellent talk. I will invite Dr. Shawqi Bazarbashi, Dr. Abdullah Shurm, Ahmed Al-Shehri, and Mohammed Al-Ghamdi to start the next session. Thank you all.
Bismillah ar-Rahman ar-Rahim. We'll start the session of gastrointestinal cancer, precision oncology in gastrointestinal cancer. And we'll start with the first speaker, Dr. Gerald Prager. Dr. Prager is a well-known GI oncologist. He's an associate professor of medicine at the Medical University of Vienna. And he will be discussing about precision medicine in colorectal cancer in the third-line setting.
Good afternoon, ladies and gentlemen. I want to thank the organizers for inviting me. Dear Chairman, it's a big pleasure that I can give you an overview how precision oncology can improve the prognosis of patients pre-treated with metastatic colorectal cancer. So first of all, the question is, how can we define a target? So we need druggable targets in the tumor biology. These targets have to be well defined on the one hand, easy to detect, not only in laboratories, but easy to measure in the clinic, or they have to be so common that we don't need them to measure. And of course, if we interfere with the drug, with the target with the drug, there should be a therapeutic effect. And then we need, of course, to do that, we need directed treatments. This might be antibodies, small molecules, or conjugates. And then we have new techniques, either to monitor the disease with ctDNA or to improve the treatment success, like new vaccines. Let me first go for the first step, to identify druggable targets in a metastatic setting of colorectal cancer disease. Potentially, there are many targets. We know we might detect a PIK3CA or PTEN mutation in approximately 8 to 10% of our patients, BRAF V600 mutations between 5 and 10%, KRAS mutation, very common, almost 50%. We have seen data on the KRAS G12C mutation, which is, however, rather rare, with 1 to 3%, MET amplification, HER2 amplification, and then potential markers which might predict a treatment efficacy of checkpoint inhibitors, like, as we know, MSI high, but also tumor mutational burden or POLE mutation. Let me first focus on the KRAS G12C mutation, where we made the biggest steps forward into the right direction. For a long time, KRAS was thought to be not a druggable target because it's so common, and it's not a tyrosine kinase, it is a GTPase, and in fact, we know for colorectal cancer that 45 to 50% of our patients bear in their tumor a RAS mutation. This RAS mutation leads to abnormal tumor growth, proliferation, and differentiation. However, it seems to be was the most easy step to interfere with the G12C mutation because of the system bridge. We have seen it in other tumor types, and now recently also a clinical phase 3 trial for colorectal cancer, where sotorasib plus panitumumab was combined after patients were treated with IV standard treatment. The so-called ColdBreak 300 study was a clinical phase 3 study which was performed internationally. A patient, of course, needed to bear this KRAS G12C mutation in the tumor, needed to have at least one prior line of treatment, needed to be in a very good to fair performance status, so ECOG 0 to 2, and then, of course, with a measurable disease according to RECIST criteria. It was a prospective randomized study with a 1:1:1 randomization design, whereby 2 different dosages of sotorasib were combined with panitumumab, and in the control arm, it was investigator choice at that time, either a monotherapy with trifluridine or regorafenib. So at that time, no combination of bevacizumab with trifluridine was considered as a standard. If you look on the patient characteristic, as you can very well see, most of the patients were recruited within Europe, but it was a global trial, so also from other parts of the world. Most patients were either ECOG 0 or 1, and then only about 13 to 15% of the patients were treated in second line. All the other patients were more heavily pre-treated. Most all patients received anti-angiogenic treatment before, and some of them had trifluridine or regorafenib before they were included in this trial. The primary endpoint was progression-free survival. And you can see that especially with the high dosage of sotorasib, the progression-free survival with a median of 5.6 months was superior, especially when compared to the investigator choice with 2.2 months, with a hazard ratio of 0.49. But even with the low-dose sotorasib, the hazard ratio with 0.58 was statistically significant. So the primary endpoint in this clinical phase 3 trial was clearly met. What else could we learn from treatment with this combination of sotorasib plus panitumumab in the G12C mutated patients? So any kind of shrinkage of the tumor was 81% with the high dose sotorasib, response rate according to RECIST criteria 26%. And this was numerically higher when compared to low dose sotorasib with 57 versus 6%. And then in the control arm, no responses at all were observed with 20% of any kind of tumor shrinkage. What's about tolerability? If we look on the safety data, especially with the high dosage of sotorasib, hypomagnesemia was only seen in 6% of the patient, rash high grade 6%, with any grade in 28% of the patients, diarrhea high grade 4% of the patients. So it seems to be a well manageable toxicity profile when you treat your patients with high dose sotorasib plus panitumumab. Of course, in this late line trial, it's always very interesting also to study the overall survival. The data is still some immature, but if you look on the data, there was no significant difference between the overall survival when compared to the investigator choice, either with high dose or low dose sotorasib plus panitumumab. But once again, the data were not mature at the data cutoff. It's only 34% of deaths were observed. A few weeks ago at the ASCO-GI meeting, also patient-reported outcome was presented, and you can see here, especially in the blue bars, that there was an improvement of the symptoms when the patients were treated with sotorasib plus panitumumab. It was more likely to see an improvement when compared to the investigator choice, which is on the very right-hand side, either after 9 weeks or 17 weeks of treatment. So clearly the patient-reported outcome, which are considered as a non-biased readout, did show that the active treatment of sotorasib plus panitumumab is not only improving the progression-free survival, but is also more likely to improve the overall health status of our patients. Second, we have just heard in the previous talk, we have recently seen generation of novel directed treatment, which should be more specific and less toxic. A good target also in colorectal cancer is HER2. We know that in patients suffering from metastatic colorectal cancer, HER2 might become amplified. So how often is this? In the unselected patient population, so all stages of colorectal cancer, it's in between 1% to 6% of the patients. On the other hand, 85% of HER2 positive tumors are located in the distal colon or rectum. And we have also learned that especially patients pre-treated with anti-EGF receptor antibodies, so cetuximab or panitumumab, they are more likely to select clones highly expressing HER2 in up to 36% of our patients. We have recently seen other data, like from the Heracles trial where trastuzumab and lapatinib was combined with stimulating response rate of approximately 30%. There have been other trials very consistently confirming that HER2 is a druggable target in metastatic colorectal cancer. The MyPathway trial combined trastuzumab plus pertuzumab and also revealed a high response rate of 32% in this pre-treated patient population. Quite recently, the Mountaineer trial was presented. This was a randomized trial with 3 cohorts. Cohort A was non-randomized with tucatinib trastuzumab, and then in the expansion cohort there was a randomization of the treatment combination, while cohort C was just tucatinib as a monotherapy. The primary endpoint for the drug combination was response rate, so in cohort A and B, while in the cohort C the response rate by 12 weeks was the readout. If we look on the data, in 38% of the patients, there was a confirmed objective response rate by a blinded central review and a disease control rate of 71%. So also tucatinib plus trastuzumab is a very effective treatment combination for patients suffering from metastatic colorectal cancer, pre-treated and overexpressing HER2. However, also new drug conjugates have been tested in colorectal cancer. We have in the previous talk heard about breast cancer. The very same drug, trastuzumab deruxtecan, was tested in patients suffering from metastatic colorectal cancer, overexpressing HER2. The so-called DESTINY-CRC02 trial did use this drug in a randomized trial design with a high dose, 6.4 milligrams per kilogram, versus the lower dosage with 5.4 milligrams per kilogram. And the primary endpoint was objective response rate. The patient had to be pre-treated with standard chemotherapy and had to be in a good performance status. Once again, response rate was the primary readout by a blinded central review. You have seen, and you are aware of this drug, it's a drug conjugate like a monoclonal antibody, trastuzumab, linked with a high drug antibody ratio of 8 with the deruxtecan, which is the cytotoxic agent. If we look on the baseline characteristic, 78% in the low dosage and 85% in the high dosage arm had an immunohistochemistry 3+ expression of HER2. However, there were patients also with immunohistochemistry 2+, which were confirmed by cytogenetic analysis. I think very notably is that there were patients between 15 and 17% who were RAS mutated. So far, we considered the RAS mutated patients as not liable for anti-HER treatment in metastatic colorectal cancer. If we look on the pre-treatment, most patients or some patients had also pre-treatment with regorafenib and or trifluridine, and there were also patients pre-treated with other HER2 regimens in about 20 to 25% of the cases. If we look on the readout, and this was the primary endpoint, objective response rate, to our surprise, there was a trend towards to be better efficacy in the lower dosage of the antibody drug conjugate, with 38% versus 28% in favor of the 5.4 milligrams per kilograms. If we look on the duration of response, however, this was quite comparable of about 5.5 months. If we look on the progression-free survival in the Kaplan-Meier curves, this is, I would say, very much superimposable between the different dosages. However, we also have seen overall survival data, and at the median overall survival at the lower dosage was about 13.4 months, and the median was not reached, the data cut off yet, with the higher dosage of trastuzumab deruxtecan. If you look on the waterfall plots, we also can very clearly see that this is a very effective drug conjugate in the HER2 overexpressors. And notably, if you look here on these yellow arrows, these were the RAS mutated patients. So RAS mutation for this antibody drug conjugate seems to be not a negative predictive factor. And this is also very much illustrated here on the forest plot, that RAS mutation for trastuzumab deruxtecan is not an exclusion factor. So there might be a quite comparable efficacy for patients bearing a RAS mutation in their tumor. We also have learned that immunohistochemistry 3+ seems to be the better predictive factor with a higher probability of response when compared to immunohistochemistry 2+ patients. And at the very bottom, you can see that also pre-treatment with other anti-HER2 treatments in this patient population was not predictive. So trastuzumab deruxtecan also works in those patients pre-treated with other anti-HER2 regimens. What's about adverse events? No surprises. High-grade adverse events were seen about half of the patients. However, serious adverse events leading to drug discontinuation was rare, between 8 and 9% of the patients. We have heard about the pneumonitis. We have to put an eye on this also in this patient population. In the end of my talk, I want to just highlight some new techniques for future treatment success. where recently, last month, there was a publication in Nature Medicine about a mutational KRAS-specific amphiphile vaccine in patients with minimal residual disease. I think it's an interesting approach where a long peptide antigen is linked to an albumin-binding lipid, and this is injected concomitantly with an amphiphile toll-like receptor 9 agonist. And together with this, you might stimulate the T cells. And if this is happening, you might prevent the relapse of the disease for patients resected for colorectal cancer with a minimal residual disease. These are very early clinical data, but I think it's a very interesting approach because with this vaccination approach, there was a tumor marker response in 84% of the patients. And so the aim, of course, in this patient population is that you prevent the relapse of the disease. Another interesting approach, of course, is immunotherapy for those patients who do not bear MSI high status or who are proficient in the mismatch repair system. And there are very early data on the HDAC inhibitors together with a PD-1 inhibitor, sintilimab with kedamide. And this is a very early randomized clinical phase 2 study presented last year at the ESMO meeting, where you can see that especially if you combine these HDAC inhibitors, checkpoint inhibitors plus bevacizumab in patients with proficient mismatch repair status, metastatic colorectal cancer, you might do something. It shows some promising efficiency in these patients, leading to responses in 44% of the patients, disease control rate in 72%, and even lead to a progression-free survival of 7.3 months. So this is, of course, way too early to tell that this will be the future, but it's a signal into the right direction that we have to think a little bit outside of the box to find new drug combinations to overcome the endogenous resistance towards checkpoint inhibitors in the mismatch repair proficient patient population. So where do we stand in third line? I've shown you this picture before. Unfortunately, more than 90% of the patients in third line either had been pre-treated with druggable targets in first and second line, or they're just not bearing any druggable target in later lines because we do it in earlier lines preferably. So what do we do with these patients? We can still use novel combinations for these negatively selected patients. Trifluridine plus bevacizumab has been shown to be superior when compared to the monotherapy. And it is also a targeted treatment, as bevacizumab is an old drug, but is targeting the angiogenesis. And it seems to work in those patients where we cannot do better at the moment, where we cannot find a druggable mutation. So let me sum up. We have novel targeted treatment options now in patients pre-treated with metastatic colorectal cancer. I've just listed a few of them. The list is growing and becoming longer. Beside BRAF, RAS mutation, at the moment G12C, HER2 overexpression, we might find some rare gene fusions. We are looking routinely for MSI high, and the list is becoming longer and longer. However, in front of the door, there are novel vaccination approaches and drug combinations which are in clinical development. So I think we are in a time which is very much exciting, and we see a lot of movement in the treatment for our patients. And for that, at the moment, I thank you for your attention.
Thank you very much, Professor Prager. We're going to leave the question at the end. Now we're going to move on with just a small change in the schedule. Dr. Ashwag Al-Nayyan will present her talk. Dr. Ashwag is a senior medical oncologist who is treating mainly GI and sarcoma. She is the head of medical oncology at National Guard Hospital, Riyadh. Dr. Ashwag will enlighten us about the many options of treating HCC. So which one should we choose? Ashwag.
مسافة طويلة إلى هنا يعني عشان أقول لك شكرا. Already see. Thank you very much. So, do I have my slide? Assalamu alaikum and good afternoon, everyone. Okay. All right, how can we go back? Okay. Yes. So I was giving the task to talk about the options of HCC, and I think we are lagging behind if we compare it with other solid tumor. So we're not that fancy. We don't have targeted therapy based on a target. We don't apply a real precision medicine. Probably it's clinical precision medicine rather than molecular precision medicine, and that's what we're gonna learn here. So how we approach a patient with an HCC. So it's by patient, by stage, by drug, preference and availability, or by the cost. And I think all of them, but we should start by a tumor board because HCC is not like one person treat HCC, it's a multidisciplinary approach, so we have too many players treating HCC. So if we talk about patient profile, so etiology, it does matter, age, performance status and comorbidity, child score and stage will determine a lot. So when you see a patient with HCC, all these should be in consideration before treatment. So if we look at, there is too many classification of HCC that try to make HCC look more fancy, but none of these came to clinical practice, so we don't treat based on this subclassification because we don't do pathology, so we don't have all these data when we see a patient and treat HCC. So let's start with etiology. Hepatitis is the most common etiology for patients with HCC. The question came because immunotherapy is the standard of care. Is immunotherapy works on patient with hepatitis? I think the answer is very clear, is yes. So we go to NASH-related or NAFLD, and we know it's growing with a lot of metabolic disorder. Does immunotherapy works in this? This is a lot of area of debate. If we look what's happened on NASH, and if you look at the level of the molecular, we do see there is some association of the natural killer cells, and we see the PD-1 and the CD8 influx when the patient starts to develop onto fibrosis and cirrhosis. But that's enough to make it like immunogenic, or the patient or response to immunotherapy. This is a meta-analysis getting mostly all the trial with HCC and looking for viral and non-viral. If you look to the checkmate, which is nivolumab, I know we don't use nivolumab anymore, but it's one of the drugs that we used to use it in the past in treating HCC. So in hepatitis B and C it works, but for viral hepatitis, it's somewhere in between. For the pembrolizumab, it works more in hepatitis B, but for C, almost in between. But in non-viral, it is less than hepatitis B, but it's even better than hepatitis C. Again, for the I'm brave, we know that hepatitis, either B and C, it works well, but for non-viral, it's equivocal. For like the cosmic, we know that like atezo plus cabozantinib, it's not one of the standard of care, but again, non-viral and hepatitis C doesn't work. If we look at the Himalaya, we see hepatitis C, they are not responding that much, but for the non-viral, it works. So what's happened? We have to understand that we don't deal with a tumor at its one part because you have multiple tumor in the liver. This is number one. There is intra-tumor heterogeneities. So the tumor are not the same. So why we see this variant? It's all immunotherapy, very much similar mechanism of action. So why it's working this drug and the other drug? I think it's based on the heterogeneity that we see within the tumor itself. So what about TKI? So we know the standard of care on the first line in the past was TKI, and we have sorafenib for more than 10 years. It was the standard of care. Now we have a drug that beat sorafenib, which is lenvatinib, especially in a PFS, not in OS. Just improvement on PFS by 3 months and also time to progress. If you look at the second-line treatment, we have regorafenib, but you have to be tolerant to sorafenib, and usually post-sorafenib, cabozantinib can be used in the second and the third line. So if we want to look at the TKI, which is best for each TKI, so lenvatinib usually for a patient with a good performance status, there is no bile duct invasion. It works with hepatitis B. There is clear clinical data that patient with hepatitis B, it works better than hepatitis C. Do we customize therapy based on that? No. So patient with high alpha-fetoprotein, child score, and we know it's a lower cost. For sorafenib, the drugs that we use for ages, we can use it for performance status, even up to 2. Patient with hepatitis C, there is a lot of clinical data, or even there is a clinical data for complete remission for patient with hepatitis C using sorafenib. What's applied to sorafenib, it's same applied to regorafenib, so you can use it also for child score of 7, and that's not applied for most of the medication. That's the only drug being used on a little bit advanced child score. So that's give advantage for sorafenib among other TKI. Cabozantinib, we know it should be in child score of A, patient have good performance status, and we know that patient with overexpression of MET, that works well. And again, patient would have good tolerance to TKI at the first line, they are a good candidate to cabozantinib. So this is the drugs that in the second line, we mentioned about regorafenib, and you see the difference between placebo and regorafenib. It's around 2 to 3 months. The same for cabozantinib, the difference around 2 months. And for the REACH, which is ramresimab, which works for a patient with high alpha-fetoprotein, it's a drug with a lower toxicity profile. In terms of efficacy, definitely it's less among the other TKI. Age and performance status, again, performance status, it's vary because sometimes performance status of 2, it's related to the symptoms which you can control and you make the patient performance status of 1. And age, I've treated a lot of patients even beyond 80s, but when the patient's functional status is good, I think the age, it's just a number. This is another systemic review for patients who've been treated as an early B with immunotherapy. And to summarize all of that it did work. I think we don't have like an evidence that we should use it in a child score of B, but I think it's safe because we use it in a lot of patients. So we talk about first line and second line. We have immunotherapy first line, and we have we have TKI first and second line. And if we look at combination therapy, we have this combination, which is Nivo, Epi, and cabozantinib. And if you look at the data, and if you memorize just the PFS and you try to compare it with the doublet therapy, you will find the difference with the doublet therapy. There is no major difference. Even the doublet therapy is better. So you're looking at the drugs with high toxicity profile, looking at the drugs that have higher cost. So I don't think the triplet is still yet one of attracting medication. This is looking at overall survival. If you look at 21 for the doublet and not reach in the triplet, we see that also on the doublet in the IMbrave and Himalaya. This is the IMbrave trial. I think this is the landscape of treatment of HCC, which using atezo-bev versus sorafenib, which is the usual competitor. And in these patients, here I think it doesn't clear. This is the IMbrave and this is the Himalaya. So I'm trying to compare these two trials because these two are the first line therapy as combination of immunotherapy. So the Himalaya is just durvalumab as a single agent, or the STRIDE regimen, which is durvalumab plus termi versus sorafenib. We will go and see the comparison between the two drugs. We don't like to do cross-comparison between clinical trial, but it's very clear that atezo-bev, in terms of overall survival and also progression-free survival, have better outcome compared to the Himalaya. But there is also advantage of the Himalaya that you don't use anti-VEGF, so patient with high risk of bleeding, that will be a candidate for this combination. The other advantage that durvalumab as a single agent, as an immunotherapy, had also a better outcome, which is the only immunotherapy that defeat sorafenib. And this is, again, the design. I think we should show that. In terms of toxicity profile and the combination of atezo-bev, I think it's very tolerant. Maybe most of the oncologists who treat HCC have been treated like near 100 of patients, and that show that less toxicity profile. I think the only caution that we have to take care of this, the risk of bleeding using Avastin. This is again the Himalaya. I'm gonna skip this. I'm gonna just show you. This is the STRIDE regimen versus sorafenib, and if you look at the 36-month, the difference was 30 versus 20, which is really significant, has a ratio of 0.7. This is look at the secondary endpoint, which is comparing durvalumab versus sorafenib. If you look in terms of number, 16 months versus 13 months is very similar to the doublet, but you can see the line are crossing over beyond the 36 month. This is the secondary endpoint, PFS. PFS was not significant, whether in the STRIDE regimen or durvalumab as a single agent. Okay, so how to select the patient? I think this is the question. So if you have a patient who's, I think immunotherapy should be a standard of care, whether Himalaya or IMbrave trial, unless the patient is post-transplant. I think pre-existing autoimmune disease, it varies because not all immune disease that severe. There is certain immune disease can be controlled in therapy, and they might be a candidate for therapy. As an example, like inflammatory bowel disease that you can, well controlled, you might treat them. In patient with NASH and NAFLD, I guess there is a lot of data like showing that maybe immunotherapy is not the best option for these patients, but again, still we don't have solid evidence to exclude these patients not to receive the best standard of care, which is immunotherapy. This is what looked like on the PCLC, and you can see there is first, second line. We don't see that a few years back. So again, treatment of HCC is not like only with systemic therapy. We have also treatment with combination with TACE and other local regional therapy. So if we look at the data of combination sorafenib with TACE, I'm gonna go quickly. Only one trial showed difference, which is improvement in PFS, 25 months versus 13 months. This is the only trial, the tactic trial, that show a difference. The rest of the trial did not show any benefit of addition of TACE over sorafenib alone. This is, I think, the most important trial, which is adding lenvatinib to TACE. In this clinical trial, you can see there is a huge difference, and overall survival, the difference around 6 months, has a ratio of 0.4, and there's also improvement of PFS. So combination of lenvatinib plus TACE, it becomes superior to TACE alone. This is ABC trial. This is a very small number of patients, but in this ABC trial, they're looking to conversion therapy, like give systemic therapy, probably like a neoadjuvant. And in this trial, they made it up to overall response rate of 44%, and they convert a good number of patients from non-local disease to a local disease that's amendable for a local therapy. This is what the future looks like. So if your patient is suitable for TACE, you might give the patient TACE. TACE plus TKI, that will be your option. If the patient responds, that's fine. If the patient refractory to TACE, you might, again, patient can go to systemic therapy if he's not decompensating. If your patient is not suitable for TACE, you have two options. Either you give systemic therapy like atezo-bev or lenvatinib, then you convert the patient for local disease, then you give TACE, or you give lenvatinib and TACE as another option. So this is what's gonna look like. We are applying more adjuvant and neoadjuvant in HCC, which was not there in the past. This is what looked like first and second line. I think we mentioned that clearly. And this is the summary. I'm gonna jump this because I'm gonna just want to mention about the Emerald one, which is a new clinical trial present on the GIASCO, which is again, which look at adding immunotherapy plus TACE, which is, this is looking at durvalumab plus Avastin and TACE, durvalumab and TACE, and for TACE alone. And here, clinical trial looked at the patient who received durvalumab and Avastin plus TACE. They show superiority in PFS, yet we don't have an overall survival. But this is to impress on treatment of HCC is not one option, it's multiple option, and you should explore all the options for your patient. And I think child B of 7 does have a chance for these patients. You should apply all your tools. Either you give the patient neoadjuvant or you try to different modality of treatment based on the patient tolerance and toxicity profile. Thank you.
Thank you so much, Dr. Ashwaq. So you can join us. Thank you so much. You can join us now. So to start with, I would like to thank you, Dr. Amal, for organizing such meeting. It's with the eminent speaker. Thank you so much, and we hope it will be an annual basis. So let me ask Dr. Sharif Al-Sammani to present a very important topic about controversy in HIBIC and colorectal cancer. Dr. Sharif Al-Sammani, he is a senior consultant. He is the chairman of the medical oncology in King Abdullah Medical City in Makkah al-Mukarramah. Sharif, the mic is yours.
Okay, thank you very much, Dr. Abdullah. It's my pleasure to join this meeting with you and my dear colleagues. So in this session, we listened to two important talks, one about refractory metastatic colorectal cancer, Prof. Prager, the second from Dr. Ashwaq, HCC, and this is a kind of a standard rather than controversy. Now we'll talk about one of the most controversial points in advanced colorectal cancer, which is the role of HIBIC in patients with advanced colorectal cancer with peritoneal carcinomatosis. So first, so this is the outlines of this talk. We'll talk about some background of peritoneal carcinomatosis and their prognostic impact. Then we'll talk about what we know about the role of cytoreductive surgery in addition to HIBIC. And then we'll move to the controversy about the exact role of HIBIC when added to cytoreductive surgery. And then we'll a few slides about the future approach to standardize the management of patients with peritoneal carcinomatosis. So let's start with the background of peritoneal carcinomatosis in patients with advanced colorectal cancer. So as we know, how peritoneal carcinomatosis develop, it's a kind of detachment of malignant cells from the primary tumor, adhesion to the mesothelium in the peritoneum omentum, and then invasion to the surrounding to establish themselves as a kind of metastasis to the peritoneum. And there are some risk factors for the development of peritoneal carcinomatosis in colorectal cancer, like having T4 tumor, 20% of those patients can develop BC, having tumor perforation, 30% risk, ovarian metastasis about up to 60% risk, in addition, of course, to having previous peritoneal carcinomatosis, even if previously resected. This is a risk factor for additional development of or relapse of peritoneal carcinomatosis. And as we know, there are certain histological subtypes that are more likely to have this kind of metastasis, especially mucinous and signet ring, compared to the conventional adenocarcinoma. And what about the prognostic impact in this series of patients, including more than 10,000 patients enrolled in different randomized trials? They looked for the impact of having peritoneal carcinomatosis versus not having BC, and they found that, as we know, having peritoneal carcinomatosis is an adverse prognostic factor compared to having metastasis in another sites of such as liver, lung, or so. And even what's remarkable is having peritoneal carcinomatosis alone without extraperitoneal metastasis, to some extent having better outcome compared to patient having mixed peritoneal and extraperitoneal metastasis. And this is in another series of patients confirming the same story of having worse outcome if the patient have peritoneal carcinomatosis compared to absent peritoneal carcinomatosis. But the question or the point that I need to address with you is the outcome of the prognosis of having peritoneal carcinomatosis is not uniform. So even among the patients who develop peritoneal carcinomatosis, we have some heterogeneity in terms of prognosis. So please look to this data. When they looked for the outcome of patients having peritoneal carcinomatosis in patients having RAS, BRAF wild, compared to patients having KRAS mutation or having BRAF mutation, they found that there is heterogeneity in terms of prognosis. And the worst outcome was in patients in having BRAF mutation compared to the others. And in addition, when they integrated the molecular background in terms of RAS or BRAF mutation, in addition to other potential risk factors like the nodal status of the primary tumor, the tumor grade, and the BCI index, they found that there are a clear heterogeneity in terms of outcome when you integrate their prognostic parameters in one prognostic tool. So as you can see in this diagram, you can find that the best outcome in patients having RAS BRAF wild, in addition to low BCI index, node negative primary, and low grade. And the worst outcome is the reverse, having high BCI, having BRAF mutation, having high grade tumor and node positive primary, and patients having mix of these prognostic parameters, the prognosis is in between. So before moving to the next step, I think we know nowadays that this is, in general, this is worse prognosis to have peritoneal carcinomatosis. This is number one. And even among those patients, the prognosis is not uniform, and there is variety or heterogeneity in terms of the prognosis of patients of peritoneal carcinomatosis according to different parameters. The next point is what we know, or what is the data that we have in terms of treatment of patients with peritoneal carcinomatosis in advanced colorectal cancer. What we know is when you treat those patients with systemic treatment only, the prognosis is not great, okay? And we have data to support that. For example, in this series of patients, all series of patients that have been published in 2012, the median survival about 12 months or so, okay? This is with systemic treatment at that time. Even with modern systemic treatment, including biologics like anti-GFR and the others, you can find that the best results that have been achieved in the modern era of systemic treatment, the median survival about 19-20 months, okay? So I think this is still far beyond being optimal. So we need to look for other options for those patients. And based on this poor outcome with systemic treatment, we started to look whether we can replicate the story of having local therapy or resection of patients with metastatic colorectal cancer with limited metastasis to the liver or lung or so. Can this story to be repeated in patients with peritoneal carcinomatosis? Actually, we can say yes. For example, patient with liver resection, metastatic colorectal cancer, limited liver metastasis, and having liver resection, in a proportion of patients, we can reach up to 5 or 10 years of survival after resection. And actually, for selected patients with peritoneal carcinomatosis, there are reports that with cytoreductive surgery plus HIBIC, there is some patients, up to 15 or 16% of those patients, can enjoy 5-year survival with surgery plus HIBIC. So, does it deserve to try to have local therapy for those patients? I think after this data, the answer is yes, if the patient is candidate to do so. However, the story of exploring cytoreductive surgery plus HIBIC started from some, or the benefit compared to systemic therapy have been demonstrated in some case control retrospective studies where when they compared the outcome of those patients treated with cytoreductive surgery plus HIBIC compared to systemic treatment, in different series of patients, there is difference in survival in favor of cytoreductive surgery plus HIBIC. However, these are case-controlled studies or retrospective data. And one of the first data that demonstrated the survival benefit in a prospective randomized fashion, prospective randomized trial, was published in 2003 by Verwal and his team, when they compared in the outcome of patients with peritoneal carcinomatosis treated with cytoreductive surgery plus HIBIC compared to systemic treatment. 105 patients were enrolled in this study. And I think you can see that there is survival benefit in favor of the combination. However, we need to highlight here 2 points. The first is, this study demonstrated the benefit of the whole package, cytoreductive surgery plus HIBIC, but this does not prove the benefit of HIBIC itself compared to systemic treatment. This is number one. Number two, this positive study used the chemotherapy component in the HIBIC was mitomycin in a duration of 90-minute infusion. okay? So please keep this in mind because we'll come within a minute to this point. So this is one of the first trials that demonstrated the benefit of cytoreductive surgery plus HIBIC compared to systemic treatment. And it has been to great extent extrapolated to use when you are going to use some kind of local therapy in patients with peritoneal carcinomatosis. You need to use cytoreductive surgery plus HIBIC. This have been tested in different solid tumors later on, including gastric and ovarian. And so assuming that you need to have HIBIC in addition to cytoreductive surgery to have the benefit. However, up till now, we don't know exactly what is the exact role of HIBIC when added to surgery. But in addition to that, we know from different data, different series of patients, this is one of them, one of the largest series of patients coming from the French registry, including more than 500 patients, that even among patients treated with cytoreductive surgery, the prognosis is not uniform and depends to a large extent on peritoneal carcinomatosis index, and patients with lower BCI, they can enjoy much better survival outcome compared to patients with higher BCI index. And this has been replicated in different series of patients, as you can see in this diagram as well. This is the first point. The next important point in terms of prognosis for patients treated with cytoreductive surgery is the completion of resection. So the prognosis is quite different in patients treated till reaching complete cytoreduction with no residual at all, compared to patients having residual, as you can see in this diagram. So now here we can agree on 2 points. First, to have good outcome, you need to have good selection of patients with lower PCI, this is number one, and you need to achieve complete cytoreduction to allow the patient to enjoy long-term survival. And the third point that we can agree upon is when in the bold analysis of several patients treated in different series of patients, they found that there is definitely, compared to systemic treatment, cytoreductive surgery plus HIBIC, definitely there is some extra morbidity, but no extra mortality, according to this data. And the fourth point that is still we need to explore more, which is the role of systemic treatment either before or after HIBIC. Cytoreductive surgery plus HIBIC. Do we have clear evidence for that? Yes or no? So up till now, we have some data, retrospective data, case control studies. One of them, as you can see, this was published about 10 or 12 years ago. They retrospectively looked for patients treated with cytoreductive surgery plus HIBIC, and they compared the outcome in patients who received the neoadjuvant chemotherapy versus patients who did not receive neoadjuvant chemotherapy. And they reported that receiving neoadjuvant chemotherapy is better, especially that the patient does not have progression on neoadjuvant chemotherapy. So you can say that it's a kind to test the biology of the disease before going for cytoreductive surgery. And in addition, in this analysis as well, they found that the magnitude of response matters as well. So patients who have complete response with neoadjuvant chemotherapy or major response, they enjoy better survival outcome compared to patients who had minor response to systemic treatment. Again, so maybe this data this is not randomized data. It cannot prove to 100% with high-level evidence the exact role of neoadjuvant therapy, but we can say that neoadjuvant therapy is a good way to test the biology of the disease before going for cytoreductive surgery and HIBIC. So I guess after this data, we can say that it seems that local therapy in selected patients with cytoreductive surgery plus or minus HIBIC is fine. We need to go for that in selected patients, especially those with low BCI, patients who can achieve complete response, and maybe in some patients, neoadjuvant therapy will be a good tool to select for patients who have good biology to go for this approach or not. So going to the main core of this talk, which is what is the exact rule? We have data to support cytoreductive surgery plus HIBIC as a package. But what are the evidence behind each component of this package? HIBIC itself, cytoreductive surgery itself, neoadjuvant chemotherapy, adjuvant chemotherapy, we don't know. So let's explore what is the evidence behind each component of this approach. So having hyperthermic intraperitoneal chemotherapy, the idea behind that is hyperthermia to enhance the cytotoxicity of chemotherapy. Increasing the temperature will increase the blood supply, increasing the efficacy of chemotherapy. This is the idea behind this approach, okay? And we have some data, some evidence to support HIBIC in patients with appendicular pseudomyxoma peritonei. So in this series of patients, this is one of the largest series of patients that support the role of HIBIC in appendicular, not advanced colorectal cancer in general, appendicular pseudomyxoma peritonei, coming from a database of the peritoneal surface malignancy group. And they looked for patients treated with cytoreductive surgery with HIBIC versus those who did not receive HIBIC. And I guess you can see that there is benefit of HIBIC according to this data coming from this Oncology Society database. This series of patients including 1,900 patients, so it's a good pool of patients actually, but again, this is in appendicular pseudomyxoma peritonei. What about colorectal cancer? Until a few years ago, we don't have any randomized data to check the exact role of HIBIC. However, in the Prodigy 7 from the French group looked for this question, whether we need HIBIC or not in patients who have cytoreductive surgery. So they enrolled the patient with peritoneal carcinomatosis from colorectal cancer, and the patient should have complete cytoreduction or maximum to have residual up to 1 millimeter. Those patients were randomized into HIBIC versus no HIBIC. But we need to highlight here that what is the protocol of HIBIC that have been used in this trial? It is oxaliplatin, 560 milligram high dose oxaliplatin over 30 minutes. So it's quite different from the initial protocol of mitomycin, 90 minutes. Here it is oxaliplatin, high dose, 30 minutes, okay? So this is the design of the trial. These are the baseline characteristics of patients enrolled. I need to highlight here something important. Please, we know before that BCI matters, okay? So if you look to the distribution of the BCI among the two treatment arms, there is balance for the BCI less than 11. It's okay. But for the other BCI categories, BCI from 11 to 15 and 16 to 24, we have imbalance between the two arms. Okay, and we have more of the BCI 11 to 15 in the no HIBIC arm. This may have some effect on the results. We'll see. So this are the baseline characteristics, and this is the primary endpoint, the overall survival. There is no benefit when you add HIBIC compared to no HIBIC in terms of overall survival. Quite disappointing trial that HIBIC has no role in the management of peritoneal carcinomatosis after cytoreductive surgery. And however, when they looked for the prognostic impact of BCI in the patient enrolled in the trial, as expected, it has impact. But when they looked for this exploratory subgroup analysis in the subgroup of patients from 11 to 15, where we have imbalance in the distribution between the two arms, they found that HIBIC is beneficial according to this exploratory subgroup analysis compared to no HIBIC in patients with BCI from 11 to 15. And this raised some concern about whether HIBIC is of no benefit or it may be the imbalance in the distribution that may have some impact on the overall results of the trial also. This is another concern. Another point regarding the safety, there is no difference in the mortality between the two arms. And the toxicity or the morbidity from day 1 to day 30, there is some extra neutropenia, thrombocytopenia as expected in the HIBIC arm. However, as expected from mortality day 60, we have more grade 3 and 4 up to 5 in the HIBIC arm compared to no HIBIC arm. So we have some extra toxicity as expected when adding HIBIC compared to no HIBIC. So these are the data that we have. However, despite that, there is no overall survival benefit. However, this decreased to a great extent enthusiasm about having HIBIC after cytoreductive surgery, okay? But again, there is some criticism of the trial. I mentioned some of them. One of them, of course, in the imbalance in the baseline characteristics. Another point is whether HIBIC in general is not beneficial or the protocol of HIBIC that have been used in this trial is not beneficial. Oxaliplatin for 30 minutes, because the initial idea of HIBIC was with mitomycin and others over 90 minutes. So it may be the duration, it may be the chemo component that's not beneficial. Okay, I have 2 minutes, okay. So this has raised some concern about the results, whether it is valid or not, no benefit, or it is related to the protocol used for HIBIC in this trial. Especially that if we go back to look for the studies that addressed adjuvant HIBIC in the adjuvant setting in patients having high risk of peritoneal carcinomatosis after surgery, like patients with perforation, resected ovarian metastasis, and so 2 trials are negative. The Profil-CHIP trial is negative, second look surgery plus HIBIC after end of adjuvant chemotherapy, negative, no benefit no survival benefit with delayed HIBIC in high-risk patient. The Dutch trial, COLOBIC, is negative as well for immediate adjuvant HIBIC in high-risk patient. There is no benefit as well. But what's remarkable is the 2 adjuvant trial, like the Prodigy 7 trial, use the same protocol, oxaliplatin 460 milligram over 30 minutes. So it seems that this HIBIC protocol should not be used anymore because it is negative in 3 trials, 1 in the advanced and 2 in the adjuvant setting. So is it the no benefit in HIBIC in general or the protocol that will need to be readdressed? So we have 3 negative trials, as I mentioned before, and the positive trial are the trials that use another HIBIC protocol. One of them is the Verwal trial, 2003, and we have another positive trial, but in ovarian cancer, that use HIBIC with cisplatin, not oxaliplatin. So it may be the protocol of HIBIC that we need to be revisited again. And based on that, the next step is to look for another HIBIC protocol and test the utility of adding HIBIC in addition to cytoreductive surgery compared to cytoreductive surgery alone. And this question is the question of this trial that looked for the benefit of HIBIC, but in another protocol with mitomycin over 90 minutes, not oxaliplatin over 30 minutes. And this protocol is being tested in a randomized fashion in this trial after complete cytoreductive surgery, where the patient will be randomized into HIBIC versus no HIBIC. But the protocol is mitomycin over 90 minutes. So just 1 minute, if you allow me, Dr. Shawqi. So the next step as well, to test the utility of systemic therapy before or after HIBIC. We have some data, but this is retrospective about the benefit of adjuvant chemotherapy after HIBIC. But when this has been tested in a randomized fashion, it is negative. We don't have clear evidence from randomized trial that in the patient who have complete cytoreductive surgery for peritoneal carcinomatosis, there is benefit from systemic treatment. Despite that, in practice, very frequently we are prescribing adjuvant chemotherapy. However, there is no conclusive evidence for that. And even there is no conclusive evidence for neoadjuvant therapy. The evidence that we have coming from retrospective data, in a small randomized trial enrolled 80 patients, they found that the patient who received neoadjuvant treatment, systemic treatment, they have, as expected, some good radiological response and pathological response, but the study is small, not powered enough to show survival benefit. So we don't have conclusive evidence for that. So we can conclude by saying that, yes, there is some benefit from cytoreductive surgery, especially for patients with lower BCI, and if you can achieve complete site reduction. But we don't have conclusive evidence of the benefit of HIBIC, but please, if you are going to use no benefit, according to the data that we have from oxaliplatin-based HIBIC, 30-minute duration, you need to look for something else. And what is the role of preoperative or adjuvant chemotherapy? I think this needs case-by-case discussion, because what we have is coming from retrospective data. We don't have evidence from randomized prospective trials. Thank you very much.
Thank you, Dr. Sharif. Very extensive overview about the role of HIBIC post-cytoreductive surgery. If you want to join us at this stage, we'll come to the last talk of our session, of the GI session. It will be my pleasure to introduce Dr. Elizabeth Smith. She's a consultant medical oncologist at Oxford University Hospital. She's practicing as a consultant gastrointestinal oncologist at Addenbrooke's Hospital in Cambridge, who are going to talk about the novel targeted therapies in gastric cancer. So, Dr. Elizabeth, the microphone is yours.
Hello, everybody. Thank you for joining me today. My name is Dr. Lizzie Smith. I am a medical oncologist in Oxford, UK. And I'm very grateful for the opportunity to speak to you today at this Precision Therapy Conference about novel targeted therapy approaches in gastric cancer. So this is a disclaimer, and these are my disclosures. So globally, gastric cancer is a very important global problem. It is most common in East Asia and Latin America, but also common in other countries. And although the incidence of gastric cancer is declining, as the population ages, cases actually increase. It's the 5th most common cancer and the 4th most common cause of cancer death globally. And closely behind gastric cancer is esophageal cancer. Esophageal adenocarcinoma and proximal gastric cancer, cancer at the top of the stomach, are very similar in biology and also similar in outcome. Proximal gastric cancer or junctional cancer is becoming more common in developed countries, including my own country and other countries where patients have high weights and reflux as common. Survival rates for gastric cancer vary according to stage of diagnosis. For patients with truly localized cancer, survival can be good. However, even regional disease, such as lymph nodes, are associated with a poor outcome. Until recently, patients with metastatic cancer had almost no long-term survivors. Because of screening in high-risk countries, Japan and Korea, for example, identify patients at very early stages and they have excellent 5-year survival. However, for example, in my own country, most patients are diagnosed late and have a 5-year survival of, sadly, only around 20%. So this is a seminar about personalized therapy, and this is where we were with chemotherapy for advanced gastric cancer. Sadly, for about 20 years, no matter the chemotherapy regimen we used, for patients with advanced disease, survival was less than a year. But happily, we are now beginning to move on from this survival and extend outcomes for patients with advanced gastric cancer. So the theme of this talk is targeted therapy approaches, new targeted therapy approaches for gastric cancer. Instead of treating patients blindly, as we have done in the past, we should now think about their biomarkers, whether these are immunohistochemistry, next-generation sequencing, or others. And we use these biomarkers to prescribe a treatment which is more likely to be effective for each individual patient. So one of the questions is, how did we arrive where we got today with personalized therapy for gastric cancer? Around 10 years ago now, in Singapore, the TAN group identified that gastric cancer has many amplifications or extra copies of genes, which we are still trying to target. Then we moved on to the gastric cancer and the esophageal TCGA, which were useful to identify subgroups like MSI and EBV cancer, and also for demonstrating that esophageal adenocarcinoma was very similar to chromosomally unstable gastric cancer. And this gave us the freedom to include esophageal adenocarcinoma and gastric cancer in the same clinical trials, so that the tumors are defined not just by their anatomic location, but also on their biology. And then we moved on from specific molecular subtypes to immune phenotyping. And I won't talk a lot about immunotherapy today because this is a targeted therapy talk, but it's important to note that this is an evolving treatment for gastric cancer. In fact, if you take a step back and look at cancer as a whole, you can think about immunity across cancer types, running from inflamed cancers, which are very sensitive to immune checkpoint inhibitors, to immune deserts, which are not sensitive at all. Overall, about 1/3 of gastric cancers are immunologically active. So that is somewhat less than melanoma and lung cancer, but still more effective than perhaps colon cancer. So, however, sadly, the majority are immune excluded and don't have T cells infiltrating the tumor. And we need to understand better how to help these patients with immunotherapy. And that's the subject of a whole nother talk, which I won't be talking about today. And finally, where do we get to now with biomarker profiling for gastric cancer? This is the complexity of gastric cancer biomarker testing, which is evolving. The common biomarkers that we need to check for all our gastric cancer patients are mismatch repair deficiency, that's for immunotherapy, PD-L1, also for immunotherapy, HER2 for targets, Claudin 18.2, is very likely to be added to this panel of biomarkers in the near future. And so even if you look at these 4 biomarkers, if you look at the proportion of patients who are negative for all, it's very few. So in future, we will have a biomarker-selected therapy, whether that is immunotherapy or targeted therapy, for most patients. So if we think about these targets, moving away from immunotherapy, thinking about Claudin 18.2, HER2, we have many drugs and many new modalities in development. These include antibodies, antibody-drug conjugates, bispecific antibodies, and each one of these deserves their own talk. But I'm going to stick to the headline acts today of those which are the most important. So let's start with HER2. HER2 cancers make up about 20 to 30% of gastric cancers. And for more than a decade, trastuzumab or Herceptin has been the standard of care in metastatic gastric cancer, which is HER2 positive. There are specific criteria for defining gastric cancer as HER2 positive. In fact, we only need 5 cells in a biopsy to be HER2 positive to define that tumor as HER2 positive. It's clear that using trastuzumab in HER2 positive cancers can lead to survival benefits for patients with gastric cancer. So this is definitely a target that's worth pursuing. However, HER2 in gastric cancer, like many biomarkers, has its own challenges. Gastric cancer in general has a chaotic genome, and this chromosomally unstable type of tumor has high levels of heterogeneity. What that means is that one part of the tumor can express a biomarker and the other does not. For example, if you look at the TOGA trial, which established trastuzumab as an effective treatment for HER2 positive gastric cancer, less than 30% of patients had high levels of HER2 expression in most of their tumor. And this heterogeneity has a real impact on patients in the clinic. For example, if we look at this Japanese study, they classified patients as homogeneous HER2 expression with nearly all the cells positive, or more than 40% positive, or heterogeneous and less cells positive. And the survival for patients treated with trastuzumab for those who had homogeneously expressing HER2 on nearly all their cells was 3 years, almost twice that who had less HER2 positive. And I'm not suggesting that we withhold trastuzumab for patients who have less HER2 positive cells, but it will be useful to know how many cells were HER2 positive so that we can define how likely that patient is to benefit from HER2 therapy. The second really, I think, well-established issue now with HER2 and with other biomarkers, because we're taking HER2 as a paradigm in gastric cancer, is that it changes under the pressure of treatment. It evolves. What we know is that when we treat patients with trastuzumab for gastric cancer, that about 1/3 to 60% will lose HER2 on their tumor after treatment. Previously, we had second-line studies in which patients did not benefit from HER2-directed therapy, and we now know that the reason for this is because they no longer expressed HER2 on their tumor. So it's strongly recommended that we check HER2 after trastuzumab, if we can do this safely, to understand what the best treatment in second line is. However, after a decade of negative trials in second line, I think that we finally cracked it by using trastuzumab deruxtecan, and this is a very helpful drug for patients. Firstly, if we take a biopsy and establish that the patient is HER2 positive, they're more likely to benefit. But trastuzumab deruxtecan is actually a very effective drug. Trastuzumab deruxtecan is an antibody-drug conjugate. So what this means is you have an antibody targeting HER2, which delivers a chemotherapy directly to HER2 positive cells. In this case, there are 8 molecules of chemotherapy attached to the HER2 antibody, and this has a potent effect on HER2 positive cells. What's interesting about trastuzumab deruxtecan is that we see infiltration of the chemotherapy into the tissue around the HER2 positive cells, killing other cells in the vicinity. And if you remember back to when I said many patients have heterogeneous tumors, you can understand why this drug, which releases chemotherapy towards non-HER2 positive cells, also is quite effective. There have been 2 studies looking at trastuzumab deruxtecan in HER2 positive gastric cancer. The first of these was Destiny Gastric 01. Destiny Gastric 01 was an Asian study in which third-line patients were randomized to either chemotherapy or trastuzumab deruxtecan. The response rates to trastuzumab deruxtecan were 3 times what we saw with chemotherapy, and median overall survival was also extended. So this led to a license in many jurisdictions for TDXD in third line. Sometimes, however, we see different results out of Asia than we see in Asia for gastric cancer. So it was very reasonable to repeat this study outside Asia to understand if the results were the same. This is the Destiny Gastric 02 study. In this study, which was conducted not in Asian countries, in second-line patients after trastuzumab, a biopsy was done to confirm HER2 positivity before treatment with trastuzumab deruxtecan. And interestingly, although this was not a randomized trial, the results were very similar. Response rates were 40%, and median survival was about a year. So I think this is an excellent treatment for patients who can access it in the second-line treatment. We don't have a large randomized trial, that is Destiny Gastric 03, and that is ongoing currently. Still speaking about HER2, we're now starting to understand the interaction between HER2 and the immune system. For example, we know that HER2 positive gastric cancer has high levels of T cell infiltrate and therefore might benefit from immune checkpoint inhibitors. In the Keynote 811 study, patients with HER2 positive gastric cancer were treated with chemotherapy, trastuzumab, plus or minus pembrolizumab. What we found was that patients who had 2 biomarkers, HER2 and PD-L1, benefited from the combination therapy. Median survival was improved to more than 20 months for patients who were double biomarker positive. But patients who did not express both biomarkers, those who were HER2 positive and PD-L1 negative, did not benefit and in fact had a detrimental effect. So we need to understand the interaction between 2 biomarkers. This is quite likely in future for other double biomarker combinations in gastric cancer in order to prescribe the best treatment. Now there are a few other biomarkers that are emergent that I would like to mention. FGFR2 is an important emergent biomarker. It is less common. It is overexpressed on the surface at significant levels in about 15 to 30% of gastric cancers. It is also associated with gene amplification, but that is less common and not necessary for benefit from antibody therapy. We've had a phase 2 trial called FIGHT, which looked at chemotherapy plus bemarituzumab, which is an anti-FGFR2 monoclonal antibody. In FIGHT, we saw significant improvements in progression-free and overall survival for patients who overexpressed FGFR2b on their tumors. The highest benefit was for patients who expressed FGFR2b on at least 10% of tumor cells. And so there are ongoing registration studies looking at FGFR2b plus or minus immune checkpoint inhibitors. If these are positive, we may have another treatment option for patients in the next couple of years. And finally, I will come to Claudin 18.2. So Claudin 18.2 is a very hot topic in gastric cancer currently because it's a completely novel biomarker. Claudin 18.2 is a tight junction protein, which is normally expressed only on the stomach mucosa. Then, when a tumor grows, it is expressed only on the tumor because that has come from the stomach. Because it is not expressed anywhere else, you can target Claudin 18.2 with limited toxicity everywhere else in the body. So this is a very helpful characteristic for a biomarker. Claudin 18.2 is overexpressed at significant levels in about 40% of gastric and GE junction cancers. And this has been the topic of a number of trials over the past couple of years. As you can see, targeting Claudin 18.2, there are a number of different drugs in development, including zolbetuximab, a monoclonal antibody, antibody drug conjugates, and bispecifics. Of these, the one that has had two positive phase 3 trials, is zolbetuximab. So zolbetuximab is a monoclonal antibody targeting Claudin 18.2, and it was used in 2 global randomized trials in patients who had tumors that overexpressed Claudin 18.2 in at least 75% of tumor cells. That's about 40% of the population. In both of those trials, GLOW and SPOTLIGHT, patients were randomized to either chemotherapy plus placebo, and that chemotherapy could be Capox or FOLFOX, or the same chemotherapy plus zolbetuximab. And what we saw in both of those trials was a statistically significant and clinically meaningful improvement in overall survival for patients who were treated with zolbetuximab. You can see first here the SPOTLIGHT trial, in which zolbetuximab was used with FOLFOX chemotherapy. In this, median overall survival was 18 months for patients treated with zolbetuximab. This is especially good when you consider that the survival that we see with immune checkpoint inhibitors, the median, is about 14 months, so very encouraging. Then we had the GLOW study, in which patients were treated with Capox plus or minus zolbetuximab. And as you can see here, median overall survival was more than 14 months, also very encouraging. It's likely that zolbetuximab will achieve a license in the next year or so, and this could become a recommended treatment option for patients with gastric cancer that overexpress Claudin on their tumor. So it's important for us to acknowledge that with these new targeted therapies, we also see new toxicities. For example, with trastuzumab deruxtecan, we need to be aware of interstitial lung disease and monitor carefully for this. With zolbetuximab and Claudin 18.2 antibodies or treatments as a class, because Claudin 18.2 is expressed on the stomach, these drugs cause nausea. But often this is maximal for the first or second cycle, and then it reduces significantly. For bemarituzumab, targeting FGFR2b, this causes corneal effects such as dry eyes and ulcers, and patients need careful monitoring by an ophthalmologist. So when we think about the biomarker expression in gastric cancer, I think the future is very exciting. And as you can see from this nice Japanese study, many patients are positive for more than one biomarker. And I think as we design treatments and treat our patients in future, the lesson from the HER2-positive pembrolizumab immunotherapy studies need to stay with us. It's not just that we can combine every biomarker together for patient benefit. We will need to carefully examine the use of each biomarker and antibody, for example, to understand whether they synergize with each other or whether perhaps, as was the case with pembrolizumab in HER2-positive PD-L1 negative patients, they antagonize each other. So there will be, I think, many trials for us to perform to help our patients over the next decade. So just to demonstrate a patient case, this is one of my cases, and how competing biomarkers are of interest. This is a young patient with esophageal adenocarcinoma I've been treating with HER2-positive treatment in April, and she initially had a great response. Very rapidly, however, she developed shortness of breath and, in fact, developed lung disease despite her liver metastasis responding to treatment. Because this had progressed so quickly, we did a biopsy. And the biopsy, in fact, showed that the cancer in the chest was HER2 negative and EGFR positive. As a result, we treated her with a second-line chemotherapy with ramucirumab and paclitaxel, and she responded well to that. What we will do afterwards, I'm not sure. We will consider, I think, trastuzumab deruxtecan, or perhaps we should think about a clinical trial for the other biomarkers which we have detected on ctDNA. So this just to demonstrate, in fact, that when we think about combination therapy and targeted therapy, generally, we're moving towards better outcomes for patients with gastric cancer. When we look at KEYNOTE-811, for the patients who were selected correctly for double biomarker, survival was more than 20 months. Using FGFR2b targeting with bemarituzumab, survival was 16 months. And in SPOTLIGHT and GLOW, we also see excellent survival for patients targeted with zolbetuximab for Claudin 18.2 cancers of between 14 and 18 months. In future, I think that our biomarkers are going to be more complicated. It's not just going to be HER2 positive or negative, Claudin 18.2 positive or negative. We'll be moving, I hope, towards a situation where we characterize biomarkers in a more complex way. For example, knowing the proportion of cells which are positive for each biomarker. And in that way, we'll be able to carefully select the best treatment for patients. I would also advocate that we recheck the biomarkers after first and second line, which is a great opportunity to reevaluate what might be the most effective treatment for that patient at that time. Because we know that gastric cancer is dynamic, so we need to do this with treatment as well. So in conclusion, I would like to say that I think this is a very exciting time to be treating patients with gastric cancer, with a number of validated targeted therapies becoming available, helping to extend overall survival. And I'm looking very much forward to your questions. Thank you.
Thank you, Dr. Smith, if she's live with us, for this nice overview about the targeted therapies in gastric cancer. We might have maybe 10 to 15 minutes questions. We may start with Dr. Ashwag because she is leaving us within a few minutes. So if we have any question about the talk that was presented by Dr. Ashwag Al-Alayyan with regard to systemic therapies in advanced unresectable HCC. Yes, Dr. Sharm.
I think
just if you don't mind, just I want to repeat the question of Dr. Sharm so everybody will know that. He's asking about systemic therapy, whether NAFLD should play a role about the choice of systemic therapy. So Dr. Ashwag, please.
I think up to the moment, we should not customize the treatment based on etiology. And if you just go to the real clinical practice, how many patients with NAFLD would treat with immunotherapy, especially atezolizumab, since we don't have the TREMI and durvalumab as well. So I think they are equally responding. Maybe we have to have a retrospective collection to our data. And as I mentioned before, there is heterogeneity within the liver itself and within the tumor, intratumor heterogeneity, which should take in consideration. Because if we do that and customize therapy, you might miss a big chance of having a better therapy for the patient, which is definitely immunotherapy better than TKI.
Excellent. I have another question for you, Ashwag, with regard to, we have now 2 immunotherapy regimens that have been proven to be superior to sorafenib.
Yep.
Are you looking at them as equal options, or should we use one of them as a default option? Unless we have a contraindication, then we have to go to the other option.
If you look at the data, I think the atezolizumab have better overall survival. If we don't have any contraindication, it would be my preference regimen over TREMI-Durva. Did I try TREMI only in one patient? And it's only one patient. So I cannot compare my experience with atezolizumab, with a huge number of patients, with TREMI-Durva. Unless we have hands-on on the drugs and we use it, maybe it will have a better outcome in the real patient in our population, because whatever clinical data, it's not tested in our population.
Excellent. Any other question? Yeah, Dr. Sharif.
Dr. Ashwag, what about patient with B7? Would you treat this patient with atezolizumab, or monotherapy will be a better option? What's your approach for those
B7?
patients? B7, yeah.
I treat all B7 with all the options, either lenvatinib, atezolizumab, and even durvalumab. And I think B7, it's not even one group. So not like we have a B7 of bilirubin of 60. I wouldn't give any treatment on these patients because they have the worst prognosis. But if you have like a B7 because of the albumin like 28, patient is malnourished, you might help the patient with nutritional support and improve this B7. And even this will be I think it's soft. You might treat these patients, or patient have an ascites. I would treat this patient and treat his ascites with beta blocker and diuretic. So I think it varies, but I think B7 it's a bulk of the patient. If we ignore these patients, I think we can exclude more than 60% of our population, and we don't treat HCC if they're B7.
Excellent. Any other question to all of the panelists that we have today? So we have a talk about targeted therapies in colorectal cancer. We have a talk about HIPIC, and we had a talk about targeted therapies in gastric cancer. Thank you, Dr. Ashwag. Hope you like a safe trip back home. Okay. So I may start with Dr. Prager. With regard to the colorectal cancer, we had like a very elegant lecture about the different targeted therapies. We used to exclude patients with KRAS mutation, any kind of RAS mutation from HER2 testing, because it's a rare occurrence with this kind of mutation, and usually the classic anti-HER2 does not work in these patients. But now with the TDXD data, we might have different opinions. So should we change our practice with this regard?
Yeah, I think absolutely. I mean, the number of patients KRAS mutated within this study were very limited. However, when it comes to the mode of action, it's a different mode of action with the ADC. So I think it's absolutely worth, if we do testing for HER2, not to exclude the RAS mutated patients. So we need to know what we have for the driver, for the tumor, and what it's expressed, and what might be the druggable targets. And when it comes to the trastuzumab deruxtecan, as far as we know, it also works in the RAS mutated patients.
Excellent, thank you. Yeah, Dr. Mohammed Al-Ghamdi.
Thank you very much. So I have a question to you, Sharif.
The microphone is coming.
Thank you very much. I have a question for you, Sharif. So in a limited peritoneal disease and limited liver metastasis, would you go with the same approach, so cytoreductive surgery and then the HIPIC?
Thank you very much for this question. Actually, what we know, Dr. Mohammed, that you know, the outcome even for patient treated with cytoreductive surgery is much better in patients who have limited peritoneal carcinomatosis with no extra peritoneal metastasis compared to patients having something extra in addition to peritoneal carcinomatosis. However, at least in my center, okay, we have high cytoreductive surgery and HIPIC program. You know that we have multiple surgeons doing the procedure. So usually, no, we are not treating those patients who are having extra peritoneal metastasis unless we have very limited metastasis, something like a solitary small lesion in the liver or so, a patient in good performance, and usually those patients, we start with some kind of systemic treatment first to address the biology of the tumor, and then in selected patients we may go for cytoreductive surgery in addition to local treatment to the liver. But usually in those patients, given that their prognosis, even the data that I presented, their prognosis is worse compared to patients with peritoneal carcinomatosis alone. So usually we don't go for liver surgery as well, just something like ablation to the liver lesion also.
Excellent. I have a question for you, Dr. Sharif, also with regard to the benefit of HIPIC plus cytoreductive surgery in those patients, because as far as I can tell from the slides that you presented, the study that showed survival benefit, it was in the era where we didn't used to have all these, new advances in systemic therapies, like the anti-GFR, for example, and to know about the restricted benefit of anti-GFR to a certain categories of colorectal cancer. So all of these things were not taken in account during this time when that study was published. So do you still believe that going that kind of surgery would add benefit?
I think we can agree, Dr. Ahmed, that for patients with metastatic colorectal cancer in general, we couldn't have long-term survival or potentiality for cure without having some sort of surgery. Okay, so systemic therapy alone in general can reach up to 3 years at best, or on average, you can say, without any kind of local therapy. However, even one of the data that I presented that about 16% of patients having cytoreductive surgery can enjoy 5-year survival. So on the other hand, even in the current modern era of systemic therapy, blood biologics, and so how many of our patients can live for 5 years with systemic therapy alone? So I think this question is valid. Maybe we need to look for something like that in a randomized fashion in the current era of modern therapies. But I still believe that without some sort of surgery, cytoreductive surgery in selected patients, the outcome will not be great even with current systemic therapies that we have.
Okay, but my question with regard to the addition of HIPEC on top of cytoreductive surgery, can we go just only with cytoreductive surgery plus the modern systemic therapies that we have?
Mm-hmm. So can we, in other words, can we omit HIPEC in general?
Exactly.
Okay. I think we don't have nowadays. We have evidence from 2003 and even retrospective data that cytoreductive surgery plus HIPEC compared to systemic therapy is fine. But we don't have clear evidence cytoreductive surgery plus HIPEC is superior to cytoreductive surgery. This evidence is lacking, actually. So I guess at the current moment of time, cytoreductive surgery alone should be our standard. We have some argument with our surgical colleagues, okay, about this point. They are still believing that the Prodigy 7 study have its limitation. There is some concerns about the design, the imbalance, the baseline characteristics. Well, you can say for many reasons about that. And even they started to move towards, previously they were giving oxaliplatin in many patients. However, nowadays they moved to mitomycin. And one of the points that have been said as an explanation of lack of benefit is about, if I remember well, about 30 to 40% of patients enrolled in the Prodigy 7 received the neoadjuvant chemo. And many of those patients received oxaliplatin-based chemo and then oxaliplatin-based HIPEC. So it may limit the outcome of HIPEC. So anyway, at least my center, they still believe that HIPEC is fine, but they moved to mitomycin in the majority of patients. Yeah. But myself, I did not see clear evidence for that.
Exactly. Just I want to, yes, please, do we have a question? Yes, we have at that corner. Yeah, Dr. Mervat, yeah, go ahead.
Thank you for all the speakers. So I do have actually the question to Prof. Prager regarding the HIPEC. So still here in Saudi Arabia, we are doing HIPEC for the patient and we are very selective. We are from 11 to 15. And in the meantime, we are giving neoadjuvant therapy followed by possible adjuvant based on post-surgery. So the main point that we know that in US, they are a little bit, the HIPEC is going back and the cytoreductive, it's mainly, and it's individualized. So my question to you as a European experience and also in your institute, are you guys still using HIPEC as a methodology for this patient? Specifically, we know that they are high-risk group.
Yeah, I think I cannot speak for all centers in Europe, but in respect of the clinical trials, I think we also became much more selective. There might be some histological subtypes who might be more reliable, like the mucinous carcinomas, who might be more reliable for cytoreductive surgery plus HIPEC. We, in our center, are only doing this measure with an perioperative systemic chemotherapy. So we do 3 months of systemic therapy, then a cytoreductive surgery plus HIPEC, and then continue the systemic treatment, as we think the systemic treatment is key for those patients with metastatic disease. But we became very, very selective.
Perfect. And if you allow me, Mr. Chairman, I want to ask about that. Thank you. That was great talk about the precision. So if we do have one of the patients who progressed, and we know that we do have the code break, we have distance study, and we now have also the positive study, which is the sunlight. So if the patient is the G12C positive or patient HER2 positive patient, and the patient progress, we don't have the data, and you are the PI and also published the sunlight. So we don't have a stratification for this patient to know that this patient, they have the same response after failure of sotorasib or the TDX for those patients. It was only based on the core group, and you can give us idea about this.
Yes, in the sunlight study, it was very selective. It was just second and third line patients. So no later lines. So the patients, the maximum had 2 lines of prior treatment. So saying this, we have seen in the subgroup analysis that independent of KRAS mutation, KRAS 12 mutation, etc., Sunlight was working. Okay, so the addition of bevacizumab did do a benefit and improving the OS significantly. So if we have now a patient like, let's say, G12C mutated or HER2 overexpressing, I mean, we as oncologists, we are very excited and we want to try new treatments. And I think there is an additional treatment line for those patients, and we should not spare this opportunity for these patients and provide this additional line of treatment to those patients with the rare molecular aberration. When it comes to sequence, as you were right, I mean, there is limited data on this. But me, myself, if I have a patient with G12C, I try to put this patient in a trial, and if there is no trial available, I try to offer the patient the G12C inhibitor plus anti-EGFR, because it's just an additional line of treatment where we see some responses. And then, as I've mentioned, the Sunlight protocol might be liable for those patients, either instead or afterwards.
Thank you.
Excellent. Thank you to Professor Prager. My question to Dr. Elizabeth Smith about what you presented about the different targeted therapies in gastric cancer. We are now, I think, talking about era where we have like several targets that can be tested in the first line. You mentioned something about the Claudin 18.2, which can be overexpressed with other like biomarkers or predicting biomarkers. So my question to you, if we have a patient who has like 2 predictive biomarkers that are like overexpressed, what is your preference, or what is the sequence of treatment you're gonna go for? I know that now if we have like a PD-L1 positive and HER2 positive, we can go combination as the Keynote 811. But what about the Claudin 18.2 with regard to overexpression with other biomarkers?
Thank you for your question. I think this is the question that everybody is asking right now, but especially because Claudin 18 is really a passenger on tumors. It's not causing the tumor to behave in any specific way, so it is constantly overexpressed with other biomarkers. For HER2 and Claudin 18.2, I think the answer is easy. So the best treatment for HER2 positive patients remains trastuzumab plus or minus pembrolizumab, because these patients were not included in the Claudin 18.2 studies. For immune checkpoint inhibitors, I think the question is a little more interesting. We don't have a trial that demonstrates safety or efficacy of adding immune checkpoint inhibitors to zolbetuximab. So the question is rather, which is the best treatment for patients? And I think this is a very individualized answer. So for me, I think there is clear evidence that Claudin is effective. Targeting Claudin is effective, as is targeting PD-L1. We know that the best benefit for PD-L1 is in patients with a CPS score of 5 or greater. In Europe, in fact, we are limited really in terms of funding to CPS 5. CPS 1 plus may come. There is a license, but it's not yet funded in a lot of countries. So for me, if a patient is CPS 5 or greater, or even 10 or greater, immune checkpoint inhibitors do lead to long-term benefits, and they're well proven. If a patient is CPS less than 5, I think that probably Claudin 18.2 might be a better choice, because I think that the benefit depends on from the immune checkpoint inhibitors really depends on the T-cell infiltrate. However, I think we need to be careful in interpreting any of the results. The results, for example, from the zolbetuximab studies relating to PD-L1 expression could be a little biased in that patients with PD-L1 positivity may not have been enrolled in those studies. So I think in future, we may be able to combine. We can't just throw PD-1 inhibitors in with immune checkpoint inhibitors. We need to carefully analyze which groups of patients benefit. I think that's been well demonstrated in the HER2 positive studies with Keynote 811. So my answer is it's on a per patient basis. So with a CPS score of less than 5, I'm less convinced of the benefits of immune checkpoint inhibitors. So when zolbetuximab gets a license, that's a conversation to have with your patient. We should note, though, that there's no license yet, although I hope that that will happen later this year. More choices are good. It means more difficult conversations, more challenging conversations, and patients will become also more informed about their results.
Thank you so much for this thorough answer. I think we came to the end of this session. After a thorough discussion, I would like to thank all of the speakers, Professor Prager, Dr. Sharif Al-Samman, Dr. Ashwaq Al-Ulayyan, who left us, and of course, Dr. Elizabeth Smith, for their valuable talks, and also for all of the attendees. It's my pleasure now to actually invite the moderators for the next session. Dr. Mervat Mahrous, Dr. Hamad Al-Hussein, Dr. Turki Al-Faya, and Dr. Abdullah Al-Tuwergi to moderate the next session, which would be lung cancer.
Thank you.
السلام عليكم. السلام عليكم. السلام عليكم. Good evening, everyone. Thank you, Ahmed. And it's the time to start the lung cancer precision oncology session. Let me introduce myself. I'm Turki Al-Faya, oncology consultant working at National Guard Hospital in Riyadh. And along with my colleagues, Dr. Mervat Mahrous and Dr. Hamid Al-Husseini, we're gonna conduct this important session about lung cancer. There will be very important topics to be covered by very eminent speakers internationally coming from different parts of the world. So I would like to thank the scientific committee for choosing these topics, and also the organizing committee for the great hospitality. So just one comment, we will leave the questions and comments at the end. Another thing, we will move one of the talks a little bit earlier. Dr. Yasser Al-Amin will have 2 talks back to back, and then we'll resume the schedule. So I'm gonna start to present the first speaker, Dr. Mehmet Altan. He is a well-known thoracic oncologist working at MD Anderson Cancer Center. He is well-known also in the field of immuno-oncology. He works hard with a lot of works and researches in the field of immuno-oncology, especially in the resistance of immuno-oncology, and especially the PD-1 and PD-L1 inhibitors. So the Dr. Mehmet need to come. Thank you. Thank you so much. Thank you so
much. First of all, I'd like to thank the organizing committee to give me this opportunity. It's the first time for me to be in this holy place, and I'm very grateful for the invitation. So today I will talk about the first-line systemic therapy for advanced metastatic non-small cell lung cancer in the immunotherapy era. Over the last 2 decades, the treatment paradigm has significantly changed, and I would like to summarize some of those changes in my talk. So, as we all know, this is the beginning of the lung presentation. Lung cancer being one of the most morbid oncologic diseases. It is a worldwide problem with over 1.8 million new cases and 1.6 million deaths every year. So in the years 2000s, for patients who do not have any local definitive treatment options, the standard of care was chemotherapy, and there were a number of chemotherapy agents in combination, single agent or as triplet studied. And this was one of those landmark studies in 2000s, looking at different platinum doublets and looking at overall survival. I don't know if you can see, well. And there was not a significant difference between these combinations, but what we can see is the median overall survival was very poor, 8 months, and 1 year survival, 35%. This was still the treatment opportunity with an improvement in OS and PFS, but there was a really significant space for improvement. And there were no clear efficacy benefit for non-platinum combinations or triplets. So in 2004, after the recognition of EGFR activating mutations and 2 targeted therapies, the biomarker analysis, so the mutational testing, particularly in lung adenocarcinomas, became standard of care. And now we do have a number of drivers mutations that we can identify, particularly in lung adenocarcinomas. And there are a number of targeted therapies which revolutionize the treatment. The problem is we don't have prime-time medications for many of patients, and generally targeted therapies do not generate a durable response. So there is a still great need for alternative approaches. And that's why immunotherapy is very exciting, because if you think about the immune system, our immune system has specificity, it's an adaptable system, but it has a memory, so there are very important aspects that's really relevant for the treatment of cancer. And if we think about our immune response, there are multiple steps from step 1 to 7, as you can see in this diagram, that plays a role. So after the release of neoantigens, the cancer antigen presentation it goes to the lymph nodes or primary lymphoid organs. And there is generally an MHC-restricted presentation of these peptides related with the neoantigens that generates T-cell clones against the tumor. And there is a trafficking via bloodstream. And these T-cells that goes to the tumor microenvironment and generate a cytotoxic T-cell killing basically by interferon gamma. And there are a number of pathways that facilitates this. As you can see, number of cytokines, inflammatory markers, as well as granzymes are playing a role in this activation. But just like many things in our body, there is a balancing mechanism, and there are a number of breaks in the immune system, and sometimes this can be used by the cancer cells. As you can see, some inflammatory cytokines, chemokines, and certain checkpoints that are playing a role in this inhibition. As you can see on number 3, CTLA-4 is an important pathway in tumor priming and tumor cell-generated T-cell priming, as well as in the tumor microenvironment. PD-L1 is an important element. But we can see there are a number of exciting targets that currently, many of them are under investigation. So the most commonly utilized therapies currently in terms of immunotherapy are, of course, PD-L1 inhibitors, as well as anti-CTLA-4 antibodies inhibitors. So if we think about how they work, if you look at the left part of this graph, usually when an antigen-presenting cells recognize a T-cell, through a T-cell recognizes antigen-presenting cell, the new peptide is presented with MHC, there needs to be a co-stimulatory pathway that is needed to activate the T-cells, to increase the number of T-cells, and to help on trafficking. And this co-stimulator pathway is CD8086 with CD28. CD28 is a ligand. And this activates the T-cell and stimulates the T-cell. But as soon as this happens, there is a decoy receptor, which is called CTLA-4, starts to generate. And it has a higher binding affinity, so it binds to CD86, and it stops this activation. So the drugs that can block CTLA-4, especially during this priming, can unleash the immune activation. In the tumor microenvironment, which is the second part of this graph, there is an inhibitor pathway when there is a MHC-restricted T-cell receptor peptide presentation. PD-1, PD-L1 engages, and this generates an inhibitory signal. So antibodies that blocks this pathway, of course, reinvigorates the immune activation. So these drugs start to be studied in the late 2000s. 2011 was the year that ipilimumab got the FDA approval for melanoma, 2014 for nivolumab. Of course, melanoma is a very immune hot disease with no chemotherapy options at that point of time. And the next quest was to look in other solid tumors where treatment options were limited, and non-small cell lung cancer was the ideal one. In 2012, 2013, these studies have been activated, which is looking at that point of time,
second-line standard treatment option, docetaxel, compared with nivolumab, which is an anti-PD-1 inhibitor in squamous cell carcinoma and non-squamous cell carcinomas. So at that point of time, the bar was really low because the response rate DOSI is generally less than 10%. So in this setting, nivolumab showed an overall survival benefit in both of these groups, and the 12-month overall survival was 42% in nivolumab versus 24% in DOSI. For squamous cell carcinoma, 51 versus 39% in the non-squamous cell carcinoma, and this led to FDA approval for the second-line treatment of non-small cell lung cancer for patients who do not have activating mutations. At the same time, another drug company was working on pembrolizumab. KEYNOTE-001 was their initial study, and in that study, the drug company identified that there can be a biomarker that can be used for patient selections. They had a DACO2-C3 antibody, and for tumors that is expressing PD-L1, they did see increased responses. So in this design, they used this antibody for trial eligibility. So this became a companion diagnostic test for their trial, and they looked at 2 different doses of pembrolizumab versus docetaxel for patients who received, progressed, or did not tolerate platinum doublet treatment. And in this setting, they did look 1 to 49% of tumor proportional score of PD-L1, or more than 50%. This was their stratification. And this study, particularly in the high PD-L1 expressing tumors, shows increased response rates as well as an improved overall survival. This also was shown in tumors that are showing more than 1% of PD-L1. Because especially this was a very remarkable result, the result that they saw in TPS more than 50% or above tumors expressing PD-L1, this led the design of KEYNOTE-24 study. In this study, a biomarker selected PD-L1 high protein expressing tumors was the target population. Again, this study was designed in advanced metastatic non-small cell lung cancer where patients did not have any definitive treatment option. In this study, the control arm was platinum doublet, so this was a first-line study. And this study allowed crossover. So for patients who progressed on platinum-based chemotherapy, were allowed to go to pembrolizumab, and 2/3 of the patients actually did crossover. And the primary endpoint was progression-free survival. Just as an important note, in this study population, the PD-L1 50% or above was identified in 30% of the patient samples. So in reference studies, this is around 20 to 30%, more like 25%. In this study, it was 30%. So 70% patients who were screened could not enroll to this clinical trial. And there was a remarkable progression-free survival advantage as well as overall survival benefit in this biomarker-selected patient population, which led to FDA approval for the first-line metastatic non-small cell lung cancer treatment with pembrolizumab in PD-L1 high-expressing tumors. So the second study was looking the companion diagnostic test in a more generous way. This study was designed to look at patients who had PD-L1 protein expression of 1% or above, and this study did not allow crossover, so only 1/4 of the patients actually did receive pembrolizumab after the progression on platinum-based chemotherapy, because at that point of time, the study was done in Eastern Europe, Asia, where PD-L1, PD-1 targeted therapies were not standard of care. So this study in all patient cohorts, so in the intent to treat patient population, did show an overall survival benefit of single agent with pembrolizumab compared with platinum doublet. But this was mainly enriched because of the responses that are observed in high PD-L1 expressing tumors. In a subcohort analysis for PD-L1 TPS 1 to 49%, did not have the same advantage. It was not inferior, but there was not a statistical significance between the treatment arms with hazard ratio 0.92 and confidence interval 95% crossing over 1. So at the same time, there were lots of efforts to see how we can add immunotherapy to our treatment paradigm in early stage, in the treatment course. and being more inclusive. So one of the things is if we can combine chemotherapy with immunotherapy. Immunotherapy and chemotherapy have unique effects, and treatment toxicities do not overlap. So it did bring this opportunity, and this has been studied in a number of studies. I just put 2 of these studies, Keynote 407. This was a landmark study for squamous cell carcinoma, and Keynote 189 that was for non-squamous cell carcinoma. And they did use, these studies use platinum doublet with pembrolizumab, which is anti-PD-1 therapy, and the comparator arm was chemotherapy, and there was no selection for patients with a companion diagnostic test, so this was for all comers. And this study, as you can see, very small fonts in the very end for both of the study. The overall survival benefit was observed in both of the studies. OS was 15.9 median OS versus 11.3 for the squamous cell carcinoma, and in the second study, in Keynote study, the overall survival is overall survival of 12 months was 69% versus 59%. And more important, these studies showed that this approach can be used in PD-L1 negative or low protein expressing tumors. And this was observed in both of the cohorts. As you can see, in PD-L1 tumor proportional score of less than 1%, patients benefited compared with chemotherapy alone when immunotherapy has been added to chemotherapy. At the same time, there was this second immunotherapy, as we mentioned, which was actually the first one that has been FDA approved, ipilimumab. And one of the questions is, can we generate a chemotherapy-sparing treatment option for the patients? And Checkmate 227 investigated this. This was initially studied in Checkmate 012. There was some promising findings, and this was a dose-finding study. And in Checkmate 227, patients who have tumor proportional score of 1, actually this is from a different company, so PD-L1 1% or above, it's not tumor proportional score, it's looking at the still tumor protein expression of PD-L1, randomized to Nivo-IP. Nivolumab is an anti-PD-1 drug, ipilimumab, which is an anti-CTLA-4, compared with platinum doublet for 4 cycles versus nivolumab. Nivolumab arm was stopped after the findings from Checkmate 026, which showed some negative findings. So these 2 arms, combination of anti-PD-L1 and anti-CTLA-4 versus chemotherapy, was studied in metastatic setting. And this study showed that combination of this dual checkpoint inhibition had an overall survival benefit compared with chemotherapy, which also led the FDA approval of this treatment regimen. So again, this study looked at tumor PD-L1 expression 1% or above. I just want to highlight the Kaplan-Meier overall survival curve. There is a crossover in the early stages of the treatment, which I will talk about it in the next slides. So one of the interesting findings of Checkmate 227, the response rates was higher with ipilimumab and nivolumab, and duration of response was pretty long. So for patients who responded to this treatment, responded almost as a median 2 years. And beyond 2 years, 50% of the patients still continue to respond. So this durability and potential role of anti-CTLA-4 in development of memory was something that has been considered and has been currently actively studied in clinical trials. Well, as I mentioned, in the Kaplan-Meier survival curves, the Checkmate 227, the last study I mentioned, is on the right-hand side, and the Keynote 402, which was a study that I discussed earlier, this was also for PD-L1 1% or above patients. There is an increased early deaths in the patient population. So this is related with 2 things. Number one, immunotherapy can start working with a delay. The second thing, for patients who have high disease burden may not have a second option. So we do see early progression and transient higher death rates compared with the chemotherapy arms. That led studies exploring combinations with immune checkpoint inhibitors, but rather than a full course of chemotherapy, with an abbreviated course of chemotherapy, which led to design of Checkmate 9LA. This gave the Checkmate 2 regimen, which is nivolumab, 360 every 3 weeks, ipilimumab 1 milligram per kilogram for every 6 weeks, And 2 courses, not 4, not 6, only 2 courses of platinum doublet compared with 4 cycles of standard of care platinum doublet with PEM maintenance for adenocarcinoma. Primary endpoint was overall survival. And again, yet this study showed an improvement compared with chemotherapy, with 12 months overall survival, 63%. And again, duration of response also in the study pretty notable. But of course, as much as we add more and more drugs, we need to talk about the toxicity. So it's not the main focus of this study, but I just want to highlight that, of course, while we don't see overlapping toxicities because of the additive toxicity rates in this study, where we combine Nivo-IP with 2 cycles of chemotherapy, the serious treatment-related adverse events were seen in 1/4 of the patients, and there were 2% of the patients who had treatment-related deaths, some of which were related with chemotherapy, but some of them are related with immunotherapy, such as pneumonitis, hepatic toxicity, diarrhea, colitis. So this is the current landscape. I just try to summarize as much as I can, but now it is a difficult time because we have a number of options. For high PD-L1 expressing tumors, we have pembrolizumab, atezolizumab, which is an anti-PD-L1 antibody, and cemiplimab. They all been studied against chemotherapy and showed improved outcome and got their FDA approval. For patients who have PD-L1 more than 1% or equal, we do have pembrolizumab per Keynote 402 and Checkmate 227 led the FDA approval for ipilimumab and nivolumab up to 2 years. And we do have a number of clinical trials showed an improvement in non-selected patient population that combines platinum doublet plus immunotherapy, platinum doublet plus immunotherapy plus anti-VEGF, or combination of CTLA-4, PD-L1 targeted therapies plus chemotherapy in an abbreviated course or with a full dose with Poseidon. So how we can do our treatment selections, there are still needs to be defined criteria for better patient selection, but what we know so far is there is a group of patients who may benefit from addition of chemotherapy, and these are patients with high disease burden, low negative PD-L1, non-smokers. We know these tumors generally do not generate as much neoantigens and not less immunogenic. Chronic steroid use, if prednisone use is daily more than 10 milligram for any indication that can decrease the immunotherapy effectiveness. And we know certain driver mutations also decrease the effectiveness of immunotherapy, so those patients benefit from chemotherapy plus minus anti-VEGF. And for patients who may benefit for dual checkpoint inhibition is another important question, because again, this step-up regimen comes with the cost of toxicity. And there might be some co-mutations that can drive some benefit by addition of anti-CTLA-4. So the Poseidon study, which is looking durva-tremi, so that is 2 drugs targeting PD-1 and CTLA-4. When we look at co-mutational profile, I just want you to look at the first group, which is dual checkpoint inhibition with platinum doublet, and the second one that is anti-PD-L1 with chemotherapy. The median progression-free survival overall response rate have been inferior in the non-CTLA-4 therapy arm. So there might be certain co-mutations that can be effective. And this is my last slide. So we are still on the very scratching the surface of the immunotherapy. There are a number of immune checkpoints. There are a number of ways that tumor cells may not cause immunogenicity. So there has been a lot of efforts to inflame these tumors, try to generate more T-cell clones against tumors, and it is a very exciting time. So thank you very much for listening.
So thank you, Dr. Mehmet, for the nice review. We'll keep the question at the end. So it is my pleasure to introduce the second speaker, Dr. Yasser Al-Amin. He's a thoracic medical oncologist and clinical investigator at the University of Texas, MD Anderson Cancer Center in Houston. He's the director of the Thoracic Head and Neck Medical Oncology Fellowship Program. His research is mainly focused in oncogene-addicted lung cancer. The first talk will be about precision oncology in the oncogenic-addicted lung cancer. So welcome, Dr. Yasser.
Thank you. Bismillah ar-Rahman ar-Rahim. Ms. Chairwoman, Scientific Committee, dear colleagues, thanks a lot for inviting me today. I'm very happy to be here back in the kingdom after so many years. to see the great transformation that's happening. So thanks for the invite. I'll talk to you today about precision medicine in lung cancer. And I'll split my talk to focus initially on the mutations, then I'll speak about the gene rearrangements. Here are my conflict of interest. And I would like to start with a quick background and then some key concepts that are shared between all these genetic alterations. Then I'll spend the bulk of the talk to talk about specific trials that address those mutations. You've seen this figure from Dr. Alton's presentation, and we all remember the days when we used to treat lung cancer patients with platinum-based chemotherapy. But now with the wide use of next-generation sequencing, we're starting to discover that lung cancer is not the same. And the slices are getting smaller and smaller. And now we're reaching a point where we're discovering that even within an EGFR mutation or an ALK gene rearrangement or a RET gene rearrangement, not all these alterations are the same. So we're really, really getting closer and closer to individualizing the care for our patients. In lung cancer, we do see changes in tyrosine kinase receptors. These changes happen mostly through mutations. Mutations can be point mutations, like the ones we see in EGFR. They can be skipping mutations, like the one that we see in MET, or insertions, like the ones that we see in EGFR. Those alterations activate downstream signaling through the MAP kinase pathway or through the PI3 kinase pathway, leading to cell survival and proliferation. The other common mechanism by which we see activation of tyrosine kinase receptors in the context of lung cancer is gene rearrangement, and we see this either intrachromosomally or intrachromosomally, so either within the same chromosome or by exchanging the genetic material between two separate chromosomes. A key concept also to grasp here is that these alterations are ultra-sensitive to tyrosine kinase inhibition. So this figure here from a fantastic review by Trevor Bivona in 2016, showing that if you get the right TKI, you will get a waterfall plot like this one, where the overwhelming majority of patients will achieve a response. Yes, it's true that the majority of these responses, are, as shown here in blue, are incomplete, but the bottom line that most patients do respond to this treatment. A slim minority, shown here in red, will have intrinsic resistance. So if you look at an EGFR cohort of patients or ALK cohort of patients treated with a TKI, you will see a waterfall plot like this. A feature that is shared among all these tyrosine kinases as well is that they are invariably ending up with resistance. And the acquired resistance can be either pharmacological, so a patient not compliant with their treatment, or due to CNS failure. But more commonly, it's a biological resistance. And the biological resistance, broadly speaking, can happen as a result of the change in the target itself, so EGFR acquiring a mutation, or ALK acquiring a secondary mutation, and so on, or by the cancer cell developing a bypass mechanism. So MET amplification, for instance, in the case of EGFR. Majority of patients will develop resistance, and they typically develop it by one of these tracks. Another track that, not shown in the figure, but typed there, is the histologic transformation. We do see adenocarcinomas transform into squamous or to small cell following treatment with a TKI. Here is a list of the targets that we currently have either FDA-approved TKIs for, or very promising drugs that are in clinical development. And I'll go through some of them. Obviously, the most common one is EGFR mutations. The relevant EGFR mutations are seen in the tyrosine kinase domain, so between exon 18 to exon 24. The vast majority are point mutations in exon 21 and deletions in exon 19. So this is what we mean by classical EGFR mutation. It exclusively means exon 21 and exon 19 deletions. The rest are all atypical. And they're seen in never smokers and females, as most of you here already know. This is, again, a repetition of what I just said, but I just want here to highlight the further division of the atypical or non-traditional EGFR mutations, which represent only around 10% to 20% of all EGFR mutations, and they can be divided into two big groups. The big group of exon 20 insertions, and the other one are rare point mutations that are non-21 and non-19. So if we speak about classical EGFR mutations, we're all aware of the 6 big randomized clinical trials that showed the superiority of EGFR TKIs over platinum-based chemotherapy. And as a result of that, all across the world, we're using EGFR TKIs as a standard of care for EGFR mutations. More recently, we've seen the FLORA data, which established osimertinib as the frontline treatment for EGFR mutations. FLORA included patients with classical EGFR mutations and randomized patients to OSI versus a first-generation EGFR inhibitor. And the trial showed superiority of osimertinib in terms of OS and in terms of PFS. And as a result, OSI has become the standard of care. It took us so many years to try to decrown osimertinib from its position as the best treatment to go to. And that is started by the FLORA-2 study. The FLORA-2 used a very similar design to the one that we have seen with FLORA-1, which is essentially taking classical EGFR mutations, randomizing them to osimertinib, which was the standard of care at the time, versus osimertinib plus chemotherapy. The data was presented by Passiani a few months ago in World Lung. The primary endpoint here was PFS. And you could see here that the PFS by investigator assessment was positive, favoring osimertinib plus platinum-based chemotherapy with a PFS of 25.5 months and a hazard ratio of 0.62. What was interesting about this study is that they looked at patients based on the presence of CNS disease. So if you see that for patients who are without CNS metastasis, the curves are overlapping, and the hazard ratio is 0.71, crossing the one boundary here, while if you look at those with CNS metastasis, you see a beautiful hazard ratio of 0.47 and clear separation of the curves. So whether this is a clinical biomarker that we could use to pick which of our patients we are going to be offering the addition of platinum chemotherapy on top of an EGFR. And here it's important to remember that an EGFR TKI is an oral pill. You give it to the patient. The patient will typically live a very normal life, come to see you once every 3 months. Here you're committing them to chemotherapy to come to see you every 3 weeks with all the toxicities associated with chemotherapy. So we really need to figure out who really needs chemotherapy. The other important trial in this context that was recently presented at ESMO was the Mariposa trial. It used osimertinib versus amivantamab plus lazertinib. Lazertinib is a next-generation EGFR inhibitor. Amivantamab is a bispecific EGFR-MET monoclonal antibody. There was a third arm of lazertinib as a single agent. Again, very similar to FLORA and FLORA-2. It included patients with classical EGFR mutations, and the primary endpoint was PFS as well. Here again, we do see that irrespective of the presence of CNS metastasis, that AMI and laser have beaten up osimertinib with an identical hazard ratio despite the presence or the absence of brain metastasis. While the overall survival data is not mature yet, it's clearly suggesting that a favorable trend towards favoring amivantamab and lazertinib. Here, this slide that I like a lot by Dr. Petroskova, when discussing the prior presentation, you could see here the 3 options that we currently have in the clinic, or potentially we may have in the clinic. Of course, osimertinib and osimertinib plus chemo are available, say in the United States. Amivantamab and laser are still not FDA approved, but we do expect to see them approved hopefully soon. You could see how each strategy is performing here. And I think, again, just like what we say in oncology, a decision around which strategy to use will have to be individualized after discussing with that patient. So this is what we do in frontline EGFR mutant. What about second line? In the second line, I think the most notable recent trial was Mariposa-2, which used patients who failed osimertinib and randomized patients here to amivantamab, lazertinib plus chemotherapy versus just chemotherapy, which was our standard of care. Here you could see that both experimental arms, amivantamab, lazertinib plus chemotherapy, and amivantamab, lazertinib did beat chemotherapy by itself. Again, this regimen is not approved by the FDA yet, but in theory, you could use amivantamab and chemotherapy because they are all approved by the FDA currently. The superiority was not limited only to PFS. We've seen superiority as well in terms of OR. The objective response rate in the amivantamab plus chemotherapy arm was 64%, and in the amivantamab plus laser and chemotherapy was also 63%. So this concludes EGFR mutation, which is the most common target. And now we want to move to the atypical EGFR mutations, or the classical, non-classical EGFR mutations. And again, just a refresher, we split these into two big groups. First, the exon 20 insertions, and the second group is the rare point mutations or the complex mutations. The best data we have now for the rare point mutations, so these are things like G719 and S768I and so on, comes from the meta-analysis from the LongLux trials. It was it's a very small number of patients, only 38 patients, but in this meta-analysis, we saw that afatinib really performs well with an objective response rate of 71%, PFS of close to 11 months, and a duration of response of 11 months. And based on only these 38 patients, the FDA approved afatinib to be used in these patients. It's the only FDA-approved TKI for rare atypical EGFR mutations currently. Of course, there are several drugs that are in development now, but afatinib remains the one that is approved. How about the other 50%, which is the exon 20 insertions? This is really the difficult to treat EGFR mutations. And many years ago, we published this retrospective analysis showing that, here shown in the red, the exon 20 insertions do not respond to classical or to EGFR TKIs like gefitinib, erlotinib, and so on. And you could see here among the very few patients that we've did RECIST on, there was only one who responded. Moreover, in the lab, if you express exon 20 insertions in BAF3 cells and you treat them with first-generation TKIs, second-generation TKIs, or third-generation TKIs, you see that those cells are resistant to these TKIs. And the reason behind that, this is the drug binding pocket in a classical EGFR mutation versus an insertion. You could see here the drug shown in blue fitting very nicely in the drug binding pocket, leading to the drug being effective. While if you look here to your right-hand side, you see in red balloon the insertion is bulging, prohibiting the drug from getting to the drug binding pocket. And this is the reason behind the resistance of these insertions to TKIs that we have. A few years ago also we studied a drug called poziotinib. It's an EGFR TKI. And what we learned from this study is that exon 20 insertions are not all born the same, that you could divide them further depending on their locations. So for insertions up to 772, we call these near loop. Any insertion after 772, we call that far loop insertion. And you could see here in panel B that the efficacy of TKIs in the near loop is has an objective response rate of 46% compared to 0% in far loop. And if you look for that's clearly, no matter how you look at that, it's consistent all across, based on objective response, based on RECIST response, and based on PFS as well, although PFS here did not reach statistical significance, but the pattern is very clear that you could split exon 20 insertions into near loop and far loop. So how do you treat these? Recently, we've seen this practice change in trial, the Papillion trial, which has studied chemotherapy, which used to be the standard of care at the time, versus chemotherapy plus amivantamab for exon 20 insertions. So these were patients who were previously untreated, so treatment naive, and randomized to one of the two arms with the primary endpoint of PFS. You could see here this beautiful figure showing that there has clear superiority of amivantamab plus chemotherapy with a hazard ratio of 0.4 and a median PFS of 11 months versus 6.7 months. So finally, we're seeing that those insertions are getting closer to the efficacy that we are seeing, or to the outcomes that we're seeing with classical EGFR mutations. And this is confirmed here on the response rate, 73% versus 47%. And although the overall survival data is not mature yet, but you could see here clearly it's trending towards superiority of amivantamab. So I do think that based on this trial, the combination of amivantamab plus chemotherapy is certainly a standard of care options for those difficult to treat patients. This is the original amivantamab trial when it was studied as a single agent. So these for patients who failed platinum chemotherapy. You could still treat them with amivantamab as a single agent. This is the data that was presented by Kunshil Park a few years ago, and it was in 81 patients with a response rate of 40% and a duration of response of 11 months. And here you could see what I was referring to earlier, that numerically, the near loop shown in red here have an objective response rate of 41%, while if you look at the far loop, the objective response is 25%. So what about TKI? Of course, TKIs. What about TKIs? Because amivantamab is an IV drug that has a lot of toxicity, profound skin toxicity and diarrhea. Most patients invariably lose their hair. We haven't lost hope in TKIs to be able to solve this problem. In last ASCO, we've seen the very promising data from sunvozertinib, and we need all to train ourselves how to pronounce it. They've shown that response rate was high, irrespective of the location of the insertion, although there was a kind of a slight numerical difference, but in near loop, the objective response rate was 62%, and for far loop, 54%. And although not shown here, they did show in their presentation that there was an indication that this drug has CNS activity, which is very important for these patients, since this CNS is a site of failure usually. So this concludes EGFR. If we want to move to a mutation that is very close to EGFR, exon 20 in particular, which is HER2 mutations. HER2 mutations, we see them in less than 2% of lung cancers. The most common one is the YVMA insertion at exon 20 of HER2, and there's a great deal of similarity between EGFR exon 20 and HER2 exon 20. They behave the same in their resistance to TKIs. The drug that we have now approved by the FDA is trastuzumab deruxtecan, which has an objective response rate of 55% and a PFS of 8 months with a duration of response of 9.3 months. What about TKIs? A few years ago, we also studied POSIO in this context. The efficacy of the drug was modest, with an objective response rate of 27% and a PFS of 5.5 months with a profound toxicity. However, now there are more next generation inhibitors. There is an inhibitor, I think, from BI, from Bayer. All of these are in clinical development, and hopefully they will raise the bar and have better efficacy and less side effects. Of course, the single most important addition in lung cancer oncology after immunotherapy is the discovery of KRAS inhibitors. KRAS is, of course, is a very common mutation in lung cancer. It's linked to smoking, and particularly at G12C, which represents around 40% of all KRAS mutations in lung cancer. So the discovery of G12C covalent inhibitor was a major breakthrough. We all remember the days when we used to call KRAS is undruggable. So, of course, this is not the case anymore. We've seen the data of sotorasib and adagrasib, both approved now by the FDA with data that is almost identical, with an objective response rate of 37% with sotorasib and 42% with adagrasib. Of course, we're fully aware that the randomized trial of sotorasib versus docetaxel was a negative one, but again, these drugs are better tolerated, generally speaking, when compared to docetaxel. And now we're also seeing the newer KRAS inhibitors from Novartis and from other companies as well. I will conclude by one of the rare alterations that is MET exon 14 skipping mutations. These are enriched in sarcomatoid lung cancer. We have two drugs that are approved by the FDA in this context. The first one is tepotinib, which results in an objective response rate of 46%. And the second one is capmatinib, again with almost identical objective response rate. Similarly to the KRAS inhibitors. We're seeing now next generation MET inhibitors also come into clinical development. With that, I would like to move to the other common alterations that we see in lung cancer, which are lung cancer with gene rearrangements. One of them is ALK, which we see in perhaps around 2% of lung cancers, again, enriched in females, never smokers, and so on. It results due to the fusion of the ALK gene with the ML4 gene, and it depends on the location of the fusion. You could subdivide them into variants. The most two common variants are variant 1 and variant 3. Variant 1 results from the fusion of exon 20 of ALK and exon 13 of EML4, while variant 3 from the fusion of exon 20 of ALK with the exon 6 of EML4. There are some biological and clinical differences between the two when it comes to the response to TKIs and so on. And just like we have seen with EGFR mutations, platinum-based chemotherapy was the standard of care until first-generation ALK inhibitors were developed. Crizotinib established itself as the standard of care. And following that, we've seen a number of next-generation ALK inhibitors. So far, we have 4 ALK inhibitors. All of them did beat crizotinib in the frontline setting. You have the alectinib in the ALEX trial, brigatinib in the ALTA-1L trial, and lorlatinib in the CROWN trial. All these 3 drugs are now approved by the FDA in the frontline setting. Ensartinib, although the trial was positive, but it's under review by the FDA now, and we expect it perhaps to be approved as well. You could see that these, the PFS here, if you look at the brigatinib data and the alectinib data, the hazard ratio is there 0.49, here 0.47, here with the ensartinib 0.51. So all these 3 figures, they look almost identical. I know that we are not supposed to, compare between trials, but we are going to do it anyway. Because here you could tell that with lorlatinib, the hazard ratio is bigger. The separation of the curves is bigger. So a lot of oncologists would read that as lorlatinib being slightly a better drug when compared to alectinib and brigatinib. Before the CROWN data was published in America, certainly alectinib and brigatinib were the most common ALK inhibitors used, but I think lorlatinib is gradually building momentum despite its profound toxicities when it comes to CNS toxicity and lower limb edema and so forth. What's important also about these things, about these drugs, that they have great objective response rate, obviously, and great intracranial activity. These drugs are super effective. Their clinical benefit are seen in the patient in dramatic ways in terms of how quick it can take place. So acquired resistance to ALK, just like with EGFR, and just like we discussed earlier, can be mediated either by on-target alterations, so an acquired mutation in ALK, and commonly that would be G12O2R, and all by development of bypass signaling, shown here by KIT amplification and other alterations that we see, even KRAS amplification and MET amplification and so on. We do also see with ALK inhibitors sometimes transformation to small cell or to squamous cell. So how do you treat patients who failed, say, alectinib or brigatinib? The data of lorlatinib, which was originally developed in the context of following treatment with alectinib and brigatinib, show that lorlatinib is an effective option there. It's approved by the FDA. However, in my practice, I do differentiate between patients who acquire the mutation following treatment with alectinib. So if a patient acquires, say, G1202R after treatment with alectinib, I think it's very reasonable to treat them with lorlatinib because the objective response rate there is 69%, while if they did not acquire ALK mutation, which suggests that they may have developed a bypass signaling mechanism, the response rate is only 27%. And that's also true when it comes to PFS. Having said that, the FDA does not differentiate. It does allow it for both patient population. I do think that the data suggests that this is, lorlatinib is more effective on those with acquired mutation. That's why I typically use it in that context, at least initially only. One other gene rearrangement that we do see in clinic, although rarely, is ROS rearrangement. This is a tyrosine kinase of the insulin receptor family. It's less than, certainly around 2% or less of lung cancer patients. Again, it's characterized by ultra-sensitivity to ROS1 inhibitors. Crizotinib is approved here with an objective response rate of 72% and a duration of response of 17.6 response and a median PFS of 19 months. The other drug that is approved in this context is entrectinib. Entrectinib, in my opinion, is superior to crizotinib when it comes to its CNS activity and also a longer duration of response. However, both of the two drugs are approved by the FDA, and lorlatinib can be used in the context of patients who failed TKI therapy, and particularly those who failed crizotinib. More recently, we've seen the FDA approval of repotrectinib. Repotrectinib resulted in an objective response rate of closer to 80%, again with convincing CNS data and with reasonable toxicity profile. All these drugs share that they cause dizziness and other side effects, neurological symptoms as well. Just like we have seen with ALK and with EGFR, resistance is inevitable, and it can be driven by, again, acquired mutations. Most commonly, the G2032 are shown here in the, if I could get the, as a cause of resistance to these drugs, whether crizotinib or lorlatinib and so on. And one of the most important development in this context is the development of NVL-520 and telarectinib. Those two drugs are next generation ROS1 inhibitors with great efficacy in both ROS fusion without a secondary mutation and also in the presence of G2032R. Moving to more rare alterations is RET. RET is another gene rearrangement that is seen in approximately 1 to 2% of lung cancer patients. The common fusion partner here is KIF5B. We have recently presented at ESMO the data of Liberto 043, which compared selpercatinib, a specific RET inhibitor, versus chemotherapy with or without chemotherapy. The trial was positive in terms of the primary end point with PFS. This is in the, so the trial allowed physician discretion to give pembro or no pembro in the frontline setting. So if you look here at to your left-hand side, in the pembro population, the trial was profoundly positive with a hazard ratio of 0.46, and also in patients who've received chemotherapy only, it was also positive in terms of PFS. That was the case also for objective response rate, very convincing objective response rate, 83% versus in the control arm, 65%. This is slightly higher than what we normally see with just platinum-based chemotherapy. So the control arm here really did overperform. The other drug that we have approval for here is praseltinib, and very similar data to the ones that were shown with selpercatinib, very high objective response rate, very long duration of response. Now, really moving to more rare and rare alteration is NTRK fusions. I see 1 to 2 of these a year, so they're exceedingly rare. We have 2 drugs that are approved by the FDA, lalotrectinib and entrectinib. We do have other agents that are in clinical development, including one by Loxo Lilly and so on. I will conclude with NRG1 fusions. NRG1 fusions are seen in 0.2% of lung cancers. They are enriched in mucinous adenocarcinomas, and we typically see them in patients who are KRAS wild type. So if you see a mucinous adenocarcinoma of the lung that is KRAS wild type, it's almost certainly they would have an NRG fusion. NRG is a ligand. It binds to HER3 on the cell surface, activating downstream signaling. And we don't have drugs that attack NRG1 directly. So what we do is we attack it indirectly by using monoclonal antibodies that would bind to HER3, preventing NRG1 from binding to HER3. One of this is sirbantumab, which is a monoclonal antibody, as I said, that targets HER3. This is the preclinical data shown here. We've took this to the clinic, and last year we presented the very initial data, and actually I presented an update to that at ACR. But the bottom line is we're seeing response of objective response rate of around 40%. The drug is generally well tolerated with some diarrhea and rash. It's given IV every week. So there are a number of drugs now in development for NRG fusions. So with that, I would like to conclude by leaving you with the table that has the targets of lung cancer. Again, you could see that it's an exciting time to be a lung cancer oncologist. We keep adding more drugs, and we keep differentiating between all these alterations to the maximum we can do. Thank you for listening, and I look forward to the discussion.
Thank you. Thank you very much, Dr. Yasser. That was excellent review, and keep up for interesting discussion. So I would like first to congratulate Dr. Amal and the whole organizing team for excellent meeting and gathering all this international and distinguished speaker, international and national as well. And it's my pleasure to introduce our next speaker. Our next speaker, Dr. Anish Thomas. Dr. Anish Thomas is a senior investigator and clinical research scholar in development therapeutic branch of national cancer. He is very well known in lung cancer field, and in the meantime, he awarded NCI and he was recognized his work as a clinical investigator. Dr. Anish Thomas, he will give us a talk about target therapy for non-small cell lung cancer. I believe Prof. Amin, he covered almost 90%, and we are looking forward for Dr. Anish talk as well. Thank you. Dr. Anish, the floor is yours. He will join us virtually.
Hello, everyone.
Yes, we can hear you.
My name is Anish Thomas. I'm a senior investigator at the Center for Cancer Research at the National Cancer Institute in Bethesda in Maryland. So the topic of my presentation is small cell lung cancer precision oncology. As you probably know, lung cancer is the most common cause of cancer deaths worldwide. This is recent statistics from the United States. You can see that lung cancer causes a lot more deaths than many of the other cancers combined in both male and females. And among lung cancer, the most lethal type of lung cancer is small cell lung cancer, which usually presents with highly metastatic disease in most patients. It tends to be exceptionally responsive to chemotherapy. Unfortunately, these responses are very short-lived. Tumors tend to relapse very quickly. And the current therapies are really not effective at the time of relapse. And most of the patients die usually within a few weeks of relapse. So this is a patient of mine who died within 6 months of his diagnosis. There are very few treatment options for patients with small cell lung cancer. At the time of diagnosis, a combination of platinum, etoposide, and immune checkpoint blockade is approved. And at the time of relapse, 2 drugs that have been approved. One is topotecan, the other one is lurbinectedin. And if you notice, outside of immunotherapy, probably a common theme of the treatments that do work for small cell is that they interfere with DNA damage or affect DNA replication in some form or the other. As I said, the disease has exceedingly poor outcomes. Most patients die within a year of their diagnosis. Unfortunately, the outcome of small cell lung cancer has not really improved for many decades now. So this is data going back to 2001. You can see that the 2-year survival for both men and women have stayed stable at around 12 to 15%. And this is in contrast to non-small cell lung cancer, where there has been steady improvement in 2-year overall survival, both for men and women. and largely attributable to advances in targeted therapy or precision oncology, where non-small cell lung cancer can be classified now into multiple oncogene-driven subsets which are targetable. Many of them are targetable. And there's also a significant improvement in outcomes as a result of immunotherapy. As you can see here, there's a significantly higher proportion of responses to non-small cell lung cancer to immunotherapy compared to small cell lung cancer, despite small cell lung cancer having a higher tumor mutational burden. So the question is, can we divide small cell lung cancer into targetable subsets? Can we make small cell lung cancer more vulnerable to immunotherapy? And can we bring small cell lung cancer to the age of precision oncology? So a major challenge is that the heterogeneity of small cell lung cancer is driven by gene expression patterns rather than mutations. And this is evident here in this paper from 2015, which profiled about 100 small cell lung cancers. You can find that almost all the tumors have inactivation of P53 and RB1, which are tumor suppressors, really limited options available to target them. And in terms of the other mutations, most of these mutations are not targetable currently. Rather, the heterogeneity of small cell lung cancer is driven by changes in gene expression, predominantly in the neuroendocrine genes. So you can see here, there's a broad subgroup, about 2/3 of small cell lung cancer, which are characterized by high expression of neuroendocrine genes. And there's a smaller subgroup that's characterized by reduced or absent expression of neuroendocrine genes. And within these two broad subgroups, there are individual subtypes that are characterized by expression of individual lineage-defining transcription factors. And you can read these transcription factors here: ASCL1, NeuroD1, U2F3, and YAP1. So a lot of the slides and data that I'll present today has to do with the differential responses of available and new agents to these small cell lung cancer transcriptional subtypes, broadly categorized into NE and non-NE. Unfortunately, despite all this new information, small cell lung cancer now is treated with same treatment for all patients, and most patients die within a year of their diagnosis. So what is the issue with small cell lung cancer? Why is it so hard to understand about small cell lung cancer and bring the benefits of precision oncology to small cell lung cancer? So there are probably three main challenges. One is that this is a tumor that metastasizes very widely and very early in the disease course. Number two is the high chemo resistance, as well as immunotherapy resistance. And number three is the heterogeneity and plasticity, or the ability of the cells or the cancer cells to switch between one subtype to another subtype during the course of this treatment. And the challenge is that there's very little that is known about the molecular basis of these features in human small cell lung cancer. And a major barrier is that there's very little available clinical samples for research. As I said, this is a very fast-growing tumor. Most of the patients are diagnosed very quickly using a fine needle aspirate. There's very few surgical resections, very little tumor available for research, so much so that even though this is a highly lethal and common cancer, it is not included in the cancer genome atlas or the large cancer databases. And most of what we know about the biology and the pathogenesis of small cell has come from continuous cell cultures and mouse models. So today I'll discuss across these three themes a unique approach that we've tried over the last 10 years to conquer this last frontier of precision oncology by using a patient-centered approach. So I'll begin by giving a brief vignette of our efforts to target replication stress as a way of overcoming chemo resistance. So very quickly, what is replication stress? It refers to any problems or impediments to this process of DNA replication. And you can see there are many sources of replication stress, some of which are endogenous, some of which are exogenous, like drugs can cause replication stress. And we hypothesize that small cell lung cancer has frequent RB1 and P53 loss, which enables loss of tumor suppressors. This is a cancer that's dividing very quickly, very fast. There's high levels of MYC amplification, and there's very high expression of these lineage transcription factors, which we mentioned earlier. So all of these are known factors that drive replication stress. And small cell also exhibits many consequences of cells and tumors that have high replication stress. And these include high responses to DNA damaging therapy, a high degree of genomic instability, high levels of mutation, as well as aneuploidy. And one approach to target replication stress is to target the cellular mediators of replication stress. And the key mediator or a transducer of replication stress, a protein that allows the cells to deal with replication stress, is called ATR. So we've been working with an ATR inhibitor for several years now in clinical as well as preclinical studies. So this was the first-in-class ATR inhibitor, berzosertib. It's a highly specific inhibitor. We combine that with a topoisomerase inhibitor, topotecan, which interferes with DNA replication, causes replication blocks and cell death in rapidly dividing cells. And the rationale to combine these two agents is, as I mentioned, this is a tumor that has high replication stress to begin with, and we are further exacerbating replication stress by producing a DNA blocker, topotecan, which is also a standard chemotherapeutic for small cell lung cancer. So we combined these two agents. Initially, there were some concerns about safety of targeting ATR, which is an essential protein, but we found that the combination is well tolerated, and we found evidence of pharmacodynamic activity by combining of ATR inhibitor in patient samples. And in a follow-up clinical trial, we tested this combination in a small number of patients with relapsed small cell lung cancer. We saw several patients with durable responses. And then we extended this combination to what we call extrapulmonary small cell cancer. So these are cancers with a small cell histology, but not originating from the lung. So they could be coming from, really any primary site. So you can have prostate small cell or, small cell from really any primary tissue outside of the lung. And again, we found that there was activity for this combination. And more recently, we completed a randomized phase 2 clinical trial comparing berzosertib plus topotecan or topotecan alone, and found that the combination improved overall survival. So this is an example of a patient who had a response to the combination. She had small cell of the breast, so falling within this extrapulmonary small cell umbrella. She had presented having previously progressed on topotecan as well as immune checkpoint blockade. And this is her baseline CT scan. You can see those large tumors in the liver. And she had a nice tumor regression within 6 weeks after treatment, which was maintained for about 8 months or so before she had tumor progression. And this is data showing improvement in overall survival. So group 2 here is combination of topotecan plus ATR inhibitor, and group 1 is just topotecan alone. So you can see that there's a significant improvement in overall survival, about 9 months for the combination versus 5.4 months for the single agent topotecan, although this was not associated with a significant difference in progression-free survival. And we think this absence of progression-free survival, but there is improvement in overall survival, might have to do with the deeper or the higher depth of responses in patients who received the combination. Here you can see that there's more number of patients had tumor responses here, indicated by this waterfall plot with the combination compared to topotecan alone. Additionally, many of these responses were durable, lasting, several of them lasting for more than 6 months, and in a few instances lasting more than a year. And the median duration of response was about 9 months with the combination versus 3 months. So basically, we're finding that small cell lung cancer is a high replication stress tumor, and there's a subset of tumors that respond to this treatment, with some patients having really long duration of responses. So the question is, who are these patients who respond to this treatment, and what can we learn from there? So that's what we've tried to do here, where we obtained pre-treatment tumor transcriptomes of patients who underwent the treatment. So these patients underwent a baseline tumor biopsy, and we performed RNA sequencing of these patients' tumors, and we found that there were 2 important features that distinguished the tumors of responders compared to the tumors of non-responders. And the main characteristic was, one, that these tumors exhibited increased expression of a number of DNA repair and replication-related pathways, suggesting that these tumors are intrinsically under high replication stress. And these include, pathways such as E2F targets and G2M checkpoint and so forth. A second key feature of these tumors that responded was that they had high neuroendocrine differentiation. As I mentioned, neuroendocrine differentiation, or the spectrum of neuroendocrine differentiation, is a major factor that drives heterogeneity of small cell lung cancer. So when we classify these tumors into neuroendocrine or non-neuroendocrine, based on a gene expression signature, we found that about half of the tumors that were neuroendocrine or classified as neuroendocrine, they had responses, versus none of the tumors with non-neuroendocrine features responded to this treatment. So this is a very small number of patients, but maybe further supporting of this observation, we found that patients with neuroendocrine tumors had significantly longer duration of response, as well as significantly longer progression-free survival compared to non-neuroendocrine tumors. So together we are finding that neuroendocrine gene expression, it defines a subset of small cell lung cancer that is under high replication stress, and that these tumors, if you can select them, could be more susceptible to treatments such as ATR inhibition and topoisomerase inhibition. Now, one of the few issues with these conventional chemotherapies such as topotecan is the high degree of toxicities, particularly myelosuppression. So one approach to overcome this toxicity is to use targeted drug delivery or targeted delivery of chemotherapies, including topoisomerase inhibitors. And and one approach to do targeted delivery is use of antibody drug conjugates. So here we've combined, instead of berzosertib with topotecan, we're combining with sacituzumab govitecan, which is an approved antibody drug conjugate for several indications, which targets a protein called TROP2, expressed in several epithelial cancers. And we find that when we combine with an ADC plus berzosertib, we're finding that there's much fewer toxicities compared to topotecan plus berzosertib, suggesting that this may be one viable approach to reduce the incidence of toxicities from chemotherapies, and we do see tumor responses. So TROP2 is just one example of a cell surface protein that can be targeted, but there are other approaches as well, which are really coming in and showing efficacy in early clinical trials. So to summarize the first part of my talk, we're finding that small cell lung cancer is a single disease. Everybody gets the same treatments, and most patients die within a year of their diagnosis. And here we are finding, using a patient-centered approach, using a very small cohort of patients who enrolled in a clinical trial, we are finding that SCLC is not one disease, rather at least two broad subgroups. And there's one, this particular subgroup is characterized by high neuroendocrine gene expression, and they might respond to replication stress-targeted therapies such as ATR inhibitors and topoisomerase inhibitors. And there are a number of newer approaches coming to target these tumors with high neuroendocrine gene expression. Probably the most promising so far is a target called DLL3. And this is particularly expressed in tumors with high neuroendocrine gene expression. And there have been several approaches that have been tried to target DLL3, including antibody drug conjugates in the past. But probably the most promising in the recent past is this drug called tarlatamab, and there are a number of others of a similar mechanism of action. So tarlatamab is an anti-DLL3 bispecific engager, T-cell engager, which really brings together the T-cell, which expresses CD3, and the DLL3 expressing high neuroendocrine SCLC, which results in tumor lysis and SCLC death. So I refer you to this paper, which is recently published in NEJM, which enrolled about 100 patients and treated them with tarlatamab at a couple of different dose levels. There were responses seen in about 55% of the patients, with several of these responses being very durable, lasting for more than 60%, in more than 60% of the patients. So what about these patients with low neuroendocrine or reduced neuroendocrine expression? So again, using a very similar approach, starting from the patient, we enroll patients on this clinical trial of PD-L1 inhibitor plus PARP inhibitor, which really has no efficacy to date in small cell lung cancer patients. Using a very similar approach, we find that patients who respond to PD-L1 inhibitor in this instance, their tumors were de-enriched for pathways that are related to neuronal system. So if you remember, this is in contrast to the earlier observation where tumors with high enrichment of neuroendocrine pathways, they respond to DNA repair-related therapies. Here we are finding that in tumors that respond to immunotherapies, they are de-enriched for neuronal mechanisms. So we've done some additional work to characterize this, and basically we're finding that Notch activation, which leads to a switch between neuroendocrine to non-neuroendocrine state, also result in increase in intrinsic tumor immunity, as evidenced here by beta-2 microglobulin and HLA gene expression. So to summarize again, we're finding that high neuroendocrine tumors that respond to DNA replication stress-related therapies, and low neuroendocrine or reduced neuroendocrine expression, these tumors, they respond to immunotherapies. Now, in an ideal setting of precision oncology, if you select patients based on these characteristics of their tumors, all patients would respond. That would be great, but unfortunately, that's not true, particularly for small cell lung cancer. And a major cause of treatment failure in small cell lung cancer, even if you were to select patients based on these observations, is intratumoral heterogeneity. So I won't go into too much in detail, but I would say that the small cell neuroendocrine tumors, they originate from a neuroendocrine cell of origin. And then with time and treatment, as shown here in a mouse model, they evolve into a non-neuroendocrine state. And earlier studies have shown that there is a huge transcriptional activation or a burst of MYC is required for the cells to differentiate from a neuroendocrine to a non-neuroendocrine state. So we recently found that this MYC activation could be due to extra chromosomal amplification of MYC genes in SCLC. So I'll briefly discuss this, but there could also be other factors which drive the shift in SCLC state or plasticity of SCLC between one cell state and another. One could be tumor extrinsic state, and one could also imagine that there are metastatic site-specific changes or transcriptional changes which can affect the small cell lung cancer subtypes. So the initial observation here, as with the previous observation, starting with the patients, here we're finding that in a cohort of patients with small cell lung cancer, you can find that there's high amplification of MYC genes, and this was also seen in cell lines from the Cancer Cell Line Encyclopedia. Most of these amplifications included MYC-L or MYC or MYC-N, and you can see that these have characteristic focal amplification patterns which are limited to small portions of the genome, compared to regular amplifications. We also found that patients with these high focal amplifications had significantly poor outcomes. So to cut a very long story short, we found that these high focal amplifications were attributable to extra chromosomal DNA, which really results when there is any form of DNA damage and followed by an erroneous or defective repair. And depending on the level of damage or the extent of damage, the extra chromosomal DNA formation can vary. So you can have a simple damage followed by repair resulting in a simple ecDNA, or more catastrophic damage such as chromotripsis, which can result in a very complex ecDNA. And we found that about 20% of SCLC tumors carried one or more ecDNA amplicons or extra chromosomal DNA amplicons. And you can see some of them have very complex structures, while some others have much more simpler structures. And these are structures that are inferred using computational tools based on whole genome sequencing data. And we confirm these in cell lines. Here again, you can see that there's complex amplifications in some cell lines versus more simple amplifications in other cell lines. And again, confirmed by using specific FISH probes for these genes, in this case, MYC-L or MYC. You can see that these signals are coming from outside the chromosome. And a very important sort of property of extra chromosomal DNA to highlight is that they lack centromeres. And because of that, they unequally segregate between cells, and which allows them to accumulate in large numbers in some cells compared to other cells which may not have any ecDNA. And the cells, as you can imagine, with MYC or MYC-L ecDNA could have a huge selection advantage in terms of ability to metastasize or ability to have chemoresistance compared to cells with very few ecDNA. And this is just an example of the intratumoral heterogeneity that is enabled by ecDNA. You can see that this is a cell line which has two different types of ecDNA, both MYC and MYC-L, varying in terms of the complexity of their structures. But you can see here from single cell sequencing data that there are some cell lines which have both MYC and MYC-L ecDNA amplification. There are some cells which have only MYC ecDNA amplification, and some cells which have only MYC-L amplification. So it really provides a huge variability of MYC and MYC-L dosage to these cells, which enables them to have a lot of the properties such as metastasis, chemoresistance, and so forth. So, to summarize the ecDNA part, which is we find that ecDNA is probably a major driver of small cell lung cancer heterogeneity, both intratumoral heterogeneity as well as the subtype switch between the neuroendocrine and non-neuroendocrine cell states. So a big question is, we're talking about two big subtypes and with possible switch between these subtypes, and considering the difficulties in obtaining tumor biopsies and surgical resections from small cell lung cancer patients, is there an approach to non-invasively profile these subtypes? So a number of different approaches have been tried. So, methylation, circulating tumor DNA mutations, and so forth. But the one approach that we've tried recently is the circulating free DNA ChIP-seq, basically targeting a particular mark called H3K4 trimethylation, which is a mark of transcription start sites. Essentially, what we find is that this H3K4 trimethylation marks in the circulating free DNA is able to predict the tumor transcriptomic reads specifically for these SCLC-related genes, including ASCL1 and NeuroD1. So here you can see these two factors that are plotted against each other with a high correlation between ASCL1 reads in the tumor RNA-seq and the plasma circulating free DNA ChIP-seq reads. This is from about 1 or 2 ml of plasma. So this we think is a potentially promising approach to classify small cell non-invasively and to identify what are the dominant lineage-defining transcription factors. And this is a collaboration with Nir Friedman and his group in Israel. So to summarize my talk, we are currently treating small cell lung cancer basically with the same treatments for all patients, and most patients die within a year of their diagnosis. What we are finding, again, using this patient-centered approach, is that small cell lung cancer is obviously not one disease. There's many diseases. There's a particular subgroup that's characterized by high expression of neuroendocrine genes. They're particularly vulnerable to DNA repair targeted drugs, and they're also under high replication stress. There's a subgroup that's non-neuroendocrine or reduced neuroendocrine gene expression, and they're characterized by immune-inflamed characteristics, and they may be more suitable for immunotherapy. And I didn't get to talk about this, but we've also identified a subtype that's characterized by germline mutations. So, for example, BRCA1, BRCA2, and a lot of DNA repair mutations. And these subtypes may be, targeted using PARP inhibitors and so forth. But more importantly, if you identify these patients, you could screen their family members and detect potentially additional cancers and have screening implications. And then I talked briefly about the switch between neuroendocrine and non-neuroendocrine subtypes, and ecDNA being a dominant driver of these subtype switch, as well as factors in the tumor microenvironment which might be affecting this tumor heterogeneity. And then finally, we concluded by talking about one of these approaches to non-invasively detect SCLC subtypes in plasma. So I'll conclude by saying that small cell lung cancer has really been the last frontier for precision oncology. And one approach to potentially reach this goal is a patient-centered approach that I described using a few different examples. So that's really the goal, and that's what really we've been working towards over the last 10 years or so. So I thank people in my lab and my funding support from the NCI. Thank you very much.
Thank you very much, Dr. Thomas. That was excellent talk. And I think obviously it's a small cell lung cancer and the perspective as well. So please stay tuned for the discussion. And we reach to the last, but not least, talk, which is recent advances in liquid biopsy and precision oncology. And it will be presented by Dr. Marianne Gratham. Dr. Marianne, she is head of medical statistics clinical trials. She is a clinical science and head of cytogenetics in Parse Health NHS Trust in London. Dr. Marianne, the floor is yours.
Assalamu alaikum. Thank you very much for this kind invitation to speak to you today. Just to let you know, I'm not head of statistics. That's an incorrect thing in the program. But I'm a clinical scientist, head of the Cancer Genomics Unit at Barts Health NHS Trust in London. So I'm going to talk to you today about liquid biopsy. So what is it? Liquid biopsy is a non-invasive alternative to tissue biopsies. It's a means for looking for molecular tumor biomarkers in liquid samples, and the source of that fluid is different depending on the particular cancer or disease we want to study. For the purposes of this talk, I'll really be focusing on peripheral blood because we're really thinking about non-small cell lung cancer here today. What can we get from our liquid biopsies? There are a number of different biomarkers. There are CTCs, so that's circulating tumor cells, so intact cells. They are very few and far between in the blood, and they can be very hard to purify from the blood. So it tends to be a target used more in the research setting than the clinical setting. And then there is circulating tumor DNA and something called cell-free DNA. So what's the difference? Cell-free DNA refers to all DNA that's outside of a cell in the blood, and that predominantly comes from normal cells, but then the free nucleic acids that are derived from tumor cells are what we refer to as the circulating tumor DNA. So, liquid biopsy is a minimally invasive technique, and it really utilizes, as I've mentioned, this cell-free nucleic acids, which can be both DNA and RNA, and we use them to profile the molecular signature of our tumors. Now, these free nucleic acids originate not only from apoptotic and necrotic cells releasing their contents into the bloodstream, but we also know now that there are physiological processes within the body that causes nucleic acids to be released from cells, and that also sometimes is in the form of exonuclease vesicles. To put it into context, when we're thinking about cell-free DNA, we usually are able to detect between 10 and 40 nanograms per milliliter of plasma. And as I've mentioned, most of this originates from normal tissue. Now, to put that into perspective, when we're dealing with nucleic acid from tissue samples, we're normally able to extract between 2 and 40 nanograms of DNA per microliter. So you can see how much harder this is. And as I've mentioned already, the circulating tumor DNA, RNA, is the nucleic acid from the tumor cells. So, what should we do? Tissue biopsy, liquid biopsy, or both? They both have their advantages and their challenges, and they are or should be considered as complementary techniques for detection of relevant genetic biomarkers. So, as we know, tissue biopsies, they are the gold standard of diagnosing lung cancers. They give us not only the histopathological information, they perform relatively well for testing both DNA and RNA, and they also allow immunohistochemical profiling. So, for example, looking at markers such as PD-L1, and also you can look for ALK and ROS1 protein expression using IHC. But as we know, there are significant challenges with using tissue. It's an invasive procedure. So not all patients necessarily will elect to have an invasive procedure. They may not be able to be fit enough and well enough to have an invasive procedure if their lung cancer patients often present acutely unwell. The tumor itself may not be accessible for biopsy. As I'll talk a bit more in my talk, and as we've heard already today, tumors progress, they develop resistance, so they need to be retested, and then it may not be possible to follow up by serial tissue biopsies. And as we also heard today, a number of times, cancers can be very heterogeneous. And so if you're sampling a specific point of the tissue, you may not be detecting all the relevant molecular lesions within the tumor. Whereas with a liquid biopsy, they're minimally invasive. Blood is easily accessible and repeatable over time, and it's certainly very cost-effective. And also because the nucleic acids in the blood have been shed from perhaps many different parts of the tumor or from metastases, it's better able to capture the tumor heterogeneity and tumor evolution. But it's not without its challenges. It's much harder to collect RNA, circulating tumor RNA from the blood. Yet we know, and we've heard already today, how important it is to look for gene rearrangements as well as molecular mutations. And also we have to think about the sensitivity of our assay and the potential for false negatives. So why should we do it in the case of non-small cell lung cancer? We've already heard very nicely today about the broad range of oncogenic drivers in non-small cell lung cancer. And we can see from this image, the circle on the outside corresponds to Asian populations and the inner circle from Western populations. There are some differences in the tumor profiles, EGFR mutations being far more common in Asian populations. But we know that these driver mutations are targetable, and therefore it's key that we detect them so that we can better stratify our patients and treat them appropriately. And so when we're thinking of an assay that we want to use to look for these particular genetic drivers, we need to ensure that whatever technique we're using, we're able to not only pick up the small nucleotide variations, so your point mutations and your insertions and deletions, we've heard about those already today with EGFR and KRAS, for example. We want to be able to look for copy number changes. So for example, MET amplification. And then we also want an assay that allows us to detect those gene rearrangements, those fusion transcripts, and also variants affecting splice sites. And I'm very grateful that I don't have to talk about the different targeted therapies in lung cancer, because I don't want to have to pronounce all those different names. But I think this timeline highlights very nicely the significant number of targeted therapies that have become available in recent years, and those credible alternatives that our clinical colleagues have now for treating patients. And therefore, it really is essential that we are testing for all of these biomarkers in a timely fashion. So there are a significant number of potential clinical applications for liquid biopsy, both at early stages of disease and advanced stages. And I'm actually going to start at the end of this diagram, at the end of the advanced stages, and kind of work my way backwards to the more early stages. So if we think about the detection of acquired resistance, Dr. El Amin spoke very nicely about the different type of resistance mechanisms that we see in patients with oncogenic drivers. So just to reiterate, for example, patients who have EGFR positive mutations, if they're treated with first or second generation TKIs, eventually they will progress on therapy due to acquired resistance. And as we've heard, those lesions can either be on target within the EGFR gene themselves, or they can be via bypass signaling mechanisms, or in fact transformation to a different histological subtype. So it really is important that we specifically look for those methods of acquired resistance so we can tailor our treatment accordingly. And as we've also heard now, that some patients are being treated either as a second-line treatment with osimertinib, or even more common first-line treatment with osimertinib. And again, it's just worth highlighting that the resistance mechanisms are different depending on at what point these treatments are used. So we need to really be allowing access to an assay that can detect all these different types of resistance mechanisms. And the same is true, as we've heard, in terms of ALK-TKI treatment. There are acquired resistance mechanisms. And it's worth noting that the slight difference between EGFR and ALK is that whilst there is what we call a gatekeeper mutation, the T790M in EGFR, which is most commonly seen as the mechanism of resistance for first and second generation EGFR TKIs, the similar gatekeeper mutation, the L1196M in ALK, doesn't predominate in the same way, and we have a much broader spectrum of resistance mutations, and the response to therapy is dictated by the different type of mutation that is seen. So again, it's really critical that we retest our patients following treatment with TKIs to determine what is the next best step. So moving backwards through the stages, what about biomarker detection at the initial diagnosis of advanced non-small cell lung cancer? Well, this is all about the issue with the tissue. Liquid biopsy offers a credible salvage pathway for lung cancer patients when tissue is inadequate or unavailable. And there may be a number of reasons, as I've mentioned, as why tissue may not be available at the time of diagnosis. We can see here that tissue biopsy may be unfeasible in up to 18% of patients. And we know that there can be quite a significant failure rate in the laboratory from extracting DNA and RNA from tissue, particularly if the samples are very small, they're necrotic, perhaps the processing in the lab has rendered the DNA highly fragmented and untestable. And also we know that, that in some parts of the world, tissue biopsy isn't necessarily always easily achievable, and by the time that tissue is sat in formalin for an extended period of time, the tissue is rendered unusable. And so some reports in the literature state that there's a failure rate of up to 40% with tissue testing. So we really need to be able to look at more accessible, cheaper, faster ways of getting a result. Robert Smith and the group in Florida performed a nice retrospective study looking at 525 newly diagnosed stage 4 patients for oncogenic drivers. And their study showed that the average turnaround time for an NGS result on tissue was approaching 25 days. However, 27% of patients didn't have a credible result at the time of requiring treatment. They also nicely demonstrated that the outcomes of patients who were treated using a targeted therapy following genomic profiling had better survival than those patients who were originally started with either chemotherapy or immunotherapy, or chemotherapy and immunotherapy alone, and did or didn't switch to tyrosine kinase. So it really makes the argument very compelling that genomic profiling is key. And then we see the data here from Dr. Albarelli's study, which was a group from Basel in Switzerland combined with a group in Portugal. And they looked at 94 patients who had concurrent tissue and plasma NGS analysis at diagnosis. And they showed very high concordance between the results from the tissue and the plasma NGS, highlighting that liquid biopsy is a credible alternative to a tissue biopsy when not available. And in their study, 83% of their samples showed concordance. And this data mirrors what we see in our own organisation in the UK currently. There is a prospective assessment trial taking place to look at patients having upfront liquid biopsy alongside tissue biopsy. And of the 51 patients tested in our organisation to date, we have an 88% concordance between the tissue biopsy and the ctDNA, and in 6 patients there was additional information on molecular biomarkers gathered from the liquid biopsy that was actionable, that wasn't detected in the tumour biopsy. So then if we move backwards in the pathway, what else can we use liquid biopsy for? There's the concept of molecular residual disease monitoring. So this study from Chowdhury et al. And the Sanford group was back from 2017, and this was a real pioneering study where they looked at ctDNA analysis post-treatment in patients with localized blood cancer. So the patients in the study had a liquid biopsy taken at the time of diagnosis, and using very high sensitive sequencing, they developed a patient-specific mutational profile that they were then able to monitor following radiotherapy, surgery, or chemotherapy. So they determined that the landmark, the initial marker for MRD, would start 4 months post-therapy, where a sample was taken again, and then their patients had serial surveillance via liquid biopsy following that landmark test. And what was really significant from this study was the patients who had no detectable ctDNA following treatment had a far superior outcome to those patients that had ctDNA detected at that 4-month landmark assay, and then following their surveillance. So the black line at the top are those patients where following therapy there was no ctDNA detected, and then you can see the significant decline in outcomes on the red lines for the first 2 Kaplan-Meier graphs for those patients where ctDNA was detectable. And then the last Kaplan-Meier graph on the end shows following detection of imaging, and that the ctDNA was detectable in advance of radiological imaging. So patients were, it could be seen that patients were relapsing or progressing much sooner than by imaging alone, which does allow for the possibility of early intervention. So how do we test for it? It's really, it's a bit of a dry topic, the pre-analytical considerations for plasma testing, but it is important to know that whenever one is wanting to take a sample to a laboratory, that the correct collection tubes are used, so you can use either EDTA or a tube with a preservative in. It's important that transportation takes place at room temperature, and the reason for this is that the nucleic acid in the blood breaks down and fragments over time because it's no longer protected by the cell, and the longer the nucleic acid is out of the body and not protected, it breaks down, and it decreases the chance of getting a meaningful result. There are a number of specific commercial kits available now, so you can purify your nucleic acid. So it's important that laboratories consider that they use a kit, an extraction platform that is developed specifically from circulating tumor DNA, so we can maximize that small amount of DNA that's present. And we have to be mindful of the storage of the sample. So the DNA should be frozen prior to extraction if it's not going to be extracted straight away. But it's important to avoid those freeze-thaw cycles so we're not fragmenting our DNA. And when we're centrifuging our samples, we need to make sure that we're not over-centrifuging them, so we're not smashing up that DNA and rendering it damaged. So also thinking about the sensitivity of the assay, as I've already mentioned, the amount of nucleic acid we can extract from these samples is very, very small. So with a 10 milliliter blood sample, you're likely to only get 20 nanograms of circulating tumor DNA, of which, if your mutation is only a small percentage of that DNA, you really are going to be looking at a limited number of copies of that mutation. So we need to make sure that our assays are sensitive. And the other point to kind of mention is the concept of CHIP, clonal hematopoiesis of indeterminate potential. So this is the acquisition of clonal molecular lesions in the blood cells of people, particularly often healthy individuals, but as we get older, we acquire molecular mutations, and this can cause confusion when analyzing results. So there have been studies that look at paired testing of whole blood samples versus the circulating tumor DNA so that you can exclude the possibility of confusing a mutation caused by CHIP as being responsible for the mutation in the tumor itself. So the main technologies used to assess ctDNA, originally there was a lot of digital and droplet digital PCR, but they specifically work for single gene analysis. And as we've heard very nicely today, that there's a significant number of mutations that we need to look for. So multiplexed NGS is the method of choice. So in summary, the current routine applications, as I've mentioned, are the detection of acquired resistance mutation following treatment with TKIs, biomarker detection for targeted therapies when tissue is not available, and potentially MRD for adjuvant treatment stratification. And there's a lot of clinical trials and research in the setting looking at neoadjuvant immunotherapy settings, MRD and relapse monitoring, and early endpoints in clinical trials. Thank you very much for your attention.
Thank you, Dr. Marlene. I think we'll start the discussion part. We will have about 20 minutes. So my pleasure to invite all the speakers to the stage so we can have some questions. So we'll start with the floor, if we have questions from the floor. If not, we can start our moderators. Dr. Hamid.
So thank you for the speaker for the excellent, talks and update about target therapy and precision oncology in lung cancer. So the first question, my question to Dr. Mehmet, I mean, what do you think about if patient receiving a single agent immunotherapy and develop like localized progression at one lesion? If you give radiation therapy, do you think this will give a better outcome or switching the therapy? I mean, now there is area about radiation and immunotherapy, so.
I think this is a very hot topic, and we do have data suggest, especially if there is oligometastatic or a single site progression, if we use radiation, we can continue to drive benefit from the immunotherapy. I think one thing to remember is, as much as we get more ambitious about local consolidation with radiation, especially radiation like mediastinal radiation can cause significant lymphodepletion, and those patients may not benefit from the immunotherapy as much. So in selected patients, certainly using either radiation or addition of chemotherapy to try to consolidate is something we routinely do, and there are not much higher evidence on that, but single arm studies suggest that those patients can derive benefit from immunotherapy with that additional modality, especially if there is a single site progression. This can be radiation, it can be surgery, or again, addition of another cytotoxic treatment.
So how do you think about the re-challenge for the patients who progress on IO therapy?
So I think the question is a little bit heterogeneous answer, because we know that especially if there is a primary resistant where after the initial induction we don't get much responses, majority of the clinical studies do not suggest we are going to get too much benefit from using at least what is available to us right now. But particularly in acquired resistant, in additional immune checkpoint inhibitor therapy or combination strategies may overcome that resistance, so it can be used. But particularly for primary resistant, there are not really high level of evidence continuation or addition of immunotherapy to the next line generates much benefit.
Yeah, I guess the lung map, which is launched last year by the Memorial Group, and they were considering it for the patient as a re-challenge. But again, it's a phase 2 study. It was only PFS benefits, and there was no overall survival. And I think they are going for the phase 3 for now. But again, after a period, because we started the immune therapy since 2015, so we start to see patients who progress on treatment even after longer period. So and some of the, and Dr. Yasser as well, he can give us his opinion. So we may consider re-challenge or second line chemotherapy, because we don't have a sequence for these patients.
Yeah, so go ahead. So majority of the time, again, depending on the situation, I think these should be case to case, should be considered. Especially now, we also have some challenges about the duration of treatment, and we do have stops. And at the time of progression, certainly re-challenge or re-challenge with a combination, or in the subsequent lines of treatment, we utilize. And in a selected patient population, we do see benefit. But I guess the difficulty right now, which is, again, the key topic about precision medicine, we don't have ideal biomarkers to identify which patient subsets will benefit from those approaches. But I think those should be considered for many.
Thank you, Dr. If I may add to what Dr. Alton said, I agree totally for patients who have primary progression, patients who have biomarkers that are associated with poor outcomes to immunotherapy, so patients with mutations in LKB1, patients with mutations in KEAP1, patients with PD-L1 0, patients with low TMB. I think it's very hard to justify why you want to re-challenge. But for those who achieved a prolonged benefit, I do think it's very reasonable to re-challenge. I think most of us in clinical practice tend to re-challenge these patients. As you said in the lung map, one of the studies, they did pembrolizumab with ramucirumab, which is very reasonable combination to use when re-challenging. I certainly do it a lot.
Marianne, sorry, Dr. Turki, but I just don't want to leave this point. So do you think that we need to go for testing again the PD-L1 for this patient, especially for a patient who high expressor, and we found that this patient, they are progressing? And especially also in your presentation, you put that IHC can be for PD-L1, which is a little bit peculiar, because we got to know that the PD-L1 mostly tissue, and we have multiple assays.
As in, do I think that you should retest? Yeah, we know that tumours change, so I think if the material is there and it's possible, we should check again to see what molecular biomarkers are there. If you have the time and the patient has the time to be able to be retested, because you may find another molecular marker, or you may have acquired a resistance, as you've mentioned, KEAP mutations, stick STK11 mutations, for example, resistance. So the more we know about what's happening inside the tumour, the more we can be confident what's going to happen with the therapy.
And you, in your practice, you find that because we know that the PD-L1 is not changing comparable to the driver mutation or the patient with other mutations that, for example, like ALK, we know that those patients, they have a specific type of mutation and then the patient develop resistance. So for the PD-L1, do you have an experience that the patient did change the states? Because on our practice, and you can correct me, Dr. Hamid, we only tested for once for the patients to know the expression. So you guys in your centers as well, you are doing, or you retest again?
We do retest. If they've had another sample, they will go through the same retesting pathway, unless if the tissue is particularly limited and we're only going to get enough for, let's say.
And you found it change?
I haven't got any experience of it changing, no.
Yeah, because I think this is concurrent with other data. This is unchanged, and you can add as well if you guys do it.
So I think the 2 point is the tumor heterogeneity has been a big issue. So even if the same time point you biopsy different sites of even the same site of biopsy, you may get different PD-L1 reads. I guess more important question is, with that data, are you going to be able to do something about it? So we do see sometimes with high PD-L1, some other immune checkpoints more critically noted for exhaustion, like LEC or TIGIT. If there are clinical trials, sometimes that can guide us, but in regular practice, that change in the PD-L1 level for a PD-L1 exposed patients does not necessarily bring any treatment option. That's why I think NGS is much more helpful, because if it has not been picked up or if it's a driver-resistant mutation, sometimes that genomic profiling can provide some treatment options, which is very valuable at that point of time.
But for squamous, we didn't have anything regarding those patients, even if we're doing for them NGS. So this is for the patient with a driver mutation. I agree with you totally, and even for the adeno. But for a squamous, even when we're doing NGS, we didn't have any driver mutation for, we don't have a druggable mutation for them. So we are stuck on the same that those patients for chemo and immunotherapy.
No, I want to agree on this with Dr. Mervat. I think for squamous cell, I personally very rarely do a second. I was saying I agree with Dr. Mervat on that. For a patient on squamous cell, I very rarely request a biopsy on progression, because as you said, what are you going to do about it? And that's what Mehmet is also saying. I do want to agree with Mehmet a lot that PD-L1 is not a perfect marker. There is very nice data from Casey Arber from Memorial and also from Jay Zhang and Anderson showing that within the same patient, if you take a liver biopsy and a lung biopsy, there's going to be a heterogeneity in PD-L1. So what do you do with this data? We also know that same mutation in beta-2 microglobulin after treatment with immunotherapy changes the expression of PD-L1. So it's a dynamic marker. I don't think it's critical that we need to biopsy to look for PD-L1, but I do think for adenocarcinoma in particularly, it's important and relevant to biopsy for NGS purposes.
I think this is going to be moving forward more and more important and relevant, because targeting TROP or some additional immune checkpoints or identification of resistant will be important moving forward. But I think we are not at that point yet, so it does not really influence our treatment decisions unless we have clinical trial options for those patients.
Great. Let me ask Dr. Thomas with us online. For the group of the gene expression, neuroendocrine gene expression, do we have any clinical characteristics for patients where we can identify them early for this future therapy?
That's a great question. So, the first step is to identify that there is heterogeneity, and I think there's several studies that now show that the treatment responses can vary depending on the transcriptional profile. I think the second step is, as you suggest, is to identify those patients. So you can try a number of different approaches. So one, as we have done, you can do RNA-seq, which is obviously not, translatable at scale for many patients. You can look at immunohistochemistry of these lineage-defining transcription factors, ASCL1, NeuroD1, and PUT2F3. And then YAP1 expression is somewhat debatable, but in most of the studies, there's very little YAP1 expression by immunohistochemistry on tumor cells, at least. So those are kind of tumor-informed approaches, and then you can think of approaches to stratify these subtypes based on circulating tumor DNA. And there's very nice work showing that methylation is able to robustly classify small cell into subtypes from circulating tumor DNA, so ctDNA methylation. And even within methylation, there's different approaches that have been tried with varying sensitivities and so forth. We have used another approach, which is basically ChIP-seq of circulating tumor DNA for transcription start site marks. And these are relatively new techniques. And I think as these techniques evolve, eventually there might be a situation where we can identify these subtypes, using tumor primarily, and perhaps if there is difficulty in getting tumor, using circulating tumor DNA, or a combination of these approaches.
Thank you. So, thank you, Anish. So I do have a question regarding neuroendocrine tumor with uptake in the gallium ductate. Because again, as you presented, the neuroendocrine tumor, we are talking about the poorly differentiated, you are treating them like small cell. However, we do have a group of patients, they have uptake in the gallium ductate, and this means that may be responding to sandostatin inhibitor receptors. So how you treat this patient, especially that it's little bit heterogeneity in well differentiated and definitely in poorly differentiated?
So again, it points to the heterogeneity, even within same tumors, there are potentially areas which are less differentiated and poorly differentiated. And there is a subtype mostly driven by NeuroD1 that tends to have, increased uptake of these markers. So I know there are a few trials that have looked at prospectively identifying these patients and then treating them with these radioligands. But I think that field needs to evolve a little bit more, and I don't think we know quite as much about the heterogeneity, to make those, sort of clinically actionable. But for individual patients, I think it makes sense based on histology to suspect, a less well-differentiated state, less, maybe the glandular structures are more retained on the histology. Perhaps it makes sense to do these additional set of scans and see if the patient might be candidate for those sort of interventions.
Great. Dr. Hamid, you have a question?
So my question to Dr. Yasser, I mean, in your clinical practice, are you using more osimertinib or osimertinib plus chemotherapy? By giving combination more higher toxicity and maybe only progression-free survival until now. So,
yeah, that's a good question. And I will add also that in your practice, who are the group you will add chemo to the osimertinib?
No, that's a very excellent question. Thank you for it. And I wish I have a good answer for it. The reality is the FLAURA2 data is positive. It adds around 6 months or 7 months of PFS. We don't know if it's going to have an overall survival benefit. So as I said, it's a big commitment. Now you're removing your patients from being on an oral drug, having a very good quality of life, and now you're asking them to come to your clinic every 3 weeks to get an IV chemotherapy. And worst part is that not only they finish the 6 cycles, they also go on maintenance methotrexate for 2 years. So when the data matures, if there is no overall survival benefit, I think there are going to be less enthusiasm for adding chemotherapy. For now, what I have started doing since the FLAURA2 trial is certainly for my patients with CNS disease, because the hazard ratio there is very convincing. I have been adding chemotherapy routinely. But for other patients who do not have CNS metastasis, I'm still leaning more towards doing osimertinib. But I tell the patients about the study, I show them the figure. Mostly they would lean towards just having osimertinib in the absence of CNS disease.
I do. So as we are speaking about the FLORA-2 and the FLORA as well, so I will just touch asking about the MARIPOSA-2, because in patients who progressed on osimertinib, we stratified them to small cell MET amplification, or so in the MARIPOSA-2 they take the whole, and we didn't stratify. So who is the patient supposed to be candidate for MARIPOSA-2?
So again, this is a very good question. I do think that the biomarkers for amivantamab remains a mystery. We've looked at MET immunohistochemistry, MET amplification. I don't think it perfectly predicts the response to amivantamab. For now, it's still not fully approved by the FDA, but we have been able to use it off-label. So now if I see a patient in clinic today who progressed on osimertinib, I do a biopsy. If they did not transform to small cell, then I would routinely offer them amivantamab and carbopem.
Excellent. Question to Dr. Altan. I came across a small paper of adding anti-angiogenic therapy, ramucirumab plus pembrolizumab after failure of chemoimmuno. And there are many other smaller trials, negative trials of targeted anti-angiogenic therapy, oral therapy. Do you think this would be the way down the road to, when patient progress on chemoimmuno, keep immuno, add, for example, ramucirumab?
So that is S1800 study that initially looked beautiful, and I think in some patient subset, again, it may be beneficial, because as I try to allude in the representation, VEGF is important for T-cell trafficking. So if it is a driver mutation such as EGFR, where VEGF might be important, or some other actionable mutation, or if there is a problem with trafficking, probably there are some patient subsets who are going to benefit from this approach. But in all comers, I think the benefit is going to be quite dismal. So I think until there is more convincing evidence, it is going to be remaining questionable, especially with some complication risks that can come in older age population with anti-VEGF.
I do have a question to Dr. Yasser, that you presented fantastic the EGFR, and we know that we do have exon 19, and also we do have L858, and also now exon 20. So clear about what to treat this patient. The uncommon mutation, we don't know exactly, and you presented that afatinib is the one who was approved, but the response rate is about 11%, and most of the patients, they have a toxicity. And the other issue that it's a small population, we do have another data by the osimertinib for the uncommon mutation as well. So we start by using the NGS as a routine for the patient to see this patient, but we know this is either osimertinib or afatinib is not enough for them. So how you stratify, and this patient, you may go for chemotherapy, because we know that target therapy, we know that this is not enough. For example, Pozatinib was used as well, and even for the exon 20, before it was using osimertinib, was dismal and even with higher dose. So far, we don't think that the data we have, it's enough to give the patient this treatment. So what do you think?
Yeah, so I think if we're talking about exon 20 insertion, I agree 100% that afatinib and osimertinib have very limited efficacy, and I don't think that they should be used at all. I think we should use chemotherapy with or without amivantamab, and I think the data with the Papillon trial is very convincing. Now we all routinely use amivantamab and chemotherapy for EGFR exon 20 insertions. For the other point mutations, so non-exon 20, like say S768I and G719A and 861Q, for these ones, I think it's very reasonable to use afatinib because it's approved by the FDA, although the data is very limited, but the response rate within the very small patient population was around 70%. So I think it's reasonable to use afatinib. I also think there is nothing wrong with using osimertinib in this setting as well. A lot of my colleagues would prefer osimertinib because of the toxicity and because of the CNS efficacy, which is superior to afatinib. It's not approved in America by the FDA, but they use it off-label for this particular small subset of patients. So I think it's perfectly fine to use either afatinib or osimertinib. We have now multiple drugs that are in clinical development that are focused on these two rare mutations. Of course, there is the reason I prefer afatinib is not only because of the FDA approval, but because there is this paper by
Tony Moore.
Also, there is more recent paper from Robichaud and Hemak. It's a Nature paper, and it's just looking at these mutations structurally, and they see that these mutations, they call them the PAC mutations, structurally are more responsive to afatinib, to second generation EGFR inhibitors. So I do think that it's a soft data, but ultimately these are the approvals. I think it's perfectly fine, as I said, to use afatinib or osimertinib for these mutations.
I think we can take the last question. Last question to Dr. Yasser. We know those people with the ROS1 and also the ALK, specifically ALK rearrangements, they live very long. And when you talk to them about biopsy, rebiopsy, not only the ALK, all the alterations, they become very reluctant to get the biopsy. Always the biopsy is bad experience to the patient, so liquid biopsy is easier. But if we decide about the tissue biopsy, there are those data to say that, okay, just rotate the ALK inhibitors. No need to take biopsy now. Rotate. If a patient especially is not interested in biopsy or liquid biopsy, so you may go back to the crizotinib, for example, if you reach lorlatinib. Do you think this is a correct practice?
You know, I think in an ideal world, you want to do a biopsy to exclude especially things like small cell transformation. And I think typically when you explain to the patient that this may really change the way we're going to treat you, they may be more responsive. But sometimes it's a dangerous biopsy, sometimes there is no accessible disease. Here where comes the importance of ctDNA. So ctDNA can help us a lot here. I think we all like to think that we biopsy a lot of patients, but in reality, we're probably biopsying only 50%. I think in the absence of clear resistant mechanism identified by ctDNA or by a biopsy, I think it's reasonable to rotate ALK inhibitors or even to add chemotherapy to ALK inhibitors. But in an ideal world, I would strongly advocate for a biopsy.
You know, also it's related with the practicality. So, like, if someone is progressing on a second-line ALK-targeted therapy, you may think that at least for certain mutations, point mutations, a third-generation lorlatinib can overcome. Still, you advise patients to get biopsy to understand resistant mechanisms, but by the time you get the NGS result, it's almost a month in the best case, because 2 to 3 weeks and arranging the biopsy. So in those settings, really looking at the pace of the disease, probably either changing the drug or to continue the current treatment until the biopsy results needs to be done case-to-case basis. Some patients do not have the luxury to wait for 4 weeks. So that's why while we encourage patients get those biopsies, it's not always immediately available for us to make a treatment decision.
So for the ALK patient you presented, we do have the lorlatinib and bergatinib and alectinib. And so definitely lorlatinib, the CROWN study, we do have the highest hazard ratio, but it's always the aching point that if I use the third generation, I maybe if the patient progress, which is happening, what I supposed to do, especially we know that the fourth generation is coming, but so far in your practice, if you do have the 3 on your shelf, which one you will pick for the patient and based on what?
Very difficult question to answer. So in reality is I used to use a lot of alectinib and brigatinib, but the more I look at the CROWN data, the more I feel like lorlatinib is superior. We don't have head-to-head comparison. I don't think we're ever going to find head-to-head comparison. I used to think that lorlatinib is very toxic, and I do think it's toxic in the second-line setting. But in the front-line setting, I'm starting to grow into becoming a lorlatinib fan.
I used it. It's not toxic. The only aching part is the edema.
The edema, and I've got a lot of kind of neurocognitive issues, a lot of depression.
In our patients, I do have it for 2 patients. I didn't face the cognitive effect Actually, definitely the alectinib is a very smooth medication. We do have also a couple of patients started on bergatinib as well. But the lorlatinib, actually, the patient after the second evaluation, I do have patient with lung lesion and metastatic to the liver with a huge absolute complete remission, which is a durable response. But in the meantime, of course, the edema is annoying.
Let's take the last comment from.
No, I mean, lorlatinib is not easier medication. I mean, I'm using, many patients I'm using lorlatinib, I'm facing the CNS effect, I'm facing the high cholesterol, the triglyceride, and edema. So it's not easier as alectinib. So
I think
still there is more toxic.
Yeah, one of the bad things that I faced is the mood changes, swinging in the mood, especially in patients who had prior radiation therapy to the brain. So, yeah, we have to put this in consideration. Weight gain, no, but mainly the mood changes. So I think with this we need to conclude our excellent session. I would like to thank all of you great speakers and welcome you to our country and wish you to come again, inshallah, in another time, and also for Dr. Thompson to have the time to come physically to see you, inshallah. So thank you so much, and we will conclude, and I need to remind all the attendees that the next session tomorrow will start 8 o'clock, inshallah. Thank you so much, and have a good night.
Thank you.